Good morning and a very warm welcome to all of you. I am Dr. Sudarshan Iyer, Secretary Nashik IMA. Welcome all of you for this first online conference, Mahahospicon 2020. IMA Maharashtra State and HBI Maharashtra State Chapter, Mahahospicon 2020, hosted by IMA Nashik. I welcome our chief guest to the inauguration ceremony, Dr. Ravi Wankhedkar Sir, Treasurer World Medical Association, President SARC Medical Association, and past National President of IMA. I welcome our guest of honor, Dr. Vinay Agrawal Sir, past National President of IMA, Dr. V.K. Monga Sir, Chairman IMA HBI Headquarters, Dr. Jayesh Lele Sir, National Secretary IMA HBI Headquarters, Dr. Rahul Iyer Sir, MLA and past President IMA Nashik. He was supposed to be here, but because of some emergency, he had some meeting in Mumbai, so he had left early in the morning. Now I welcome Dr. Avinash Bondwe Sir, President IMA Maharashtra State, Dr. Pankaj Bandarkar Sir, Secretary IMA Maharashtra State, Dr. Mangesh Patel Sir, Chairman HBI Maharashtra, Dr. Saurabh Sanjanwala, Secretary HBI Maharashtra State. Now I request all our dignitaries to light the lamp.
I think it is all set and the ball is started rolling by none other than our leader Dr. Wankhedkar sir. Dr. Rajan Sancheti will be the host for the next session, and he is a very known face in IMA Maharashtra. He doesn't require any introduction. He has been PTO and right now he is an RMO at Bharati Vidyapith Hospital. I now request Dr. Rajan Sancheti sir to please take over and carry forward the session. Thank you. Thank you.
Honorable past National President and the Treasurer of World Medical Association, Dr. Ravi Wankhedkar, State President of Maharashtra, respected Dr. Avinash Bondwe, National HBI Chairman, Dr. V.K. Monga, National HBI Secretary, Dr. Jayesh Lele, IMA Maharashtra State Secretary, Dr. Bandarkar Sir, IMA Nashik President, Dr. Samir, my all brothers and sisters from IMA Maharashtra State. I welcome you all for this Mahahospicon, a state conference of IMA Hospital Board of India, Maharashtra State. Before there are technical glitches which we sort out, let us go ahead as suggested by respected Wankhedkar sir. Friends, we all are aware, last 6.5 months, all of us have gone through this bad phase of pandemic and we still continue to go through. In last 6.5 months, all IMA members, doctors, through their own hospitals, they have catered the healthcare all across the state of Maharashtra under the able leadership of our state president, Dr. Avinash Bondwe sir. Not only delivering the healthcare, Indian Medical Association, Maharashtra State and Hospital Board of India has time and again intervened and interfered whenever there have been problems from the side of the government or whenever there have been issues from the public. Lot many hospitals where they have faced the violence during the last 6.5 months of pandemic. In spite of central government coming out with the amendment for the Medicare Act, violence episodes were noted all across the state and outside the state also. But IMA Maharashtra State has vehemently opposed so. And whenever any such episode has happened, within 24 hours, we always have shot a letter to the state government. And through our good offices, we have seen to it that culprits are always uh, taken care of. So IMA Hospital Board of India, under the aegis of the Indian Medical Association, has been serving great all across the nation and in the state of Maharashtra as well. Started around 9 years back, Indian Medical Association Hospital Board of India has marched and reached to this level today. HBI is catering all the problems and issues of the hospitals which we are coming across day-to-day practice. It may be registration issue, it may be issue regarding the fire NOC, it may be regarding the biomedical waste. Everywhere, Hospital Board of India, we have given the upfront, we have tried to help the hospitals. I think I will request our state president, Dr. Bondwe sir, to start this meeting further. Dr. Bondwe sir.
Thank you, Dr. Mangesh. The treasurer of World Medical Association, past national president, our friend and philosopher and guide, Dr. Ravi Kedkar. Welcome to this Hospicon, Mahahospicon 2020. Sir, this is, everybody knows that this is the result of all the seeds you have sown years before and groomed into a big unit of IMA. The condition in which the Maharashtra State IMA HBI board is all a result of your constant support, and we are proud to say that it is one of the best HBI, state HBI all over India, and it's really we are very much thankful for your support all the time. The national chairman of IMA HBI, Dr. V.K. Monga sir, and national secretary, Dr. Jayesh Lele sir, we welcome you to this Hospicon 2020. With your able guidance throughout this year, IMA Maharashtra State HBI has always been got good inspiration and support every time. I especially congratulate the state office bearers of IMA Maharashtra State HBI, Chairman Dr. Mangesh Pate, the Secretary Dr. Saurabh Sanjanwala, and all the team of HBI. You have worked exceptionally throughout this year, right from the beginning. Even in the early days of this pandemic and lockdown, you are not only inspired to do the positive work to support the common people. The HBI, with the help of HBI and guidance, all over Maharashtra, we could have fever clinics and these community health clinics and many other activities like the mobile ambulances and all other things were carried out. Not only after that, whenever the government needed the support of the private hospitals and doctors, IMA HBI has come forward and supported with their force of all these doctors, as well as many of our hospitals where rather we accepted as COVID hospitals duties. And all these things, along with this, we have fought, we have struggled at every point whenever there was a problem, whether it was an administrative problem, whether it was a problem of the respect to the doctors, or it was a problem of violence among at the hospitals. IMA HBI and IMA Maharashtra State, they are not different bodies. We have always taken care of every situation, and I'm proud to say that it is really a wonderful thing that we are working together unanimously and with unity. And I would like to say that with the help of all the work done by this HBI, all these whatever the wrong things are done against all the doctors as well as the hospitals, we are having the further steps, and we are really definitely go ahead with all your support. I would like to congratulate the team Nashik, IMA Nashik, who have hosted this wonderful conference. Everybody must have seen the very good scientific as well as all the discussions and panel discussions. And I congratulate the organizing chairman, Dr. Rajendra Kulkarni and President Dr. Chandratre for their in-session efforts. And I'm really, really happy that this Mahahospicon, which is being taken place at this time of this COVID pandemic, is really a grand success. And just some minutes ago, the organizing chairman, Dr. Rajendra Kulkarni, informed me that there are more than 2,000 registered delegates are here. So it's really, I congratulate the IMA branch, IMA Nashik branch for their in-session efforts for organizing this. You have done a great job, and I'm sure that this unity, your work will definitely lead IMA Maharashtra State, not only the IMA Maharashtra State, this
Hello.
work of IMA to the society, as well as will help all our members of HBI and all the members of IMA Maharashtra State for further things. All my office bearers of IMA Maharashtra State, I really welcome you and thank you, especially Secretary Dr. Pankaj, our Vice President Dr. Dinesh, and all other members who are there. I'm really definitely happy, and I'm sure that the work of HBI is now expanding. As you all know, we have developed our PPS scheme. Will be inaugurating its new insurance schemes along with many insurance schemes. I request you to attend the session at 2 in the afternoon, and that will be really a very, very good thing in the state of Maharashtra, that for the first time in the history of IMA, that Indian Medical Association is going to do some wonderful thing. Please watch for it. So with this, I thank all the organizing committee chairman. I thank the the HBI of IMA Maharashtra State, and wish you all the good luck. Thank you.
Wankhedkar sir, Bonwe sir, Dr. Mangesh Pate, President-elect Dr. Londe sir, immediate past President Dr. Huzi Kapadia, guest of honor Dr. Monga sir and Dr. Vinay Agrawal sir, the President-elect Dr. Suhas Pingre sir, my dear office bearers of Maharashtra State and my colleagues in Nasik, and all the esteemed delegates from all across the country. I'm very happy to announce this inauguration and Mahahospicon 2020. We are fortunate to have the able leader, visionary leader, Dr. Wankhedkar sir as our chief guest. Without spending much time, I just would wish to mention two things. That this is very, very successful conference going to be, because so far we have almost 2,400 registrations online. And because the program, which has been crafted very meticulously by Dr. Mangesh Pate and Dr. Bonwe sir and Dr. Jayesh Lele sir, this response is tremendous. Thanks to all the friends across the Maharashtra. And I now request Dr. Wankhedkar sir to take over, because we have very short time. I will just mention that we had quite a few state and national activities in the past. Of late, in 2010, we had a Mastacon. Then in 2016, there was a Jericon. And in now it is Mahahospicon. We had Maha Sports twice, and the first ever national sports of IMA was also organized by Nashik IMA. And in all these, we have contributed after each conference very significant sum to the Maharashtra state. If all goes well with all your blessings, with the permission of my president, Dr. Samir Chandratre, I assure you that we may contribute to IMA Maharashtra state up to ₹1,00,000. This is just because of the cooperation by all over, from all over the state. And that is why we have been going to all this Mahahospicon 2020. I request now Dr. Monga sir to speak a few words and guide us. Monga sir, please.
Uh, Dear President Avinash, my very close friend Ravi Vankedkar, who is a path breaker, and in all his activities, he has shown the way to IMA. My colleagues, Dr. Lele, Dr. Mangesh Patel, Dr. Pankaj, Dr. Rajan Sanchiti, uh, Dr. Rajinder, and all my friends and colleagues. It's a great honor for me to be here at the inaugural ceremony of IMA Maharashtra HBI hosted by Dr. Nasik branch. Friends, HBI has been told, I mean, you know, people have told you, Dr. Pate told the history of HBI and others also told you the history of HBI. And during the time of Ravi Vankedkar, IMA Hospital Board of India reached very great heights, and then came you know, other people who could take a lead from Dr. Ravi and go ahead with it. The topics for the two-day conference have been selected very meticulously by, I think, Dr. Avinash Lele and Dr. Pate. In COVID times, these are the challenging times, and the whole world is seized of the matter. And India has, in fact, in that way, worked a lot under the present regime at the center and Indian Medical Association also. So, COVID times issues like the small nursing homes, big nursing homes, how to take care of them, all these things have been coming up. It's a new disease, new theories, new practicals, no new research is going on. I think that's a very good thing. We are going to talk about violence. We are going to talk about MLCs. We are going to talk about insurance, digitalization, and on top of it, we are going to talk about accreditation. These are the few issues which are very important in present day times. We cannot ignore even a single topic in these. So I'm very hopeful that after 2 days, by tomorrow evening, we'll all be more intelligent and we will be able to carry this message to all over the country that Hospital Board of India is definitely means business, and they are able to tell all the doctors of the country how to deal with COVID issues and general regular day-to-day issues in our medical practice. So all the best to IMA Nasik, IMA Maharashtra, and with the blessings of Dr. Ravi Vankedkar, I'm sure it will be a great success. Thank you very much. Thank you also. Thank you.
The president of IMA Maharashtra State and my dear friend since college days, Dr. Avinash Bondwe, whom I fondly call uncle, but he is a thorough gentleman, one of the few gentlemen in Indian Medical Association, and our senior guide, friend, philosopher, the chairman of IMA HBI at the national level, the past finance secretary of Indian Medical Association, the past standing committee chairman of the health in the Delhi Municipal Corporation, and a friend indeed, Dr. V.K. Monga sir. On behalf of Maharashtra, first we congratulate you that you and Madam Monga have successfully combated the COVID and you have come out hale and hearty out of it. It is all due to your good deeds which you have done up till now. So we welcome you, sir, in Maharashtra conference, and we hope now that with renewed vigor you will be able to serve the Indian Medical Association very nicely. The chairman of HBI Maharashtra State, my brother, Dr. Mangesh Pate, the national secretary and workaholic, Dr. Jayesh Lele, the secretary of HBI Maharashtra State, Saurabh Sanjanwala, the vice president IMA Maharashtra State, Dinesh Thakre, and who is also the joint secretary of HBI, all the past state presidents who are present for this conference, the president-elect, Dr. Londe, the president-elect for 2022, Dr. Pingle sir, the president of IMA Nasik, my friend Dr. Samir, the secretary Sudarshan, the man behind the success of such a huge, successful conference, the organizing chairman, our dear friend Raja Bahu, and I really need to thank and congratulate IMA Nasik for such a wonderful attendance of registrations, more than 2,400, and at this current moment I am seeing more than 650 people are in attendance on a Saturday morning. In spite of starting late, such a huge number is really very heartening. But this also shows that people are interested in solving their day-to-day problems of the hospital. And for the same reason, Hospital Board of India was constituted, and the entire credit of formation of Hospital Board of India, though the concept was floated by Dr. Adhav sir when he was the national president, but it came into existence only and only because of our Mahaguru, the past national president, Dr. Vinay Agrawal sir. When he was the national president in 2010, first time Hospital Board of India was created as a separate wing to deal with the problems of hospitals, especially the small and the medium-sized doctor-owned hospitals. And since the able guidance of Dr. Vinay Agrawal sir, the hospital board is now becoming one of the major wings, surpassing, I should not say this, but the other wings of IMA, because HBI, friends, is more and more relevant. I have been associated with HBI since its inception. Initially, I was the director, then was the national secretary, before becoming the national president. And just on the lighter side, all those who have worked in HBI have always risen ahead into IMA. I became the national president, the national secretary before me, and the chairman, Dr. Ashokan sir, became the HHG later on. So HBI is a good launching platform. So it will be heartening for all my HBI office bearers that, and I am very sure in the coming years also, HBI is a breeding ground to create better and better leaders. Once again, I congratulate, and I hope the two-day deliberations, something concrete should come out of it. I request IMA Nasik and the IMA HBI Maharashtra to come out with white papers on each and every topic which has been discussed. Practical white paper which can be circulated to all the members, so that the bullet points of biomedical waste, Clinical Establishment Act, violence, accreditation can be shared to each and everyone, even those who have not attended this conference. Once again, I thank the organizers, IMA Maharashtra State and IMA HBI for a wonderful event, and I wish all the success for this event. Thank you. Jai Hind, Jai IMA.
Thank you, sir. Only I want to thank the chief guest, Dr. Wankhedkar, sir. And now I request Saurabh to propose the vote.
Good morning, everyone, sir. I'm very happy to say an excellent conference. I am a Maharashtra State Hospicon, Mahahospicon, organized by under the able guidance of Dr. Rajendra Kulkarni from Nashik. Though there are some technical issues which are a part and parcel of these type of conferences nowadays in this COVID crisis, but I would like to thank everyone who has taken the efforts to make this conference a great success, right from Dr. Mangesh Pate sir, Dr. Lele sir, Dr. Bondwe sir, Dr. Monga sir, Dr. Ravi sir for giving his valuable time and being the chief guest for this conference. I request all the delegates who have joined this conference to please maintain their momentum and do not leave, because technical glitches are a part and parcel. So once again, I would say that an excellent attendance, excellent response, all important matters related to hospital will be discussed in this conference, and question and answers also will be taken in between as and when. So without much delay, I would now request Dr. Rajendra Kulkarni and Dr. Mangesh Pate to take further the conference, and we hope I am sure it is going to be a great success. Thank you very much, everyone.
Thank you, Saurabh.
Yes, sir.
Now we will proceed for the scientific program. The first lecture is by
Uh, Today we will slightly discuss about the violence against the medical fraternity, especially in the COVID times. Friends, the medical fraternity is the medical fraternity in the COVID testing times has been assaulted from all the sides. With the efforts of the IMA headquarter and our supreme leaders, we have been able to at least achieve in passing the amendment to the Epidemic Act, wherein the Central Act came into force against the violence against doctors, the healthcare givers, and the medical establishments till the time epidemic is act is in force. Though we are not at all satisfied, but at least it is one step towards having a very strong central law against violence. It is very, very unfortunate that on one side, the government, the public, and the media says that we appreciate that all the healthcare workers are working day and night in saving the lives of patients. Still, the same people, the same media, the same government is assaulting the healthcare workers from all the sides. And mind you, this assault is not only physical. There has been assaults legally. There has been assaults financially. There have been assaults psychologically. All these various assaults have left the entire medical fraternity not only scared but highly frustrated with the state of affairs which our country is facing at this moment. We have been threatened day in, day out. People working either in the private sector or in the government sector. The assault by the legal threats in the form of cancellation of registration, invocation of the Essential Services Commodity Act, or to put us behind the bars under the Epidemic Act if we don't follow the various quixotic orders of the government officials. The over bureaucratization of this crisis has really led to policy paralysis. Worldwide, the medical experts and the technical persons who are well versed in managing this crisis, their expert advice is considered as the prime advice, while the bureaucracy is supposed to only implement whatever advices are given. Unfortunately, in our country, the exact opposite thing is happening. It is the bureaucracy which is deciding everything. Furthermore, even the orders from the bureaucrats, they are not uniform everywhere. Each corporation, each district is having their own set of ideas and they are trying to enforce on the medical fraternity. This sort of legal threats don't bode good for the medical fraternity. Ultimately, it is not the medical fraternity which is suffering. All this reflects bad in the management of this COVID crisis, leading to increase in COVID cases and increase in the mortality of the patients of COVID. Because the technical experts have to decide what is right, what is wrong. We all have seen that the government trying to dictate how much oxygen we should be using. The government trying to dictate when to give what drugs. Government trying to promote unscientific methods. All these things basically harm the patients and the general population itself. But the entire blame comes on to the healthcare professionals. These legal threats have to be stopped in their tracks itself. There is a financial assault continuously for last 8 months. First 3 months of the lockdown, there was a total shutdown. Even though very bravely all our IMA friends and colleagues kept their hospitals open, out of the feeling of sacrifice, out of the feeling of maintaining ethics, out of the feeling of our responsibilities towards our patients, bearing great financial losses, bearing great threats, grave threat to their own lives and their families. We all gave our services and are still giving. But all this resulted in great financial assault on our financial health also. The footfall of the patients have decreased up to 80%. Routine admissions have been decreased. The expenditure cost has been increased. The biomedical cost has been tripled. The cost of maintaining sanitization and maintaining the distance, social distancing, mask, PP kits have increased. And on the other side, there is a assault, financial assault by capping of the prices. This is really paradoxical and quixotic. I mean, only a fool can think of this, that you don't control the cost of inputs and you try to control the price of the output. Never in the world this is a sound financial management. This can't sustain for long. The government should try to understand this. We have been long demanding from day one that cap the prices of N95, cap the prices of PP. And now, just last week, what the government committee itself said, that the companies who produce the N95 mask and PP kits have looted the doctors and the hospitals and the government itself. A cost of which the government committee found out that the N95 mask should cost only 12 rupees. And we have bought it for more than 150 rupees right from the start of the pandemic. Same with the PP. PP kits are still available from 2000 to 300 rupees. The biomedical waste cost has tripled. We have to pay extra to retain our staff, or without giving the slightest consideration that the cost of inputs have risen, the patient's income has decreased for the hospitals, and the government, like a big fool, or like the legendary Don Quixote, they have capped the prices without any scientific basis. No scientific study was done by the government. I challenge the government of Maharashtra, or rather any government of the state, that shows the scientific study which you have done before you are giving this big financial assault on our hospitals and clinical establishments. They have capped the prices of CT scans. They have capped the prices of lab investigations. What is going on? We have submitted all this through the IMA Hospital Board of India at the national level and Maharashtra, which have done an excellent job of doing a scientific costing study, which is at least 6 times more than the government rates which are fixed. But the government is now totally not only deaf, blind, like the 3 monkeys of Gandhiji. I am very sorry to say this, but that is a fact. And if such deaf, dumb government, we have to be poked into action through the and that is why rightly IMA Maharashtra State has put up a court case in the Mumbai High Court against the capping of charges. This is a major assault on our financial health. Everybody knows that not only the assault by the relatives or the public in general, but there is an assault on our personal health, because we have seen that so many of our colleagues have succumbed to this disease, unfortunately. If the mortality rate of the general population as of now in India stands at 1.4, and in our state it is 2.5, the mortality rate of healthcare professional friends is 16.4%. So it is 15 times more than the general public. We have to be able to tell this, explain this to the opinion makers, to our non-medical friends, that with such great risk to our own life, we are struggling to try and treat patients as much as we can. And it is the entire success of the entire medical fraternity, that whatever success the government is claiming, that India is having the lowest mortality, and now we are over the peak, and the in many states, COVID has been controlled. This entire credit goes to you and me and the entire healthcare workforce, that in spite of such variety of assaults on the medical fraternity, we have been able to deliver. And instead of acknowledging this, what the government is doing, what the media is doing, there is another type of assault in the form of media trials. It is assault on the image of the doctors. A doctor works for 20, 30 years to create an image. And on that, his image, his reputation grows, and that reputation helps him in getting further ahead into his own profession. But certain section of media, just in the form of sensationalizing the news, have assaulted and conducted media trials. This assault on our reputation also has to stop. The psychological assault due to the fear of the disease itself, not only the fear of contracting ourselves, but even our loved ones, our family, our children, our parents. That fear definitely works psychologically on our mind continuously. Coupled with this, the fatigue which has set in. Fatigue of stress of last 8 months in dealing with this pandemic. And add on to the frustration which the government and the media is giving us. All this is taking a great toll psychologically, and it is estimated worldwide that at least 20% of the healthcare professionals are facing burnout in this COVID crisis. This is also a psychological assault. So 15% more we are having a risk of dying from COVID. And 20%, even if we survive, 20% more risk of we becoming a psychological wreck. And even with such great hazards, I am really proud of my colleagues, my paramedical staff, my healthcare workers. In spite of all these difficulties, they are working still day and night. And I am sure they will keep on working continuously, because this crisis, even though this is said that last 10 days India is now over the peak, but it is too early to say that we have really cases are decreasing. And the experience with even the most developed countries, which shows that even the first wave decreased, now all the European countries, they are facing a second big wave, which is much, much bigger than the first wave. Another thing, let me warn you about two things, friends. One, that even a vaccine is discovered, a safe, affordable, effective vaccine. Probably by early next year it will be discovered. But discovery of vaccine doesn't end the story. The story really begins for a low, medium income country like India to vaccinate each and every people. Here our organizations have to be very vigilant that this vaccine is freely available to the frontline health workers and not to some bureaucrats and some netas. Second point about vaccination, the same fatigued, overworked, overstretched, frustrated healthcare workers will be again put to task to vaccinate each and every person of this country, which itself is a mammoth task. We have to be prepared for it. And the second danger sign which I foresee is this legal and bureaucratic assaults which we are facing in the COVID crisis will continue even after this pandemic is over. The government, bureaucracy and the politicians now have tasted blood. The example of capping of prices even of non-COVID rates, or the clamoring demand for implementation of Clinical Establishment Act, all these bore bad signs that even if this COVID pandemic is over, the government and the bureaucracy will try to control the medical fraternity to a large extent. And hence, it is my humble request that we can only and only survive and regain our glory by remaining united. There may be problems. All associations, all organizations will have problems because each individual is different. And especially in the COVID crisis, everyone is stressed out. And when people are stressed out, their reactions are not like normal times. So each one of us should understand that there will be limitations due to COVID. People will be stressed out. Organizations will be stressed out. Still, we all have to see to it that our mother organization, Indian Medical Association, becomes as strong as possible. For that, each one should contribute in its own ways. Imagine our mother organization is like a big ship which is now caught in this COVID storm. And even though we may fight with each other, we may have differences with each other, but it is each and everybody's duty that when we are facing a big storm where we don't know whether our fraternity will survive or not, our ship will sink or not, each one should try and see to it that we close all the holes which are leaking water into the ship and not try to create more holes. Times will come, times will go. Posts will come, posts will go. Awards will come, awards will go. They all will be there if our mother organization, if our mothership, IMA survives and comes out of this crisis. If it doesn't survive, friends, we all will be left in the lurch. Whatever, I agree, there are deficiencies. There will be shortfalls. IMA will fall short in certain areas. But then, unless and until each one does its own part, plays its own part, contributes whatever he can, we can't steady this ship, especially through the storm of COVID which every one of us facing. So again, it is my humble, earnest request, forget whatever differences we have. It is my humble appeal to all other organizations also. Let us join hands together. Unless and until we will have our differences. When everything becomes normal, we will again fight. We will again deliberate over our differences. But today, that is not the time. If we have to synergize our energies, we have to synergize our resources so that we come out with minimum bad effects of this crisis. Thank you one and all. Jai Hind, Jai IMA.
Thank you, sir. Thank you for the, as usual, wonderful, enlightening speech. And now I hand over the mic to Dr. Rajan Sancheti. Before that, I would tender my apology from Team IMA Nasik for some technical issues, but I had spoken to Mr. Dipen Mehta of DigiShield that sent a test link yesterday, and the final link which was sent to our IMA Nasik was not intimated, and so there was a problem. So we had to just wind up the inauguration ceremony, and there was some chaos. So I sincerely apologize on everybody's behalf. And now I think it is all set, and the ball has started rolling by none other than our leader, Dr. Wankhedkar sir. Dr. Rajan Sancheti will be the host for the next session, and he is a very known face in IMA Maharashtra. He doesn't require any introduction. He has been BTO, and right now he is RMO at Bharati Vidyapeeth Hospital. I now request Dr. Rajan Sancheti sir to please take over and carry forward the session. Thank you.
Thank you, sir. First, I'd like to thank President Dr. Samir Chandratre and Dr. Rajendra Kulkarni, organizing chairman, for giving this opportunity. So also I'd like to thank Dr. Avinash Bhondwe, President Maharashtra State, in organizing, I would say, a very big Mahahospicon. 2,200 delegates is a huge number, and they need a big applause for this, that they have done, I would say, a very good job organizing this Mahahospicon. And I would thank again Dr. Monga sir, or all guests of honors for being with us. And I would like to introduce our next speaker. May I introduce Dr. Meena Pruthi. She is MD Medicine, consultant physician with specialization in echocardiography, practicing at Lifeline Hospital, Dombivli West. Immediate past president, IMA Dombivli. Co-chairperson, COVID Task Force, IMA Dombivli. IMA Maharashtra State Mission Pink Health. She was a zonal coordinator. I request Dr. Meena Prithvi to take over her talk.
Yes, thank you, Dr. Sancheti. Respected IMA dignitaries, very respectful good morning to all. This session, which we are starting right now, is the panel discussion on the clinical management of COVID. I would first introduce the panelists. We have eminent panelists who are professionals and are highly in expertise in their field of COVID management. So we have our panelists for the day, Dr. Archana Pate, Dr. Rahul Pandit, and Dr. Kapil Zirpi. I would have a brief introduction of the panelists for you, please. We have Dr. Archana Pate. She's a consultant physician and an intensivist and an executive member of the Maharashtra Medical Council, a member of the KDMC Task Force, chairperson of IMA Dombivli Task Force, a convener of the Ethical Committee Maharashtra Medical Council, chairperson of the Mission Pink Health IMA Maharashtra State, a national coordinator of the Women Doctors Wing IMA Headquarters, national coordinator of Mission Pink Health IMA Headquarters, national convener of Our Gaon Chale IMA Headquarters, past chairperson IMA Maharashtra State Women Doctors Wing, past president of IMA Dombivli, and a recipient of multiple IMA awards, IMA Maharashtra State President's Appreciation Awards in 2016, 17, 18, and Dr. A.K. Sinha Oration Award. Am I audible, sir? Am I audible?
Yeah, you're audible.
Can you hear me?
Yeah,
Yes,
we
right?
can hear you.
Dr. A.K. Sinha Oration Award and the IMA Maharashtra State Best President Award for Medium Branch. We have with us Dr. Rahul Pandit. Welcome, Dr. Archana Pate ma'am. Welcome, Dr. Rahul Pandit, sir. Dr. Rahul Pandit, he's a director of the Intensive Care Fortis Hospital, Mulund, a visiting consultant, ICU, a vice president of the ISCCM and the chairman ISCCM Mumbai chapter. He's a member of the COVID-19 Task Force Maharashtra's government, the teacher for College of Intensive Care Medicine in Australia and ISCCM fellow in diploma courses. He's got several publications, 3 book chapters, and more than 120 lectures and scientific presentations to his credit. He has a special interest in critical care echocardiography, ultrasound, brain trauma, and organ donation. He's an MD in anesthesia from Grant Medical College, JJ Hospital, a prestigious fellow of the Australian College of Indian Intensive Care Medicine, ICCMI, and worked as a consultant in Australia for several years, and an European diploma in intensive care medicine. And he's recognized for his contribution by the American College of Chest Physicians as a fellow of the College of Chest Physicians. So welcome, Dr. Rahul Pandit, sir. We have one more panelist on our, we have Dr. Kapil Zirpe. He is an MD chest physician with multiple professional accreditations and academic accreditations, whereas he's the editorial board member of the Journal of Critical Care Medicine. He's on the editorial board member, Journal of Critical Care, as well as Cardiac Critical Care. And he has also has multiple achievements, let us put in the professional society memberships and responsibilities, and awards and honors, where he has been felicitated by the British High Commissioner Embassy for the project EMS and the pre-hospital care, as well as an association with the ambulance services. He has been felicitated with gold medal by the hands of late Dr. B. Grant, who's the Chief Managing Trustee of Ruby Hall Clinic. He has been honored with Fellowship of Indian College of Critical Care Medicine, felicitated with Presidential Citation Award. He has been honored with the Fellowship of American College of Medicine, and honored with these excellent award in New Delhi, as well as been in elderly care. So please welcome these eminent personalities who are there with us, who will guide us as to the clinical management of COVID-19, what is the right way, what are the protocols, and it will enlighten us more on this. So welcome all three panelists. I will be starting my questionnaire. Dr. Archana, can you hear me? Yes, Dr.
Yes,
Archana.
I can.
Yeah. Dr. Archana, can you please tell me which are the patients in which we should suspect COVID-19 infection?
See, basically, we are in a pandemic scenario, and WHO has given us certain definitions and guidelines. That is, any patient who's presenting with influenza-like illness. So, influenza-like illness is any patient who's presenting with fever, cough, presenting in last 10 days, there are these symptoms, or any patient having SARI, that is severe acute respiratory illness, the same symptoms but which may require hospitalization. These have arisen in the last 10, suspecting a COVID-19 infection. But based on what we have been seeing, and ICMR has given certain definite guidelines as to which patients should be tested for COVID-19 in containment. What we see in clinical practice and in the present current scenario, that any patient wherein the fever is lasting for more than 48 hours, whether or not respiratory symptoms have yet come in or no, or features of viremia have come in or no, it will be better to get a COVID-19 test done.
Okay. Dr. Rahul, can you please throw some light on, is there any clinical course which this virus seems to be following? I mean, over a period of 6 months?
Yeah, look, I think the way this virus has basically panned in the pandemic now, we know for sure couple of things. Obviously, these course which I'm going to describe right now is not seen in 100% of the patients, but majority of the patients see this. So the first week, when you actually have 2 or 3 phases, one is the asymptomatic phase, when the incubation has happened and there is a viral replication which starts off. Patients don't have symptoms usually for a day or so, and after that they start exhibiting symptoms, and the symptoms may come up in form of upper respiratory tract symptoms or lower respiratory tract symptoms, or sometimes even GI symptoms. And of course there are these different presentations with stroke, MI, peripheral thrombosis, and all these patients presenting and then being found to be COVID positive. Okay, but the first week typically is the viral illness week, where you have influenza like symptoms, where you have fever, cough, and uh, sputum production is not a very good hallmark of this, but malaise is there, body ache is there. Sometimes you can have a GI disturbances. By around 7th or 8th day, the viral replication starts to go down, and probably around 9th or 10th day, it completely stops in majority of the patient. So there is this huge viral RNA load which is represent in the body, which essentially triggers off a immune response, which is the second phase of the virus, which is the second week of the illness. Okay, and that immune response is seen in form of either a new onset problem in such as hypoxia, or you may see hypoxia along with a new onset of fever, or a fever which was pre-existing starts becoming high-grade fever. And then if you look at your blood markers, your cytokine panel starts to rise up there, and that's what we are describing as the cytokine storm, or the cytokine activity which starts up in the second week. And then in a day or two, this stops, goes down, and by around day 13 or day 14, most patients become completely asymptomatic or they recover. Obviously, the ones who become critically ill or who require oxygen or intensive care continue to have problems in their recovery phase, even post day 12, day 13, either in form of ongoing oxygen need, or that is the time when they were usually susceptible for secondary infection. Because in the second week, you're also using steroids and bringing their immunity down a little bit. So that's the typical course which you would see for a patient.
Okay. Dr. Kapil, this question is to you, sir. Do all patients need careful monitoring? And when do we clinicians ring the bell, the alarm bell? That means they have symptoms and signs which suggest that this patient, needs immediate medical attention or can go critical.
Yeah, it's a very good and a practical question. First, what Dr. Rahul said is that every patient is not necessarily symptomatic. You will get the asymptomatic or symptomatic patient. Suppose if the patient comes with the asymptomatic, like his corona test is positive, but he do not have any symptoms. So we can advise them the home quarantine, ask them to monitor themselves. Now for home quarantine also, you need to understand that the each and every asymptomatic patient, you cannot ask them the home quarantine. Those with lots of comorbidities like angioplasty, bypass done, this patient needs to be admitted even though they are asymptomatic. Now coming to the ringing bell or alarm bell, any patients who is at advised at home quarantine or even in a ward, he is asymptomatic, admitted as asymptomatic with the lots of comorbidities. If the patient develop the sweating, if the patient develop the breathlessness, if the patient develop the choking sensation, if the patient has a chest pain, or patient become drowsy, or patient has a high-grade persistent fever, like fever is 100, 101 for 48 hours. These are the alarming bells. Please ask your patient to come to the hospital and get admitted. So I will say in a short, the persistent high-grade fever, chest pain, breathlessness, choking sensation, or uneasiness feeling. These are the cardinal symptoms where patient needs to come to the hospital in the emergency medicine, check their oxygen saturation, check their parameters, go through the investigation and get the admitted according to that. Thank you.
Yeah. So, Dr. Archana, do we categorize the patients? Like there are so many different clinical ways in which they are presenting to us. So how do we categorize the patient depending on their clinical as well as their radiological features?
See, as we all know by now, it is a common knowledge that, 80% of the patients who come to you may be asymptomatic or mildly symptomatic, but even they need to be monitored, and 20% of the patients are going to be having a moderate kind of illness, and a few of them are going to be progressing to be needing, ICU care. So basically, we do not know which patient is going to be definitely progressing towards that. As Dr. Pandit rightly said, this illness has been seen to progress through phases. And as Dr. Zirpe said, we need to monitor, these kind of symptoms. So basically, any patient who presents with, in the OPD or is seen by you for the first time, at every visit, you need to categorize this patient into mild, moderate, and severe category. See you initially, and they may come to you for 2 or 3 follow-ups. So at every follow-up, you need to examine these patients and you need to categorize them into mild, moderate, and severe category. At any phase, if you find that they are progressing to moderate or severe category, you need to request them to get hospitalized. So basically, what is this mild, moderate, and severe symptoms? So basically, any patient who's coming to us with only constitutional symptoms, that is, anything which resembles like flu-like illness, low-grade fever or malaise or headache, body ache, or any GI symptoms, which is not making them, there is any problem with the vitals or any oxygen levels problem, or even persistent, it made them follow up important here is first to, when we ask history to the patients, we need one of the onset of symptoms, because this is on an average going to tell us when is the patient likely to worsen. That is in the second week of illness, that majority of the complications are seen when the patient enters the immunization. So the milder would be the constitutional symptoms. The moderate would be where they would be having some respiratory symptoms, wherein the patients would be having an increase in the respiratory rate. There will be some increase in the work of breathing. The saturation would start falling down, but it would be still maintained on oxygen, but nothing going below 90. Respiratory rate should be, under 24 or 26. That is what we would call it moderate. Beyond this, the patient needs to be in at least high dependency unit where they will be monitored. Any respiratory rate which is going above 30, or even on oxygen support, if the oxygen that is more than 6 liters, the patient's oxygenation is not improving, still remaining below 90, this patient needs to be categorized as severe. They have any hemodynamic instability, the PF ratio is less than 300 and progressively falling. So all these, we need to categorize them into severe, and they need to be taken care of in the ICU with the hemodynamic monitoring. Radiologically, we basically, now CT scan has come up in a big way, because there are patients, we have seen patients who are immunocompromised, who really do not come up with a lot of symptoms. But if you do a scan on these patients by around say 6th or 7th day, we would see involvement of the lungs on the CT scan. And the Radiology Association has come up with certain categorization. They've given something called as CT severity score. So CT severity score is, and they have given a CORAD system. So CORAD system of 5 is, the involvement of the lung, which is typically seen in COVID patient, but the patient is not yet found to be COVID positive by RT-PCR or antigen test. And CORAD score 6 is the same score, but with RT-PCR or antigen positivity. And there is something called as a CT severity score. So as we know, the lungs are divided into a right lung and the left lung. The left lung has got 2 lobes, the right lung has got 3 lobes. Each, the percentage of involvement is given a score of 1 to 5. And the scores of all these 5 lobes are added up, and then a CT severity score is given. So any CT score of less than 8 is taken to be 8 on 25 is taken as mild. Between 9 to 15 radiologically is taken as moderate, and more than 15 is categorized as severe.
So it's depending on the clinical presentation and the radiology combined together, they are classified as categorized as mild, moderate, severe, right?
Yes, mild, moderate, and severe.
Yeah. Dr. Rahul, could you highlight some diagnostic tests which will raise the red flags in a COVID patient, especially the significance of the CRP levels, D-dimer, LDH, ferritin?
Yes. So I think we need to take one step behind, and this is where I've been repeating this for the last 7 months, that we need to actually identify these patients before they become hypoxic. And there are some clinical tests and there are some investigations as well which you can actually look at. So the best clinical test, which costs nothing and should be meticulously done, and unfortunately, despite publishing it, talking about it, it is rarely used in the hospitals and at home for home quarantine patients, is the 6-minute walk test. For some reason, 6-minute walk test has not really been implemented into clinic. Everybody knows about it. All doctors know about it. But when we talk to the patient, we need to be very, very meticulous about this 6-minute walk test. It is inducible hypoxemia. It is a test which is not invented by COVID. It is a test which has been there since the last 20-25 years. American Thoracic Society has recommended its use in patients who have got cardiac and pulmonary problems to look at the cardiopulmonary reserve. And if you are able to induce hypoxia by 6 minutes of walking in this patient, that patient needs to be in a hospital. Or if he's in a hospital, he needs to be in a higher level of care within the hospital. It's as simple as that. So if you can do that, it solves a lot of problems. The second thing is, as you mentioned, that there are some clinical signs and some investigations which you need to look at. So clinical signs, I think Dr. Jirpe has already mentioned that if you have a new onset of high-grade fever, shortness of breath, respiratory rate increases, or you start having choking sensation, or your saturation starts to drop down. These are some of the clinical signs. And radiological signs, the blood investigation signs or the cytokine signs which we look at, the most important, I think, is the CRP. Okay, I think that has to be the basis on which you would make majority of your decisions combined with your clinical decision. So we don't treat a CT scan. I really think CT scan as a snapshot at the diagnosis is fine, but you can't go ahead and treat a CT scan because you need to treat how the patient is clinically. Lot of radiological serious, significantly critical patients on the radiological picture are not that bad when you see them clinically, and you are able to get away without doing a lot of things. But vice versa is also true. They may not see very bad on the CT scan, but clinically they are profoundly ill. So CRP, rising in CRP, persistent, sometimes do a CRP at a very frequent interval with these patients in whom you want to take up a critical decision. Secondly, the D-dimer, ferritin, LDH, they are all acute phase reactants. They will rise with many things. IL-6. Now, IL-6 is something which we talked about quite a lot with a lot of enthusiasm when we started using these monoclonal antibodies, the MABs. However, we now know that IL-6 needs to be collected into a gel tube. If that gel tube is not available and you collect it in the normal tube and send it to the lab, just in the transport, you may have IL-6 increased by a couple of hundreds as well in some patients. So that's very, very important. And this is not coming from me. This is coming from our laboratory friends who say that, you, especially smaller hospitals who refer the samples to a bigger lab, just in the transport you could have problems. So please collect them in a gel tube, and that basically makes the big difference in terms of your actual value of IL-6. IL-6 just being high, but patient being clinically okay, no new onset hypoxia, X-ray is all right, CRP is probably not rising, does not mean that we have to panic and you start thinking of monoclonal antibodies. So these are some of the things which we need to know. My important message in this is, please look at the patient and treat the patient, not the number. Number can be anything. You have to correlate that with the patient's decision. And I'm saying this from after seeing and after going through the same process in the last 7 months in our hospital as well, that we probably treated a lot of patients based on number with monoclonal antibodies across the state, across the country, when majority of them probably didn't need it. Today, I have not used a single tocilizumab or itolizumab for last 2 months.
So very true, sir. So treat the patient and not the reports. That is what we always learned in our clinical practice, right? That is what it is. Dr. Kapil, this question is to you. As since we are on the treatment, could you guide us about the treatment protocols based on the clinical category of the patient?
Yes. See, basically, again, if you see the category already explained by Dr. Archana, it's a mild, moderate, severe. For asymptomatic patient, there is no treatment, only monitoring with the vitamin C, zinc, and B complex. For mild, moderate, severe, in mild, again, there has to be the with comorbidities and without comorbidities. If there is a mild patient who is admitted in a ward with without comorbidities, generally they don't need any antiviral. They can manage with the zinc and supportive treatment and monitoring. With coma, and you can add the augmentin or doxy as a antiviral effect. With comorbidities, you may offer them antiviral in terms of either hydroxychloroquine or Fabiflu or Flavipara or doxy and ivermectin. These can be the drugs which you can try in a mild with comorbidities. Moderate category is the patient. Moderate to severe, they need generally the antiviral on a priority. Moderate, that means those who are with comorbidities, their saturation is less than 94, they may require oxygen or they may require oxygen therapy. This patient needs the antiviral. My take on this thing is, when you are in a viral pneumonia phase, and if the patient is moderate to severe, his saturation is less than 94 and he's on the nasal O2, don't wait till he go on high flow or non-invasive ventilation. Just aggressively treat them in those particularly viremia phase, because the viral replication is on the surge. You have to add you are the best weapon, and the best weapon at present is the remdesivir. Believe me, whichever the way people are saying, I treated more than 3,500 patients, more than 750 critical care patients, more than 250 invasive ventilated patients, and more than 500 non-invasive and high flow patients. Remdesivir is one of the potent antiviral drugs which acts like a magic. In antiviral phase, generally they require, initially when they are on a nasal O2 2 liter with the scoring might be 6 to 8, just start them the remdesivir. Give them the steroids, which remdesivir generally we prefer the methylprednisolone, not the Dexa. Methylprednisolone 1 milligram per kg dose, that is a 40 milligram BD. And then low molecular heparin. You need to understand what is corona. Corona has a 3 pathophysiological features. One is the viral pneumonia, second is a microvascular coagulopathy, and third is your hyperinflammatory state. So you have to hit 3 things simultaneously. So start antiviral for the viral pneumonia, start steroids for the anti-inflammatory, and start the low molecular heparin for the microvascular coagulopathy, irrespective of the D-dimer. Please just read it carefully, listen it carefully. Irrespective of the D-dimer, start therapeutic doses of the low molecular heparin. Recent publication in NHS clearly says that if you give them the therapeutic doses of the low molecular heparin in early stages, it may work like a wonder. So we generally give them 0.6 ml subcut OD enoxaparin on the day 1. So your treatment is antiviral, your treatment is steroid, your treatment is low molecular heparin in therapeutic doses, and good basic critical care management. What do you mean by that? Good hydration, early optimization, correction of the your electrolyte balance, control of the fever, and oxygen requirement, optimized oxygen requirement. So this therapies works like a wonder. My aim in treating the critical care is to avoid them go on an NIV or ventilator rather than treating. Now, I will just want to comment on the Dr. Rahul's. I don't want to go extreme regarding the immunomodulators like tocilizumab. Yes, I use the tocilizumab. I am not fond of the tocilizumab, but I use the tocilizumab. If your timing is right, see, just look at your timing and the selection of the patient decides the results. If your patient is on the nasal O2, you already offer the remdesivir, methylprednisolone, and low molecular heparin. On day 8 is there, day 8 of the illness. Generally, when your hyper-inflammatory stage start. At that time, if your IL-6 was initially 15 and now jump to the 100 and 150, don't wait. See, he's going to be in the cytokine storm. Just observe for next 24 hours if there is a tachypnea, if there is oxygen requirement is going up, or if the patient is going on a high flow or NIV, and your IL-6 is rising trend, then tocilizumab single dose. Tocilizumab single dose, 8 milligram per kg, that means 400 OD, works like a wonder. I have seen almost 20 to 30 patients who have prevented from going on a NIV, and it works like a wonder. But again, the right patient, right timing. What do you mean by right timing? Your phase of the viral pneumonia ends on the 8 to 9 days. And if your day of the illness is a day 10th and your patient's requirement is going up in spite of all this cocktail, then please consider the immunomodulator. That is what my take on. So don't say no to anyone. Don't say no to the any treatment. Offer them at the right time and offer them in the right doses. Offer them. So other way around, if the patient is already intubated ventilated, please don't give tocilizumab. You will landed with the septicemia and the multi-organ failure later on. So all intubated ventilated patient, I never give tocilizumab. I never give the tocilizumab who is on the NIV and oxygen requirement is more than 80-90%. So he likely to be landed it on the ventilator. So why to blame on my immunomodulator? Might be I'm wrong with my timing of that drug. Probably I missed that stage of his control of the hyperinflammatory stage. This is how I look at. So there is no hard and fast rule in treating. Only these 3 drugs has to be there in a initial viral pneumonia stage. Regarding immunomodulators, your experience, your timing, the availability of the drug, and the overall patient's response decides the results. Thank you.
Madam, can I add something?
Yes, please. Yes, please.
I think 2-3 things which Kapil very brought out very important, and emphatically I agree with that. Is 1 dose of tocilizumab only. There is no role for repeat dose of tocilizumab. I completely agree. Timing is right. Okay. I mean, we have to look at the time, and Kapil, I'm not saying that I will not use. I've not had to use it. What it has basically happened. But what we need to do is we need to time it correctly. And if you're timing it correctly, it is a life-saving drug. There is no question about it. I don't have any doubt about it. My just third thing which I want to talk about was favipiravir. I think if you have, the same concept which Dr. Jirpe said, that if you have a patient who is going to be into a moderate or severe category, use your best weapon. I think if somebody is going to be treated up on an OPD basis who has comorbidities or who basically has got a high risk of worsening, I would not hesitate starting them on oral antiviral, because those are the patients who would probably benefit from them. In fact, you may go to the one extent and say, I would only use antiviral medications for a viral problem, not an antiparasitic medication for a viral problem. Because right now, ivermectin and doxycycline combination, seems to be working, but the data for that is not very robust.
Right, absolutely. Dr. Kapil, any new drugs which are there, which are showing some promise for treatments?
Honestly speaking, there are so many drugs are there, like adjuvant therapy, conversion plasma is there, or they are anti-molecular antibodies. Like that Trump is now promoting the new drug, so-called. I got so many calls, shall we try? I said, let the Trump try it, and we can just observe him, because Trump can get anything out with his answers. So I'm not fond of this thing. What I did in last 6 months, a very disciplined practice, very systemic approach, and whatever our evidence based management. That means antiviral, suppose remdesivir is working, yes, remdesivir in initial stage. Steroids are working, steroids in a proper doses. Low molecular dependence is working in a therapeutic dose. Early optimization. What I've seen in last 6 months is your critical care management in the early phase does the 90% job, and the 10% job is done by your rest of the drugs and all these things. Let me tell you, in last 6 months, I might not use single convalescent plasma in any of my patient. It doesn't had any problem in my practice. But I'm not against this drug. Please don't take it that I am very rigid personality. I strongly believe on a disciplined practice when you are approaching the pandemic, where the virus is unpredictable. When the situation is unpredictable, your treatment has to be the very disciplined. You cannot have everything in your hand and trial and error basis. You may landed with a lot of confusion. So, and see, my concern is I'm not working alone. There are 8 consultants, my 60 sisters, my 40 junior doctors. If I go on changing the treatment, now there will be a lot of confusion amongst the staff. So I need to tell them that what is the plan for this category of the patients, so that they can work on that meticulously and continuously without having. If you go and add change on the treatment now, then you will landed with the problem with a lot of confusion, and you landed with the medication error. So I did a lot of discipline practice in last 6 months. Not
Rahul, any new drugs which are showing any promising new drugs, Dr. Rahul? Sir, you'll have to unmute yourself, please.
Yep. So promising new drugs, as Dr. Jirpe said, there are drugs which are coming out every day. The Regeneron, which is the monoclonal antibody which President Trump used. Then we've got our Indian monoclonal antibody, which is itolizumab. There are a number of drugs. None of them have actually found to be in level 1 evidence right now. My concern, and I echo Dr. Chirpe's for feelings and what thoughts he expressed, is drugs are not substitution for good care. What we have learned for evidence-based care for the last 30 years of ARDS management and critical care management, that should be the form of our basis. Right from the first week, we are intubating these patients when they needed intubation. We are not basically delaying it. Right from the first day, we are going without any hesitation, either on high flow, and if we ran out of high flow machines, we have used non-invasive ventilation also on those patients. So, all this talk about aerosolization and stuff is good when you have the resources of a negative pressure room in every ward, which will be hundreds of them available. We don't have that luxury. So wherever possible, we are able to use negative pressure room, we will use it. Otherwise, we are taking all the precautions, maximum precautions, and do the stuff. So my humble submission again is, don't wait for a magic drug to come. The magic is basically good critical care, good physician care, good ward level care. Please don't use any of these drugs as a substitute. One of the classic examples, again, I'm not pointing fingers at anybody, but again echoing my same thought. Hypoxic hai, let's give another dose of tocilizumab. Hypoxic hai, let's give 500 milligram of methylprednisolone. Those things are not going to substitute for the intubation which that patient requires. So let's basically go back, take a step back, and start practicing what we have learned for last 25 years and unlearn the bad practices which we have learned in the last 6 months.
Thank you, sir. Thank you so much. That was very nice. Let's go to the oxygen delivery systems, which the viewers would like to know. Dr. Archana, could you please enlighten us on that a bit, on the different oxygen delivery system for hypoxic patients when they come to us?
Yeah, so basically, as Dr. Pandit rightly said, the whole aim is to maintain a good, oxygen levels in the patient, and that may be by any means, because the hypoxic damage that happens, basically, it will increase the work of breathing. The patient is in respiratory distress. So unless you take care of the hypoxia, you're going to be seeing a lot of other problems which will start coming into the patient. So basically, the whole aim is, either if you have only the pulse oximeter wherein you are able to monitor, then maybe you should aim for an oxygen saturation of 95, 96, but which is not very good when the patient is having an increased work of breathing or is having respiratory distress, because that is when we need to have ABG and we need to have, PO2, FiO2, which will guide us towards the ARDS and the severity of the ARDS. So any patient who is having, mild to moderate mild to moderate hypoxia, basically we can start with the initial oxygen delivery devices, that is by nasal prongs for the initial oxygenation. Anybody needing more than 5 liters, we should use Venturi mask. Anybody still having higher requirement, a non-rebreather mask would be good up to 15 liters. patients in COVID are, they are seen to have very, very high oxygen requirements, and HFNO has, shown to be a very, very good oxygen delivery device system in these patients with COVID-19. But probably with patients who do not have a very high work of breathing, and they can deliver oxygen up to 60 liters per minute. NIV in the form of either CPAP or BiPAP. I do not know. I heard initially that BiPAP or CPAP would not be doing, NIV would not be doing a lot of good on these COVID patients. They do not tolerate it well. But in our patients, where where we take more of moderate category of patients, wherein if they worsen or if they need anything like a ventilatory strategy, or progressing to severe ARDS, where we know that the patient is eventually progressing and is going to need higher tertiary care support. So based in these patients, what we have seen, that patients, when they are going into ARDS, they suddenly start developing hypoxia very rapidly. Their work of breathing increases. What we see is their RR increases, and they suddenly start having lots of cough in many of the patients. These are the patients we have seen that these NIVs, they do help the patients to quiet some extent. And if any further need is there of oxygenation, definitely for a worsening patient who is progressing towards severe ARDS, there is no point in waiting much, as Dr. Pandit has rightly said. And these patients need to be ventilated, intubated and ventilated in time to give them a better chance of living.
Right. Dr. Kapil, could you please explain to us what is the CARD protocol and this whole management strategy which we follow? The CARD protocol or the proning position?
See, if you are talking about the corona ARDS, let me tell you, though there are two types of the ARDS, they are Gatternoni explain, H type and L type, that means the high elasticity and low elasticity. But whatever we have observed in our practice, there is no difference of the ARDS in between the corona and non-corona ARDS. Most of the time they behave like a similar fashion. So if we are talking about the ARDS, now, ARDS is not necessary. Patients should be intubated or ventilation. If you see that the oxygen therapy, I would like to cover some part of the oxygen therapy. Initially, you have to start with the awake proning. Don't wait till patients require oxygen. Even on the patient is in a ICU for the monitoring, you can start the awake proning. Just explain them what is meant by prone. Be with the patient for first 10-15 minutes. Be with the patient. Explain that when you are on your tummy, you might feel choking, you might feel suffocating, you might feel pain, but just be aware that after 15-20 minutes you will find it better, and the literally patients start feeling better. So initially starts with the 15-30 minute session, then go on as per the cooperation of the patient, go up to the 2 hours. So what they have advised, 2 hours on a prone, awake proning, that means the patient spontaneously get on his tummy, 2 hours lateral, 2 hours another lateral, and 2 hours supine. And believe me, if you give them the good briefing and the confidence, they automatically do that. Whenever you are entering in a unit, the majority of patients are lying on their tummy and they are very happy and they are speaking with you and saying, doctor, I'm fine. Yesterday I was 6 hours. Yesterday I was 4 hours. So that is a awake proning. That is a spontaneous proning. That is a new terminology come during this particular COVID. If suppose in spite of that patient is dropping saturation, then oxygen deliveries are rebreathing, non-rebreathing, nasal O2. That means the simple oxygen therapy and the high flow, low flow oxygen therapy and high flow. Low flow are generally nasal O2, simple mask, venturi mask, where the flow is limited and the patient don't require that much oxygen. And high flow means patient requires the oxygen with the 15 liter, 60 liters, 40 liter, or NIV, that is high flow and NIV. So where you can explain, and even on that also, you have advised the high flow and BiPAP patients also in a prone position. So generally it works, and in spite of that, suppose it said we are not hesitating to intubate on day one also. See, in whatever we are taught in our critical care is that your NIV or high flow trial should be maximum 2 to 24 hours. You cannot just extend them by, see, conscious level is not the indication for intubation and ventilation. Most of the time the excuse is that patient is conscious, patient is speaking with the relatives, he's doing all these activities, he's eating. I don't care. That is not the criteria for any oxygen therapy or intubation. You have to look at the only two things: the respiratory rate and the oxygen saturation. In spite of the high flow with the 60 liter and FI2 of the 80%, if your respiratory rate is more than 30, that means that machine is not suitable for that particular patient at that time. Or your BiPAP, he is on BiPAP of 16 and the EPAP of 8 and the FI2 is more than 60% and the respiratory rate is more than 30, 35. Again, see, the key of success of the high flow and the BiPAP is just look at the respiratory rate. If the respiratory rate is less than 30 and patient is comfortable without tachycardia, tachypnea, with a saturation of 94, 95, you've done the job well. So look at these two parameters. In spite of this, if they are not maintaining, then go for the intubation and ventilation. And intubation and ventilation itself is a typical ARDS intubation ventilation, low tidal volume, PEEP, judicious PEEP. But generally what we observe, these patients don't require the high PEEP. Generally with the 8 to 10 centimeter water, they do well because this is not only ARDS. There is a microvascular coagulopathy works more in this patient for the worsening of the oxygenation rather than the bad lungs because of the damage of the alveoli. Then your prone position. Now prone position, what I explain is a self-proning. Self-proning is a spontaneous proning, and that is different from the invasive ventilation proning. In invasive ventilation, if your patient is on the tube and the control ventilation with FI to 100% of PEEP of 10, he needs to be sedated and paralyzed. He needs to be sedated and paralyzed, make him prone. This is proper act. It requires a lot of training. Please, that is what the problem with the periphery. I always wonder how they are doing the proning, because they require the two healthy, hefty ward boys. They require the two nurse, one person at the head end to secure the lines, catheter, tube. They have to turn the patient on the prone. Then when you turn the patient on the prone, again just check the ventilative parameters, whether there are peak pressures are going up, or your tube is get kink or tube is get blocked. Everything needs to be monitored after the proning and even continuously. And when the patient is in a prone, you can go maximum up to the 16 hour. Like spontaneous proning, you can ARDS ventilation, you have to go up to the 16 hours of the proning. That is the one setting. After the 16 hours, you have to make the patient supine, clean all these lines, catheter, and all these accessories. Check the RT feed, nurse him, clean him, and then observe for 4 hours. If 4 hours patient maintain the saturation, after 4 hours again you go for the proning. So maximum 5 setting generally work. So proning is an act. Proning requires a lot of experience. Proning requires a lot of manpower. Proning requires the monitoring. Proning requires the ventilatory knowledge. Proning requires the vigilance. It is not only putting them in a prone will improve your oxygenation. The proning is for 12 to 16 hours. 5 settings are generally work. So this is how the ventilation goes. So I always wonder, when we are promoting the proning, one need to promote it how to do it in the right way. Otherwise, you landed with the lots of airway accident and the loss of the patients. That's the problem, because if the patient is in a prone with the so many lines and catheter with the tube, and if he has a brady, I think that is the end of the story.
Thank you, sir. Thank you for explaining so fluently, sir. Dr. Rahul, I'll come over to you. So we have questions for you for which patients should be considered for invasive ventilation, and what is the strategy to be followed in case of for invasive ventilation, sir?
I think Kapil has mentioned quite lucidly already that
Yes.
patients in whom, despite non-invasive ventilation, the work of breathing, especially the respiratory rate or the use of accessory muscles, remains high, those are the patients who should be intubated. Another category of patients is that when we give a trial of a different oxygen delivery system like HFNC, HFNO, or BiPAP or CPAP, you need to be they are the most difficult patient. You need to be standing at the bedside and assessing whether that's working or not. If your PF ratio, and this is where another problem is, most people are not doing ABG very routinely. If your PF ratio continues to fall down despite best of your efforts, that is another indication. And what happens very often is that these patients will have a PF ratio coming below 100, way below 100, severe ARDS category as per Berlin criteria, but they would be speaking with the family, they would be speaking with the doctors, and this is where the deceptive thought process goes, that let's put him on 100% oxygen, but PF ratio is very, very low, 70, 80, 90 at times. So those patients, before they actually land up into trouble, should go. I will tell you my unit's protocol. We try and keep the PF ratio between 100 and 150. And if despite our best of the ability, it basically does not improve beyond 150, we go ahead and electively ventilate these patients. Anything above 150 to 200, we are a little bit relaxed. This is what we've learned over the last 6-8 months. I'll tell you something. Intensivist, me and Kapil, proning is not new. We've always done it for last 10 years. Low molecular weight heparin is not new. We've always done it for last 20 years. So all these practices which we are actually talking about now may be new to everybody else, but core intensive care has been based on those principles. Okay, so when you intubate these patients, you need to have a clear intubation protocol for these patients. Our intubation protocol involves a laryngoscope with a video, so video laryngoscope. Okay, somebody may not have a video laryngoscope, does not mean that their protocol is any inferior to our protocol. They have to just develop a way of basically minimizing the aerosolization when they are intubating them. So you could have a intubation box, or you could wear an extra face shield. One thing is very clear: whoever is intubating has to be the senior most person, the most experienced person who is intubating. These patients are not patients to teach intubation. These patients are the patients whom you want to get them right the first time very quickly. Okay, then as mentioned before, we need to look at the PF ratio, ventilatory strategy as per ARDS ARDSNet protocol, and if they are having a PF ratio which is below 150. Now, where is this magic figure 150 coming from? The Proseva trial which came out in 2014 used 150 as a benchmark to start proning these patients early. So prone them early. What we do is, in our unit, we are proning them irrespective on the first day. Okay, and then we start thinking after 16 hours whether they require any more proning or not. Usually between 2 to 4 cycles, most patients actually improve reasonably well. Either we go ahead and extubate them, or we go ahead and tracheostomize them and start weaning them. Okay, but it requires a lot of vigilance. It requires a significant amount of human effort. But I will be very honest again. If we are not proning the patients today, we are doing a disservice to the patient. That does not mean that you prone the patient by putting the patient to the risk. Improve your ability to prone the patient in your unit in the periphery. Have more manpower if possible, but please attempt to prone them in a safe way. Okay, not in an unsafe way. So don't put them at more risk. But by proning, most patients will have their improvement in the oxygenation. So these are some of the ventilatory strategies. For first 48 hours, complete sedation with paralysis. Again, many studies have shown that it is beneficial. There are some counter studies against that as well. And use your best medications, the drugs, the antiviral drugs, or whatever it is, way before this situation comes. But if a patient comes to you on day one and you've intubated, don't hesitate to use remdesivir, don't hesitate to use low molecular weight heparin, don't hesitate to use your low dose steroids, 0.5 to 1.5 milligram per kilogram of methylprednisolone. So these are the strategies.
So what about the strategies for neuromuscular blockade and sedation which you follow in your setup, sir?
So there are a number of studies now. From there, all the data comes from ARDS trials. So for first 48 hours, we want these patients to be deeply sedated. What we use in our unit is fentanyl and midazolam infusion, continuous infusion, and we put them on a atracurium infusion for the first 48 hours. Depending that, most patients are actually difficult to oxygenate on day one, and we have intubated them for the lack of oxygenation. So give them the best opportunity to improve. Secondly, when we prone them, it is easier to prone them and for them also to lie in a prone position when they are completely paralyzed. We use a train of 4 monitor, top monitor. Try and keep one twitch on the top monitor so that we are not overdoing with your neuromuscular blockade. So that when they wake up, the neuromuscular weakness, which we call as critical illness, myopathy or neuropathy, is also very, very minimal, because steroids along with sedation and along with your neuromuscular blockade actually complicates this problem as well. So the recovery may become a problem as well.
And also, what is the strategy for weaning of such patients? I mean, once the patient is recovering, when would you wean such?
So generally what we monitor again here closely is a multi-pronged thing: clinical situation, hemodynamics, patients saturation, patients heart rate, urine output. We look at the X-ray. Auscultation is almost out of question. We are not auscultating most of our patients right now. So X-ray improvement, ABG improvement, acid base as well as oxygenation and carbon dioxide clearance. Start stopping the sedation and waking these patients up and see how they wake up. Sometimes they de-recruit as well very quickly, and we have to resedate them and go across with another few days before we can actually wean them off. And your main important thing is that your problem with which you started is starting to resolve now. So all your cytokines are settling down, your X-ray is improving, your oxygenation is improving. Those are the patients you would start weaning them gradually. A sizable number of them require tracheostomy, especially if they are ventilator intubated. Don't delay the tracheostomy too long, but this early tracheostomy thing we try and avoid um deliberately if we feel that we'll be able to extubate. There are some patients we just know that he is going to need it. In that case, we have gone ahead and done a tracheostomy on day 4, day 5 as well. Otherwise, averagely around day 7, day 8 is what we are doing tracheostomy. But first 3 or 4 days, it's all proning, supining, proning, supining. Then once they stabilize for a day or two, PEEP becomes a little tolerable, FiO2 comes down, that we can do a safe tracheostomy. That's when we do a tracheostomy on these patients.
Sir, could you just enlighten us a little bit on the role of ECMO in such critically ill COVID patients, sir?
Yeah. So again, ECMO is a therapy. The first question when somebody thinks of ECMO should be ECMO to what?
Okay.
So ECMO to recovery is the goal which we should be having. ECMO to lung transplant is not a reality in 99.99% of the centers in India. Only few centers in India may have that kind of option, that ECMO to heart or ECMO to lung transplant. So when do you have that chance? Again, most of the trials, most of the data which we have looked at, ECMO should be instituted not as a last, rescue therapy, but as a therapy which will basically benefit the patient and have some chances of patient condition improving. So if one or two prone cycles patient does not improve, patient is within the first 7 to 8 days of therapy or of illness, please by means you can go ahead and put them on ECMO in a patient in a center who is ECMO capable. Many times I see that centers which are not ECMO capable uh, ask this therapy as a distress therapy, and then they are not able to manage those patients very well because they are just simply not trained to do that. Okay, even in the best of the ECMO centers, complications come, machines stop, oxygenators burst out, leakages happen, clottings happen, all those things happen. So we've got to be very clear. What we do is, I have done now around 2-3 ECMOs in this COVID time. We have gone across, put the patient on ECMO and brought them to our unit. That's what we have done. So all of these referrals we have done, and we've chosen our patients, only those patients who probably are likely to improve with the ECMO. But those patients who are in the second or third week of illness and not improving because of lack of oxygenation, ECMO is not going to change their outcome. Unfortunately, that's the truth about it. So use ECMO at the right time.
Thank you, sir. Thank you so much. Dr. Archana, could you just tell our viewers about the plasma therapy in a COVID patient, the role of plasma therapy?
Basically, as Dr. Zirpe rightly said, with the use of remdesivir, actually remdesivir has shown such wonderful results in patients when it is, used at the right time. That is, in the viral replicating phase. That is the time when, remdesivir has shown wonderful results. And so plasma therapy, which is an off-label therapy, is really not that frequently used in all the centers. But plasma therapy basically can be used, with a proper patient selection. And again, it is meant for use in moderate category patient, because if we understand plasma therapy is basically we are trying to give ready-made antibodies to the patient, and this would help only when there is an active viral replication going on in the body. So this would be helpful in moderate category of patients, say between the same 5th to 10th day. And ABO compatible plasma needs to be given to the patient, 200 ml. And again, you have to watch for all transfusion related, complications which come by. So plasma therapy is approved for off-label use by, in moderate category of patients, the category we have just spoken about before. So that is a respiratory rate between say 24-30, saturation say just between not lesser than 90, patient within falling in this phase, intermediate phase. So these are the kind of patients who could be benefited by plasma therapy.
So Dr. Rahul, your experience with plasma therapy, I mean, have you been using it? Have you used it on patients? Any experience you could share? Dr. Rahul? Um, Dr. Kapil, any experience with plasma therapy?
No, I told you that I never use in any one of my patients. But I didn't say it is an off-label treatment, and there is a lot of. This is a media trial. I will say that this was just promoted by the media, not by the scientists or doctors for this thing. So even ICMR also guidelines says that there is no role of the conversion plasma, and even international trial was clearly showed there is no evidence of benefit with the conversion plasma.
Dr. Rahul, would you like to throw some light on the this? Have you plasma therapy in your center?
I have not. So we have a plasma therapy available in our center. We've actually distributed 99.99% of our plasma outside Fortis. I have not used a single plasma in my patients. There are 2 or 3 reasons for that. Okay. One, again, I'm going back to what Kapil said because he's been sort of saying all the right things so well. You have to regimentialize your therapy. Regimentialize means I cannot afford to have one therapy for one patient, another therapy for another patient. I have a very clear protocol which is working for us. Suddenly to bring in the plasma is a problem. Secondly, none of the evidence actually is pointing towards any benefit with the plasma. And thirdly, I feel that this whole concept of keeping plasma reserved for patients of moderate or severe, I think we've missed the boat. If you look at the Mayo Clinic protocol, they are using it within the first 3 to 4 days of patient's illness. And that's probably the time when you are the best effect. Now tell me which patient in my ward am I going to convince that you please use plasma day 3, day 4, PO? This is the time you will actually have the most beneficial effect. None of them will agree. I would not agree probably myself as well. So I think plasma therapy, we need to be very, very clear when we are going to use, and it probably is best within the first 4 to 5 days. I would actually think of that. Another way of thinking it in a broader sense would be that when you think of remdesivir, think of plasma also at the same time. So when you think that your patient is ready to receive remdesivir right now, think of plasma on the same time and give both the therapies together. So that's another rough rule of thumb sort of a picture that you think of it.
No, and actually, what Rahul said is right. See, there was from day one, there is a confusion. When the ICMR released the guideline in late May or early June, they say it is for 200 to 300 PO to FR2 ratio. That is the mild criteria. Later on, the trials came for the moderate to severe. If the patient is already on the ventilator, I don't think your antibodies are going to work for the plasma therapy. So, indication of the plasma, if at all you want to use, is a very early phase, and that's what you have to club with the remdesivir. That means the early 5th day or 6th day of the illness. That means the patient requires when nasal O2 2 liter. I think the plasma may work. I don't know about that, but it may work in a very early stages and the mild form of the disease. And probably what I am seeing now, if the patient is on ventilator and all relatives, politicians, everybody is calling me, say that why don't you give the conversion plasma? So they know only that something that treatment is advised and discussed on the newspaper, and they want to. I categorically say that I don't do any trial in my critically ill patient. I tell them that I never do any trial, whether it is homeopathic, Ayurvedic, conversion plasma. I am not against any therapy. Let me tell you, I am not against any therapy. Unfortunately, I don't have knowledge about those therapy. And if any therapy I don't know, I am not supposed to try on my patients who are already critically ill and they are in the verge of the deterioration. So that is what the logic and science we use in our critically ill patient. So if you explain, they listen. Majority of the time they listen to your proper explanation.
Unfortunately, what is seen is, this plasma is being used in peripheries. What we see is it is used for severe and critically ill patients.
Yes, that is wrong.
Somehow. I mean, and with the media trial that is there, it is, brought out as a magic potion. So as if, giving plasma is going to sort out all the problems and patients are going to be all absolutely okay after giving plasma. Plasma, if at all, I mean, because it is an off-label use and not really many people do have a lot of, because remdesivir has proven to be a very effective drug. So unless you use it at the right time, plasma does not have any role to play, and definitely not in severely and critically ill patients. Second is the use of remdesivir, which we have seen is, people use it beyond 5 days. It is like used randomly for 7 days, 10 days period. And again, beyond 5 days, it is really, if it is to show any effect, it is going to show in those 5 days. Beyond that, it has not really shown much effect. And the third thing what we have seen is, people are not using low molecular weight heparin. The low molecular weight heparin is not finding a place into the protocol of now what we are talking is, Dr. Zipe and Dr. Pandit represent the multi-speciality tertiary care hospitals, and what I represent is, the peripheral hospitals, the small and the medium peripheral hospitals that we see. And definitely there is some lacunae over there in following the protocols. So certain things definitely need to be put across to the peripheral hospitals which are treating the COVID patients, that there are certain protocols which everybody definitely needs to bring into the clinical practice, and a protocolized treatment is going to give a better chance to the patient, in the form of preventing them from progressing towards the severe illness as far as we can. But because I can tell you that definitely in whatever the patients I have seen or I have encountered, the moderate category of patients, if given proper protocolized treatment, really very, very few patients have progressed to the severe or the critical illness. So if given a right protocolized treatment, definitely we give a better chance to the patient and chances for a better outcome.
Yeah, and let me put it on the note that I don't blame periphery doctors and hospitals. They don't have that protection. They don't have that this thing. There is a lot of pressure from the non-medical and the politicians. I and Rahul works in an absolute protected environment. Believe me, to reach us, they have to cross the 3-4 layers to reach us. So I can talk on a dais and very categorically say that don't use this, don't use this. I agree with that. But if I mean to say that if you explain them across the table in a proper way, they may listen to you. They may listen to you.
Listen.
Thank you. That was so nice. Well explained, especially for the peripheral hospitals. Sir, Dr. Kapil sir, can you tell me what are the complications which you've observed in COVID patients, or do they present in some other complicated manner or clinical presentation?
See, basically, COVID is totally unpredictable virus. Its presentation is varied. Though we are saying classically fever, sore throat, these are classical. But I have seen the patients with the migraine infection, stroke, GI symptoms, everything, except the pregnancy, everything I have seen with the COVID virus. So first thing, see, during pandemic, if somebody is coming to your casualty with the fever and any other symptom, it is the COVID. So in fact, it is very difficult and very easy. I always say that this virus is unpredictable, very easy to diagnose. If somebody comes to my casualty and say that I have fever and convulsions, I say it is COVID. Somebody says I have fever and chest pain, I said it is COVID. Somebody says that I have fever and pain in abdomen, I say it is the COVID. Somebody says I have fever and uneasiness, it is COVID. So basically it's a varied presentation. Second thing, complication. I told you that this virus has a three pathophysiological this thing, like and inflammatory, severe inflammatory stage, pneumonia, and microscopic coagulopathy. So they present with the, you can say bleeding. They present with the gangrene. Just yesterday, I received the patient with the pain in abdomen. We operated his whole intestine with the colon was gangrenous. So if people don't understand this. People, when they brought them, they was almost in a conscious and vitally stable. And after 24 hours, he's in a septic, he's in a shock and multi-organ failure, and he's going to die. So these complications starting from the brain to the toes, I will say. I have seen the gangrene of the toes. I have seen the gangrene of the intestine. I have seen the gangrene of the colon. I have seen the MI. I have seen the stroke. I have seen the venous sinus thrombosis. I have seen the encephalitis. I have seen the IC bleed. I have seen the convulsions. So every complications are with this particular virus, and they are related with its side effects.
Okay. Dr. Archana, suppose we have a patient who comes with signs and symptoms, clinical and radiological features of COVID, but they test negative. Many times it happens that the COVID PCR is negative. Then how do we treat such a patient?
There are many reasons why a COVID PCR, would come negative. First, as we know that COVID RT-PCR, it has got 30% of false negativity. So despite patient being positive, the test would be revealed as negative. Second, it all depends on how the test is taken. If a proper nasopharyngeal or oropharyngeal swab is not taken, then there are very high chances that the swab test is going to be turning negative. Third, as Dr. Pandit said, that, by 9th or 10th day, you do not expect the virus to be detected from the swab which is taken from the upper respiratory tract. So if a swab is taken in the later phase of the illness, then again the RT-PCR is likely to be negative. But for all practical purposes, any patient who's presenting with SARI with all the clinical signs and symptoms which are, matching the COVID signs and symptoms, who are having, now here is where the CT would play a major role, that the CT is quite relevant as to the findings of, with a CORAD 5 score. So that is where we would like to treat the patient in exactly the same way that we would treat a COVID positive patient with similar kind of features, but probably we would treat them in a separate area or in a separate, place where we would not be mixing them with the COVID positive patients. Do again a COVID RT-PCR at the center when the patient comes to you. If the patient is, turns out to be RT-PCR positive with a proper swab test being done, you can treat them along with your other COVID positive patient, or you can treat to continue to treat them separately or in a COVID negative facility, but probably in the same manner as you would treat a, RT-PCR COVID positive patient.
Okay. And I mean, if you could just help us with some discharge guidelines and criteria once the patient is recovered, we have, and then what are the discharge criteria and guidelines for the
Yes, so discharge criteria have been given out by the ICMR. So we talk about basically in these patients wherein one thing, as it has already been discussed, that if a patient generally does not develop any complications by the 10th day, then the patient is unlikely to develop new complications after that. So that is where a 10-day mark has been set, to call the patient relatively, problem free. So a patient who's in home isolation or patient who is in the isolation ward, if that patient does not have any problem, any complications so far, then by 10th day, they are said to be discharged from the home isolation or from the isolation ward. For any moderate category patient, it is like either 10 days or 3 days from the last fever, or 3 days from the last breathlessness, or the use of oxygen. The patient has been off oxygen, doing well for 3 days, whichever is later. Okay, so that is considered to be as the discharge criteria. From the ICU, generally it's like never that the patient is okay by the 10th day of the illness. So basically that is where the entire your clinical criteria or the clinical discharge criteria, as in the hemodynamic stability, or the patient is maintaining oxygen levels well, the patient is febrile, the patient is off any other complications, patient is able to do well by himself, and the same criteria then follow. It is at least 3 days of febrile period, or 3 days out of the ICU and doing well into the wards of any support. That is when the patient can be discharged from the hospital.
Dr. Rahul, if you could explain what is the post-discharge care at home, and the role of pulmonary rehabilitation in such patients.
I think it's a very important thing. I have been sort of running the post-COVID clinic now for last 2.5 months almost. And you need to be very, very specific about what we are going to give them as post-discharge care. So there are some corona appropriate habits, there are some corona appropriate behavior, and there are some corona appropriate therapies which we have to look at. So all three are very, very important. So what are corona appropriate therapies? Corona appropriate therapies means most patients who have been critically ill, required oxygen, stayed in the hospital for a long time, we would probably extend the low molecular weight heparin along with aspirin for these patients for at least 2 weeks, get them to visit us in 2 weeks time, and then decide whether we need to give them it for some more time or not. Some of them may be on a tapering dose of steroids depending on what was their discharge condition, and tapering doses of oxygen. So you need to look at that very, very carefully. But most importantly, so the specific therapy specific the guidelines, I'm sure everyone is very, very capable, but you need to guide them for right nutritious diet. You need to guide them for proper pulmonary rehab. Pulmonary rehab in most instances is talked only about incentive spirometry. That's not the case. We have a pulmonary rehab physiotherapist who actually helps them with deep breathing exercises, tells them how to hold the breath, how to let go of the breath, when to basically start talking, in what voice, in what tone you need to basically start your exercise, doing just starting the exercise to be taken up. All of those things are basically taught up by the pulmonary rehab. And then there are some maneuvers which they help to bring out the cough, or if there are any secretions which are there, which most patients generally don't have unless they've had a secondary infection. Third thing is good 8 hours sleep. These patients are extremely fatigued for the first 2 to 4 weeks. So good 8 hours sleep. And along with that, I am actually giving them a digital detox regime as well. I tell them to switch off their phone 2 hours in the morning and 2 hours in the evening as well. So that's something that as a medical advice I've started giving them, that digital detox is very, very important. Then corona appropriate habits. You know, you should not go out and forget about your corona appropriate habits. So masking up, sanitization and social distancing has to be followed for at least 2 weeks strictly in isolation, if you can afford to do that in a home. If not, at least within the household you need to have these three virtues, the corona appropriate habit. And then you have your corona appropriate behavior, sorry, corona appropriate behavior, and then you have your corona appropriate habits. So corona appropriate habits are essentially, you are going to, whenever you're going to use a common area of the house, make sure that you clean it behind you. When you are going to go out of the house, make sure that you are basically going to have your protection as well as the family people's protection. All these things need to be unfortunately told to all of us. They are not followed up. These are all common sense things, but they need to be spelled out on a prescription कि ऐसा ऐसा करो तो ही, you know, you will be basically having some form of adherence to it. Otherwise many people will not adhere to it. In fact, there is a bravado. I have seen the bravado in my own consultants as well, who've turned positive and come back to work, that I have a antibody kavach. That bravado has to go away. They have to be terrified that they have actually caught it once, and if they catch it again, it will be a big problem.
That's very important, not to be overconfident about being positive. It's not so powerful as it is.
Another thing, sorry madam, I was sort of talking about that. Another thing is mental rehab. So many patients, many patients, and lot of them are unfortunately our colleagues as well. I've had 2 or 3 doctors who have children living abroad, and they are petrified that they would not see their children in the near future or perhaps ever. So there are a lot of things which have basically been talked about mental health, but how many of us are actually offering them mental health and psychological counseling? We have our post-COVID OPD where we actually offer them this, but unfortunately many of them opt out of it. So they are happy to do blood tests, they are happy to do PFT, they are happy to do CT scan. You tell them you go and see a psychologist next time, or not there. But all of them within the heart, they feel that, you know, why were they a victim of COVID? Now, why did COVID choose them as a victim? We just don't know that answer. So that answer basically needs to be a mental unlocking to be done. And that's how they need to move forward. So mental health is very important.
Rahul, I will add to that. I have seen the medical person with the COVID are more vulnerable to the mental changes rather than non-medical. And the probable cause is the knowledge about the COVID. Because as a medico, we think worst come worst. I will start cytokine storm, then I will end it with the respiratory failure, then what will happen? And most of us are insecure in our practice. That's the another reason. We haven't planned our life, we haven't discussed with our family member. Even I am quite sure the majority of us just never share what is the plan of the next 15 years with the wife. Most of the doctors' wife don't know what they are earning and what they are where they are invested and what is going to happen, how many loans are with them and what risks they are working. So probably the last moment insecurity. I have seen the 50-year, 40-year young doctors crying like a baby. They are just crying like a baby when they are admitted. And it was so painful to watch them. See, there are two things. With the knowledge, you should become more confident and you should face the disease with the confidence. But other way around, with the knowledge, you become more and more weak. And probably that's insecurities in our practice. We should learn after the COVID. I said COVID is the best teacher in my life because COVID taught me the hundreds of things. COVID taught me the discipline. COVID taught me the self-hygiene. COVID taught me the respect to your colleagues. COVID taught me how to spend the time with the family and what is the importance of the family. COVID taught me what is the noise level in ICU. COVID taught me how the relatives should not be allowed on that floor. COVID taught me the less infection because nobody is doing any procedures. Nobody is handling the patient. So probably we are unnecessarily doing the most of the procedures and handling of the patient. COVID taught me stethoscope has a very limited role in our practice. Why I need need to tell the kid, I don't diagnose the cavernous or bronchial breathing by stethoscope. So that was something I did for so many years. I need to go back and check. And the COVID taught me the human values. COVID taught me the human values. That's what I think COVID is going to give us a next for 25 or 50 years the comfort of life. We should start practicing only 6 hours or 8 hours. We should stop the unethical competitive practice. Even if I do not see the more patient, the somebody else will see. That somebody else should stop seeing that patient. Why can't we say that every general practitioner physician see every day 40 patients only? Why can't we limit? We are easily available. We are easily providing the service. Though people don't value us. Why today they are respecting us? Why today they are giving us respect? Why they are not troubling us? Why they are not shouting us? Why they are not abusing us? Because they know the importance of the doctor. And probably we become a cheap and available, so we lost our values. So simple message: give respect to your duties, give respect to your families, spend time with the families. I'm quite sure whatever we are earning must be spending after the 50 on the different disease. So COVID taught me the hundreds of the things. What are the losses I record with those hundred of the thing, and I will go on learning. That's what
True,
my
sir.
point
So
of view.
true and so deep. And it's a pre-COVID and a post-COVID. You yourself will see the difference how you
Yeah,
are.
and the one more thing, let me tell you, the COVID taught my juniors to become a consultant. The whole game of the COVID was managed by my juniors and my younger doctors. And they must have been taken another 10 years to learn this thing. They learn within 3 months. Now they learn, they are independently managing, they are independently taking decisions, they are independently doing the procedures. I have find a major 180 or 360-degree change in my doctors. Their speaking style, their confidence, their judgment, their clinical knowledge, their communication, they are learned to live alone in this worse environment. So that gives me the confidence that probably must have been spent another 10 years to train them to become a consultant. Now within 3 months they become a consultant. So that gives me a lot of confidence. So probably we have to rethink about our education system also. Probably we are suppressing them a lot in day-to-day practice. That's what I have observed in my this 6 months stay with
But
them.
adding on to this, if we see, all the patients, those who get admitted, because, now the human touch is lost for the patients. Because we do not allow any relatives to visit, there is like for those few days, they are completely isolated. They are only seeing the doctors, and that too hooded. They are not seeing the doctors face to face. The staff, the ward boys, mouses, everybody is like, there's a lot of distance which is maintained from the patients. So these patients, so many, I would say about 80% of the patients have lots of psychological issues. They pass through lots of anxiety. They pass through a lot of depression, and that is where our role, a lot of probably just a bit of psychological counseling on these patients, showing a lot of empathy to them, and our talk would relieve lot of their anxiety. And in the patients where this anxiety and depression goes on to the next level, that is, it starts hampering their response to the treatment, or probably it clouds our judgment, because the patients are not being able to give us a proper feedback as to what is the complaint status or what. So definitely we need to think about psychiatric counseling on these patients. Teleconsultation has proven to be a very, very good support system at this phase. Even that suffices, but that definitely needs to be taken up in a big way on these patients who are undergoing treatment.
Absolutely.
And later also.
Absolutely. Dr. Rahul, you told us that we should not be super confident with the COVID coverage. I mean, if a person has once COVID, right? Can they get reinfected with COVID? And how long do those antibodies protect us?
The antibodies, there are various papers now which basically talk about antibodies going down as much as 28 times within the first 3 to 4 months itself. That means 28 times if they've gone down, they're essentially non-existent in your body. They're existent only in a microscopic level now. So we really don't have a long-term antibody coverage available with us. Even the antibodies which are there in the prime, we don't know whether how many of them are neutralizing antibodies and how many of them are binding antibodies. None of the labs, most of the labs are actually giving you a total IgG antibody. Total IgG antibody does not mean that all of your antibodies are neutralizing. There is a percentage of that who are going to be neutralizing antibody. Okay, that's why the titers of antibodies is important. or at least you should have 70% of your antibodies to be neutralizing antibodies. Then you can say that I've got a good antibody cover right now. So reinfection is a reality. There are a number of papers which have now started to report these cases. And I think we would probably start seeing them more and more often. I have been referred a couple of cases now as reinfection. Problem is that I don't have the first genome with which he was infected to actually say that this is a second genome. But when there's a clear gap of 2 or 3 months between the two infections, it is probably easier to say that this patient is infected again. So we need to again learn. So another lesson which we are learning from COVID is you should not be complacent with your personal protective equipment as doctors or nurses or any of the hospital staff, paramedic staff. We have to keep the guard all the time. Another thing, there is no place such as non-COVID in the world. So it cannot be in your hospital also. Okay, so these green zones, orange zones are actually having a lot of gray areas. You will find once in a while in a green zone a COVID positive patient coming up. So even in a green zone, at least your top part of the body, gloves, and some form of a overcoat like a gown or something should be the bare minimum which you should be using. So don't let your guard go down. There is nothing called as non-COVID right now. Everything is COVID.
Absolutely. We have to be careful at every point of the way. Sir, in your practice, what about the post-COVID sequelae which you have seen and how can we prevent them?
Yeah. So post-COVID sequelae, the most commonest complaint which patients have and can continue for 2 to 3 months at times is profound weakness. And this profound fatigue and weakness essentially is almost like a chronic fatigue syndrome, which many of us have seen patients complain of. So they get tired with few hours of work. They easily sweat during activity which they were normally basically very easily able to do it. Their baseline heart rate goes up many times. Even at rest, their heart rate is 10 to 20 beats higher than what it was pre-COVID. So these are some of the common complaints with which patients come. Other complaints are lack of sleep-wake cycle, lack of appetite, and then the most profound and the bad one, breathing difficulty. So pulmonary fibrosis, we have a sizable amount of people who may have pulmonary fibrosis. It would be fair to say that the earthquake of COVID is still going on, but are we going to get a tsunami of pulmonary fibrosis? That remains to be seen. We just don't know whether the pulmonary fibrosis is going to be a bigger one or not. What we know is that even with the SARS and H1N1 pandemic, majority of these so-called pulmonary fibrosis actually resolved spontaneously by around 6 to 8 months. So going by that data, which is like a coronavirus, SARS was a coronavirus itself, we were hopeful that what we are thinking today, that these patients have got profound fibrosis, maybe they will clear off their CT scans and their pulmonary function test completely in 6 to 8 months time. So I think next April or so, we will be in a better position to say that how these patients have fared. I am I'm an optimist, and I feel that these patients, majority of them would behave in the same way, and there would still be a very small number of them who would be the unfortunate ones who would not have much recovery and would be respiratory crippled or respiratory dependents, who will have to be taken care of in a different way altogether. Some of them may have to have lung transplantation may increase in the next years to come, provided organ donation increases. So these are the things which are sort of interlinked to each other. But these are the common sequelae. Another common sequelae which I am seeing, again, I am going back to the mental health. Lot of people are getting nightmares. I have my own medical colleague here in the hospital who is out of the hospital, out of the ICU for last 3.5 months. Says that he gets nightmares in the night and wakes up thinking that he's in the ICU still.
Oh my God.
Yeah. So I mean, he's now undergoing counseling and all those therapies and stuff. But that's the reality of it. We are underestimating the problem of psychological health and psychological problems, and we need to be very, very on top of that. Plus neuropsychiatric complications. We've not even come across the neuropsychiatric complication spectrum. We don't know how big is this spectrum going to be. We are only looking at a psychological spectrum. Neuropsychological spectrum is something which is completely going to be different, and it will be seen as things go forward.
So there's like post-traumatic stress disorder, something like
Yes,
that.
it is a post-traumatic stress disorder. PTSD is probably the commonest and the best way of explaining this. It is a big stress, big trauma on the patients when they undergo COVID, especially for those families who have had somebody very very sick in the ICU, who have lost a member of their family, or who have had difficult financial stress because of this lockdown and the whole COVID scenario, and on top of that got involved with a sick patient, or they themselves had they become sick. For them, the mental trauma is huge, huge. It is unimaginable. I think it's a much bigger problem than a health problem which we are going to face. And unfortunately, right now, it is very difficult to find a psychologist who is actually willing to spend a lot of time together with the patient. Most psychologists are working, but they are working online. So it's all online consultation. The human to human touch is probably the only barrier which is not broken up yet. So once that happens, once people become more confident of doing a one-to-one counseling, perhaps it may be a little shade better. But that's again the mindset. I may have to change my mindset and say that it's only the online counseling which will work now. We don't need to do a one-to-one counseling.
Rahul, I need to add, I have objection on the pulmonary fibrosis wording. Fibrosis is an irreversible stage. I have seen the most of the patients are coming back with the normal functions. They are coming to the my cabin by climbing the 2 staircase. So we need to redesign or do this terminology pulmonary fibrosis. Pulmonary fibrosis, like idiopathic pulmonary fibrosis, is a permanent game. This is not permanent game. It is irreversible. I have seen the CT scoring of 20 coming back to the 0. So don't be afraid. Don't be just blown out of the proportion. This fibrosis is going to trouble us. Most of the patients, 90-95% of the patients are going to have their normal regained pulmonary function test, and already they are getting it after 2 to 3 months. So don't be afraid of the pulmonary fibrosis. This probably it is an interstitial pneumonia, and microvascular coagulopathy is a major playing role rather than the pneumonitis, pneumonia damage and the fibrosis. So that is the one. And second thing, I have observed the mental problems in the old people mainly, not in the younger or this thing. Probably they have feeling of loneliness, they have feeling of that the family dumped them somewhere else, and they are not very familiar with the social media. The problem is that if the younger patients are enjoying the quarantine, they are enjoying the hospital stay, they are playing games, they are doing everything on the social media. And unfortunately, that old person never be very familiar with the mobile. He don't know how to do the video calling, how to communicate with the families, how to play the games. So these older people have a feeling of that the families don't want them, and that is what the major concern. Probably this class more than 55, 60 are going to have a tough time in future rather than the younger. I just observe younger people just enjoy that corona. I don't know why they enjoy it, but they enjoyed the corona.
The problem in the younger patients is seen when they are very critical, or when there is a job problem, or they have lost one of the elders in the family. Those are the ones who are traumatized in the younger age.
Possible.
But other younger people, I think many of them actually have coping capacities in a different way. But I think pulmonary fibrosis word probably will be redesigned. So there is already talk of that in the pulmonary circles, that it is so. I mean, we all know pulmonary fibrosis is irreversible. So if these patients are clearing of their fibrosis in the 8 to 9 months time, it was never fibrosis to begin with. So it will have to be redesigned, whether we call it as an interstitial pneumonitis, whether we call it as a pre-fibrotic stage, which basically gets reversed. Those terminologies will come up.
Dr. Zirpe, just a minute, Dr. Meena.
Yeah.
Dr. Zirpe, Dr. Pandit, I just wanted to ask, how is your experience with Perfenidone or Nintedanib?
It's good. See what I am doing. There is a recent very good publication about the management of pulmonary fibrosis. What they give us as steroids, long-term steroids. Generally, those patients who require the oxygen for a long term or ventilator for more than 2 weeks, they require the steroid extended up to the 3 weeks, 4 weeks, even 6 weeks. You can tapering doses add. I'm adding the Defport after the 14 days 6 milligram BD and followed by the 6 milligram OD. I'm adding the Perfinex 200 milligram 8 hourly. I'm adding the Aldactone 50 milligram OD, which is as an antioxidant helps. I'm adding the nebulization with Budecard. Once they are negative, I am comfortable with this thing. I am giving them continuing with the proning. Even in a recovery phase, I am giving with the proning. So proning at the start of the illness and proning after the recovery also helps. So this type, and then nutrition, you have to be very aggressive with the nutrition, call dietitian, calculate the daily requirement, calorie deficit, high protein diet, and then your physiotherapy, exercise, mobilization, and the family presence. So It's like a multifactorial, multifaceted treatment. But yes, definitely Perfenix plays a role, and they take their time, but they recover. They recover from this thing. So this is what I am using it.
I don't know whether that helps or everything else which Kapil said helps. So probably
Something
very
is
difficult.
helping us. The
Something
patients
helps.
are coming, so
So,
I
But
don't want to
patients
say.
are
but
2 months down the line, they
4
are
months
coming
ago
with
I was
better
not
situation.
4 months ago I was not prescribing Perfenidone, but they are better. So
Yes.
probably Perfenidone has got a very small role to play, but everything else has got a very big role. So my mantra is corona appropriate behavior, corona appropriate habits, and digital detox, and spend time with the family. If you do these 4 or 5 things, they are going to be happy after discharge.
That's a complete treatment of the whole, complete care.
Yeah.
So any this vaccines on the horizon, because that's what everybody is looking for. So our panelists, please, if you could guide us in that.
So I will start.
Yes, sir.
I'm not very fascinated about the vaccine. The issue is the reinfection is common after the I'm getting corona. How a vaccine is going to protect me, I don't know. Second thing, which vaccine to believe? Russia, what is the vaccination? I think it is going to play a mental role more than the scientific role in our practice. So rather than believing and waiting for vaccine, I always say that follow the self-hygiene, self-distancing, and whatever the corona taught us follows for the next 1 year. Mostly corona will change its route and will be our own, back to our home in a proper way.
Because maybe we won't change our routes. Corona will change it.
It doesn't happen in last 6 months. Whatever change, we used to spend 1 lakh rupees per month on the different things. Now in 5,000 and 10,000, even the families are comfortably eating and performing. Now they are not going to the theaters, not going to the malls, not purchasing anything, but they are still happy. So what is the need of the life? Need of the life is we have to decide what is the need of life. So I will not go into the philosophy, but I don't believe, I don't waiting for the vaccine. I told my family members that don't wait for the vaccine, because every day they ask me when I go to the home, when vaccine is coming. I said, I am coming back. That is more than sufficient. Don't wait for the vaccine.
I will tell you, there is already a vaccine in place, which we are actually not promoting in the way it should be promoted in the spirit, which is your masking and social distancing. The mask is the vaccine and social distancing is the vaccine. How many of us refuse to actually talk to a person who is not wearing a mask? We should be doing that. How many of us actually make them feel that they have done something wrong? We should be doing these things. So mask is the biggest vaccine which we have right now. Mid of the nose to the bottom of your chin. It has to be full, not sitting on the chin, not above your mouth. Okay, so it has to cover both your nose and your mouth. Secondly, on a serious note, let's talk about the vaccines which are coming out. So we've got 2 or 3 vaccines in which the human trials have started up, and we know those Oxford one. Then there is an AstraZeneca and a Cadila vaccine, which is basically been going to come out. And then the Hyderabad-based, Bangalore-based company, the Bharat Biosciences, they are actually also coming out with the vaccine. Now, let us say on 1st of March or April or May, we have a vaccine available. Okay, let's take that hypothetically. The vaccine is probably going to be only beneficial by protecting to the extent of 60 to 65% only. We are not going to have 100% vaccine coverage even after getting vaccinated. So that's one problem. That means the mask will remain as the second vaccine, which will have to continue even after vaccinating. Second problem is we are 135 crore people in this country. If let us say every one of us has to get vaccinated from day one, it will still take 135 days if we vaccinate 1 crore people per day, which is not going to happen. So realistically, if our dream of getting vaccinated, all of us, to the extent of whatever it is going to come true, it is going to come true in 2022. So let us prepare ourselves that for 2021, mask is our only vaccine which we are going to have, and social distancing and hand sanitization are the 2 virtues which we have to carry all the time. So this is what the vaccine's short story is.
Yes, these are the new normals which we'll have to learn to live with. And unfortunately, people are just looking for development of vaccine and the other things, but we have to learn to live with the new normals.
We have to
Corona is
teach
here
them
to stay.
Yes, what the real vaccine is, as Dr. Rahul said.
Yes,
Protecting ourselves is the only way out.
Absolutely.
We have with us HPI chairperson, Dr. Mangesh Pate, sir. and he would like to ask a few questions to the panelists. Welcome, Dr. Mangesh Patil, sir, please. So your voice is not heard. So we cannot hear you.
Now can you hear me?
Yes,
Yeah,
sir.
yeah.
Absolutely.
Yeah. I will just explain this entire panel discussion as a phenomenal. That's it. No other word for that. And I'm so thankful to all of you. Sir and madam, as discussed by me with you, I will just have another 2 or 3 minutes. I have humble request to you to spend on this. Very specific and pointed questions. Number one, role of paracetamol or indomethacin. Number two, there are more than 1,000 hospitals right now live in this webinar, listening to you all. So I want you, even if we have said, to repeat the strict and stern protocol to use the remdesivir and tocilizumab in terms of number of days and number of dosage very categorically. Again, this is my humble request to you. And third, will it be right to say that the plasma therapy is slightly hyped than required after this panel discussion? These are the 3 things I want to ask you. Thank you, sir.
Who is this question from, Mangesh? Yes, for us.
Role of paracetamol, sir.
Role of paracetamol.
Yes, sir.
The paracetamol, role of paracetamol is essentially what it has been used for last so many years. Use it when you have got body ache and low grade temperature, but don't sort of give it continuously to try and muffle down the fever so that you don't have symptoms. But use it when you have a temperature which is basically more than 100.5 or 101 degrees Fahrenheit. Or if you have myalgia, by all means use it. I don't think there is any role for paracetamol to prevention or treatment of COVID-19.
Anti-inflammatory or anything like that?
No, sir. No role which is proven with indomethacin or any of the other other anti-inflammatories. Only anti-inflammatory which has worked is the steroid property, the anti-inflammatory property of steroid.
Yes, sir. Second is a number of days and number of dosages of remdesivir, tocilizumab, very strict and stern guidelines from you.
So remdesivir, 5 days. First day 200 milligrams, next 4 days 100 milligrams OD. There is no role to go beyond that. 5 days is as good as 10 days. So please continue with 5 days of this only. And tocilizumab, as Kapil said, if you have a correct timing of the patient, correct timing means patient is essentially going towards moderate illness, has got a rising CRP, has got a new onset fever or worsening of his hypoxia, has got a rising IL-6 perhaps at that time, you can consider to give him one single dose of tocilizumab, 400 milligrams, not more than that, or 6 milligram per kilogram body weight for somebody whose dose would come less than 400 milligrams. So don't go beyond 6 milligram per kilogram. For somebody who is 60 kilos, you may want to give only 360 milligrams, not 400 as well. So 6 milligram per kilogram, or whose dose goes above 400, just use 400 milligrams, single dose.
Okay. And lastly, sir, is a plasma therapy slightly hyped than required?
Sir, plasma therapy is definitely something which people are talking in a hyped way. I think we need to have scientific protocols when to use it. And the mental problem is actually within the physicians as much as it is within the doctor, within the patients as well. We are a bit hesitant to use it in the first 3 to 5 days of therapy because at that time the patient is not that sick. So we may use them early, we may find it to be better. But the current protocol and the current findings of the trials, I think it's a overhyped therapy. I firmly believe it.
Okay.
So there's
Thank you, sir. Thank you so much. I think Meena, you can.
Yes, sir. Thank you, sir. Thank you so much. So there's a question in relation to that, whether plasma pheresis can be of more use than plasma. There's one question from one of the.
So it is even more invasive therapy. Plasmapheresis has got a role if the viral induced HLH or hemophagocytosis has happened, then there is a role for plasmapheresis in these patients. Just like any other, if there may be a role for plasma also to be given later on in the day. But that's a different indication, madam. It is not for COVID-19. It is for the complications of COVID-19. Fortunately, not many patients go into HLH. So we are not being troubled by that in this COVID-19 era.
So there's one question, Dr. Kapil, on role of ivermectin.
I think ivermectin plays a major role in a prophylactic, and Honestly, I don't have any experience with ivermectin, but most of my
Yes.
colleagues, doctors have used, and it is in the prophylactic,
Okay,
not in
Doctor.
admitted or prone cases.
Okay, okay.
I haven't tried.
Dr. Rahul, your experience with ivermectin, because there are many questions on role of ivermectin in COVID, sir.
Again, I think it's an overhyped therapy right now. Many people are using it without any evidence for that. Just like people
Right.
talk about cyclopanin, people talk about augmentin, people talk about azithromycin, doxycycline. I think ivermectin is an anti-parasitic medication, just like HCQ was an anti-malarial medication. We
Absolutely.
should be clear that none of these were actually proven to be used in COVID-19. Unless there is a randomized control trial done, we don't know. The only trial for prophylaxis which was done in Egypt, I believe. I need to read that paper again. I sort of left it off very quickly without having a greater detail to it. But there it showed some benefit in those patients in whom ivermectin was given and they did not get COVID-19 positivity. So we don't know whether it is even useful for prophylaxis.
Okay. Sir, any long-term side effects of the drugs which we are using, remdesivir or tocilizumab, if any long-term side effects for any of these drugs?
So we know the short-term side effects, madam. Long-term
Yes.
side effects, I think in a day or in a year or two, we will understand what is happening.
Right.
None of them have been reported because all of these drugs, like remdesivir, was been there from Ebola time. You have tocilizumab, itolizumab being there for a long, long time before as well. I think the safety is probably more or less known, but whether it is used in this context, they may have some different complications which were not seen or understood before. We will have to find out.
And so any protocols, there's a question from one of the viewers about protocol in pregnant COVID patient. Any protocols to be followed in treating COVID positive pregnant patients?
So I think it depends on which phase of the pregnancy the patient is,
Right.
and what type of medications you would want to be using in that phase of the pregnancy. So patients who are near term or who are basically who are in the third trimester, it is easy. One of the problems is that you are not able to do X-rays in any trimester before that. So that's one of the policies. But of course, you can put up a shield and do things. CT scan would be out of the question for majority of them unless the risk of the mother is very high. If she's already come to moderate type of illness, then of course mother is the priority, and you can go ahead with whatever you do. I think plasma may be something which may be of very good use in these pregnant patients if we use them early. But again, many of them fortunately don't have the severe form of a disease and they come across. The challenge would be a full-term patient coming to you in ARDS and you needing to ventilate those patients. So like any other ARDS protocol, pregnancy will actually split your diaphragm and cause a breathing difficulty by itself. So you may need to think of electively delivering these patients at times as well. That's a decision which has to be taken at a clinical bedside management. It is not something which can be put up on a protocol that you have to go ahead and do it. That's one-to-one case-based decision which you have.
Yeah, but first trimester, I mean, when many medications cannot be given, suppose it's a first trimester pregnancy.
And most patients improve with symptomatic care. Zinc, vitamin C, vitamin D, which can be given very easily. The safety of none of these drugs, remdesivir or favipiravir, they've all excluded pregnant patients. So we just don't know. We just don't know whether we should be giving. So we should be using drugs which are simple and straightforward and can be used.
Absolutely. I think most of the questions, there are many more questions, but I think we are running short of time here. I would like to the panelists to please give us your take-home messages to the viewers, please. Yes, we start with Dr. Rahul, sir. Please, your take-home message.
My take-home message is that whatever we have learned for the last 25, 30 years in managing a illness, whether it is wards or home quarantine or in the ICU, please stick to the basics. Basics are the ones which are basically going to help you. None of these drugs are substitute to your basic care. What has been proven in the last 4 months is the therapies which have really helped is oxygen, steroids, basic care, and antivirals, which again are the same principle that if you have viral infection, you give antiviral. If you're hypoxic, you give oxygen. If you are basically having a patient who requires to be prone and ventilated, you go ahead and give that basic care to the patient. So these are the only therapies which have really helped. So let's stick on to the basics.
Absolutely. Yes, Dr. Kapil, if you could please
Yeah,
give us a take.
I will not go on a treatment. I will say the more on the prevention, because prevention is better than treatment. Self-discipline is the thing we need to continue. Then social distancing we need to continue. Mask we need to continue, and self-hygiene. These things need to be continued probably in near future, and try and avoid that. Is the prevention is better than treatment, and if it happens now, we know that what is this virus and what are the treatment part. So no need to worry. Please visit to your nearby hospital, nearby doctor, and start the treatment as early as. What we have seen, we have lost the many more lives because of the fear factor and because of the late presentation. So if you visit to your doctor early and in the right time, your mortality morbidity will be much less to the corona. So no need to fear now with the corona. We can face the corona very well in future also, even if there is a second wave or third wave. Now our healthcare system is completely geared up, so please rest assured that we are here to serve you and save you. Thank you.
Thank you, sir. Yes, Dr. Archana, I would like to take a message, please.
Yeah, I think I'm going to be elaborating more on what we see at our end. Basically, one thing is do not delay the diagnosis. What we see is that people either shy away or they are not guided correctly in doing the test in time. And there is a lot of confusion which remains. See, it is probably not going to change your treatment modality once the patient reaches you. Whatever state you receive the patient in, you're going to be treating the patient as such, but it is going to make a lot of difference to the patient if he reaches the hospital in time if diagnosed early. So please send these patients for testing early, get them diagnosed early, follow them up properly, treat the right thing at the right time, treat them correctly in a protocolized manner. For our doctors, I would like to say that please don't shy away from getting tested yourself, because we really have seen people questioning why should we do. As it is, we know what to do, so we'll be self-monitoring and we'll be taking care. So this is the general thought process which still prevails in a lot of people. Please, we are definitely in the midst of a pandemic and we need to be careful. It's just going to be a lot easier if you know your COVID positive status. You know that you have got it, you have to follow it up for a few days, and probably if that phase is through, you are through the woods, So it is better to get tested early, monitor the patients correctly, treat them correctly in a protocolized manner at the right time, and give them a proper post-COVID rehabilitative care. And that would be my take-home message.
Thank you so much. Thank you, dear panelists. We have many more questions coming in, I think, but since we are short of time, we can try and mail these questions to the panelists and get the reply from them, if that is okay with the respective panelists, right? And I thank you all for enlightening us and making us more wiser, more confident in our diagnosis, in our approach, in our management of COVID, as well as in prevention of COVID. And thank you very much, respected panelists, Dr. Rahul Pandit, Dr. Kapil Zirpe, Dr. Archana Pate. Thank you, Dr. Mangesh Pate, sir. And thank you, IMA HBI Maharashtra State, for giving me the honor to conduct this session. I think we'll hand over to Dr. Rajan Sancheti now.
Thank you very much, madam. Madam had conducted in a very beautiful way this session, moderated this session, and actually we are short of time. Main thing I'd like to thank the faculty members, Dr. Rahul Pandit sir, Dr. Kapil Dirpe sir, Dr. Archana ma'am. Excellent presentation. I feel about 2,000 doctors who are hearing, they have taken a good message from you. And we, in short, we say, Jaan hai to jahan hai. Two things I would like to say. You have to make aware your patients in having them wearing the mask, social distancing, because some days when the hotels opened, we saw a lot of problems there. Social distancing was not maintained. So we should make all the common public aware. And whatever the questions, I feel there were another 50 questions remaining, but due to short of time, we can take them later. A lot of queries have been answered, and we have to take care of the bravado and the mental setup, rehabilitation, as said. I won't say much about that, and we can start our next session by thanking all the faculties who have excellently, beautifully presented. Thank you, Veena ma'am. And thank you all the faculties again for having a very good session and enlightening us in a very, I would say, lucid manner. So for, can we go for next, I would say, lecture of Dr. Jayesh Lele on legislation on the horizon. Can we go for that? I am aware that everyone knows Dr. Jayesh Lele, but I would like to introduce him again. Dr. Jayesh Lele is the National Secretary, IMA Hospital Board of India, 2016-20, President of IMA Maharashtra, 2015-16. I am a professor, Sridhar Sharma Oration Award for the year 2017-18 in recognition of his services rendered to IMA headquarters. Held various posts in IMA branch, state and HQ levels. Received awards from IMA headquarters, IMA Maharashtra, like IMA National Individual Community Service Award in 2015. Delivered Thane Oration on CA at MAPCON 2016. Maharashtra Medical Council member, Accreditation Committee, Ethical Committee, gave many talks on CA, NABH and hospital issues, convener for Academic and Accreditation Board, convener for Education Promotion Implementation of Adult Vaccination, co-convener, I am a standing committee for research and innovation. So I would request Dr. Jayesh Lele, a dynamic, I would say, leader and a very good orator also. So please, sir, take over and enlighten us on the topic legislation on the horizon.
Yeah, Dr. Sancheti, thank you. Can you allow me to share the screen?
Yes, sir, please.
Yeah, I hope everybody is able to hear. Thank you, organizers. Thank you, Dr. Rajendra Kulkarni. I am in Nasik. I am in Maharashtra, Dr. Bondwe, sir, and of course, our mentor, Dr. Ravi Wankhedkar, who inaugurated the conference in the morning. Just before my talk, I was listening to the dreaded COVID disease management and how dreaded, and as doctor said, everywhere there is a COVID and everywhere there is issues regarding the COVID. So we have to be very careful. My talk is regarding the hospitals because over the last 6 months, lot of hospital issues have taken up the center stage, right from our capping to our charges, so oxygen and admissions and other things, and even taking over the hospitals, some 80-20, 50-50 and all that stuff. So today I'm going to talk something about various laws and some laws which are bound to come. We are in the pipeline and we have tried to take measure. I remember Dr. Mangesh Pate and myself and our leaders met the concerned government officials and we did work on them. But I'm going to just inform you about how those laws are going to, going to affect the various hospitals, because IMA, as you know, represent a very small and a medium hospitals, maybe about 30 to 50 or 100 bedded, 150 bedded hospitals in the periphery. So I will start with some of the laws. This is the topic of the discussion today. There are various laws governing the commissioning of the hospitals. These laws make sure that the hospitals facilities are created after due process of registration and are safe for public. I will not go into the detail. I am just going to read the covering head. Laws governing qualifications and practice and conduct of the professionals. These are the so many 10 laws are there. Then there are laws governing storage, sale of drugs and safe medications, wherein these control the use of chemicals, the blood, prevent the misuse and other regulate their sale. These are almost 10 laws which are applicable. Then there are laws governing the management of patients. Almost 16 laws are there, right up from the drug magic remedies up to the protection of human rights. There are laws governing the environmental protection, because whenever we are using this, outflows and biomedical waste and other things, especially sound and water and surface. So these are the government which are we need to protect them. There are laws governing the employment of manpower in the hospital because we employ right from doctors to receptionists to the nurses and ward boys. So there is a particular laws are there. There are regulations governing the business aspect of the hospital because whenever the hospital is there, many are under trust or what profits they make. So these are the laws govern the hospitals, especially the Charitable Trust Act, Customs Act, when we get the medicines and other things. Then there are laws governing the professional training and research. We do kind of some research as we are, whether we are following the ICM or MCI guideline, whether we are following the nursing councils and National Board of Examination. Those are the one which affect this. Then there are laws governing the biomedical research. These are the some of the medical legal aspects. Various IPC sections are affecting the laws affecting that. And there are state acts. Suppose like we take for the Maharashtra, we have a Bombay Nursing Home Act. And similarly in other states also some acts are there. But many states did not have act particularly for running of the hospitals and health management. So some of the states requested the government of India that time during around 2010 prior, and that is how the CA was born in 2010. The CA today, in spite of various issues, IMA was one of the pioneer in preventing 10 years back that this was not directly put into the Maharashtra hospitals because we took a lot of agitation and we represented government very well. Some of the states, what the central act was there passed by the central government, some of the states accepted that act, but many states modified it. And in Maharashtra also, we during the time of late Dr. Kishore Tauri, we represented the government and a separate committee was formed. We have given our proposals, changes and all that. But the government of Maharashtra has yet not accepted that act. But now we came to know that they have already proposed different kind of frames into that, and different important points are already they have tried to cover up in that. So I'm going to touch upon those special points which myself and Mangesh represented to the government, and we gave in writing the various issues. So some of the points I'm going to touch upon that. The most important point is whatever the clinical establishments where the indoor facilities are available should provide basic emergency medical assistance within the facilities prescribed, because in the formerly the state as well as the government of India and the Supreme Court said that any patient, any injured or anybody, you must give some primary treatment. And suppose the complications occur, neither they are going to give the bill, neither they are going to stand by us if the complications occur. So we are going to propose that whatever the facilities is available with the hospital, and within the framework for that hospital, the doctor will be giving the treatment. Otherwise, they will transfer or they will not accept the patient for that kind of treatment. There are additional points covered in the additional medical officers, because very well they are asking the MBBS doctors in the hospitals and the entire trained staff. There is a dearth shortage of medical officers or CMO, AMO and a trained nursing staff. So for that we have given them some guidelines and we have helped them to go for that. Another major issue has been tackled regarding the minimum space requirement for the hospital. For example, the bed area, room area, ICU area, staircases, entrance. Entrance is the major factor. Some time back, it was attended in Mumbai, because in Mumbai, Municipal Corporation stated that in have a separate entrance for that hospital. So like that, these are the which we came across. We have given the government.
Go on,
Important
please.
topics are here now. Basically,
Yes, sir. Go on.
general planning and building requirements, road abutting, which I was mentioning, some because of some technical glitch, we had to wait for some time. The small hospitals, they are always compromised regarding the kind of roads, parking, and other things. So we have requested the government that those rules of this urban development should not be applied for this hospital, because they are always having the issues about that. As I mentioned about the parking spaces should be allowed to have more, exemption, because there are ambulance coming in, patients coming in continuously. There is a possibility. So nearby road should be allowed to keep the car parking. Multi-level car parking may be implemented if possible. Practically, if it is possible, we can get that much space without FSI. Like FSI is another problem because many times the hospitals are purchased on a small land or transferred or kind of this thing land, and then a lot of road constructs come because you can get a TDR, you can get the land FSI transferred, but in the place which is being allowed, the roads may be smaller, and then you cannot have that exemption of the attached to the road because of the FSI being getting it. So those minor points, what are there, they should be looked after by the urban development. The said relaxation should be enforced by the state government to avoid further objective and variable applications to the local authorities. Many times, what during even COVID we have seen, the government of Maharashtra orders something, India orders something, and local implementing authority orders something. So this discrepancy we don't want to occur. Otherwise, all our small nursing homes in the rural and the small setups will suffer. Most important is change of user. Many places the change of user because the hospital comes under a commercial or a semi-commercial category, and then the applicable laws are differing. So these small hospitals provide basic healthcare infrastructure of state of Maharashtra. So they should be exempted from that. Residential zone should be allowed to have the small hospitals because ultimately, whom are these hospitals going to help them? They are going to help the needy patients in and around. And if the hospitals are not allowed in the total residential, where those patients will go? So we have told them that this should be a small hospital should be definitely allowed in the residential zone area. So these are the some of the section 22.11 states. All details are there. The polyclinics, diagnostic center, dispensaries should be permitted to use in the residential zone. Otherwise, many times places it is said that in the building where all the residential is there, you cannot have this dispensary, dental clinic, physiotherapy, because ultimately these are the small people who help in and out of the healthcare. Everybody cannot run to the 5-star or a big multi-site. They don't need also. So they go to these small nursing homes, small hospitals, and also this should be permitted. Use of residential premises, as I mentioned, in Mumbai especially or in big cities nowadays, the 1 or 2 floors are taken in the building by the hospital or nursing home. So they should be allowed, they can charge some change of user fees, but they should be given. So what we requested that in the cities, when they are purchasing at a very high price, this change of fees should be very minimal, or the premium should not be taken too much from the hospital. So they should be waived off. That consideration should be given. Another major important issue what people are facing nowadays is the fire safety. And again, as I mentioned in the just now, that small places, district collector or the civil surgeon and the fire safety officers of that particular municipal corporation or a city or a metro city, everywhere the different rules are applicable. So we have time and again, in fact, Mangesh has been after the this various authorities. He has written kind of a small complete data analysis that which area should be given, and we repeated again that fire safety act and the small hospital should be definitely looked after as a separate measure. Every fire safety act hospital should be possible wherever it is there, but IMA HBI stands with all the safety of institution. We don't want to abide and dislodge other safety activity. Understand that, but then at the same time, the too much stringent rules should not be applied to the hospitals. IMA HBI request to have option of mass purchase of market for all the hospitals in state to minimize the financial burden on the small hospitals. And we have already written to the government that we as a Maharashtra state will take initiative and bringing this entire mechanism of fire safety help to the small hospitals in toto. Again, requirement of fire safety devices differ, installation differs, water supply, pump capacity, everything is different in small areas. So all those will have to be tackled separately, especially hospitals below 45 feet or 15 meters and 5 floors. They should be given some benefit, some the stringent action should not be taken against them. Minimum extinguisher should be allowed to for these hospitals, because most of the hospitals you will find that these are below 45 feet in a small area and in the cities as well as the rural areas. So this is our projection was there. We also found that the equipment purchasing has been very costly. The overpricing was there. wherever the kind of agents have their monopoly of distribution agents and retailers and all those things. So we requested that fire safety equipments are being forced to be brought from the specific agency. So we said that government should standardize some agencies, government should notify, and then how like a government, the tenders and all those things work, so the prices comes down. Recently, you must have seen regarding a simple N95 mask, it varied from 25 rupees to 200 rupees. So similarly, all those equipment should be given to the small nursing homes at a comparatively rate, and IMA HBI will help to see that MAR purchases will occur, and the government at the same time hospitals will follow the rules and regulations. Training of doctors, because this is very important. Just having a fire safety is not sufficient. We had said that the hospitals and doctor staff in that, particularly IMA HBI, will undertake the training of those things. Fire audit, there are two issues. One is fire audit B form and fire audit is A form. Fire audit B form, 6 monthly fire audit is approved by the agency, shall be granted. Notification of all government Maharashtra also state the same. But civic bodies at many places, they say compulsory audit every now and then, which has caused unnecessarily corrupt practices, and which definitely we have objected to that. Another thing is fire NOC by fire officer, A form, which I mentioned, A and B. A form or a fire NOC by the fire officer is for new establishment for the first time. And old establishment, they will not be able to have a fire, this A form certificate. So those should be exempted, and it should not be forced by them to have a NOC every year or every renewal, because nowadays many hospitals and many places we found that such registration and renewals were objected and they are held up. So we requested government to definitely look into this category and help the small hospitals. This has created a very big round of corruption all over the state. Every small IMA members are aware about that. Hospitalization issues. In fact, previously, Dr. Mangesh has already taken a big lecture on this hospitalization issues and renewal issues. There are n number of certificates, n number of forms. As I mentioned, from the fire, oxygen, BMW, and other things are there. So we would request them, when they are bringing in the Clinical Assessment Act, this should be one window procedure, one window. Everything should be come under one window. Doctor has to practice. He doesn't have to go anywhere from place to place for getting this registration and renewal certificates. So these are the major issues, hospital registration issues, which we have told the government to simplify. Now another one big law which has recently amended, and still some things are not very clear, but some judgments have already occurred, saying that the CPA to 2020 or 2019, which came and forced into 2020, that previously when the CPA came about 20 years back, we IMA did fight a case in the Supreme Court, but unfortunately lost. And then subsequently, you see how the prices and how the control and the corruption and the violence has erupted. All this because of the consumer protection. And now with the consumer protection in the parliament, there was a discussion that the CPA is healthcare sector will not be applicable. But unfortunately, in the act, there is no clarity that the healthcare is exempted. There is no exact word that healthcare is not exempted. So there is a difference of opinion. IMA is definitely working on that, and in the near future we'll come to know whether this CPA is applicable or not, because that's why we are going to study some cases in the consumer court, in the lower court, to understand whether the consumer is taking up this cases of the CPA to 2020 new cases. Now new laws are going to come for the telemedicine 2020, because you have seen that recently Niti Aayog, at the onset of this pandemic COVID, they introduced that the teleconsultation and definitely the practice of not examining the patient by touch. As you know, all these years, every doctor is examining the patient by touch. That's the most important thing. That counseling or satisfying the patient that he has been really examined, is happy. That telemedicine 2020 is going to change the entire scenario. Some restriction will be there, and some clarity still needs to become. So we need to have that. This is one of the major factor, that legislation is going to affect the clarity of on the regarding the medical legal issues, regarding the consent, what treatment will be admissible, what kind of doctors can, up to what level and doctors will be protected, and what level doctor should tell them and stop that. Yes, now here onwards you have to come in person or you have to go to your neighboring doctor. In this telemedicine, there is another big issue which we are going to face is there are restriction on a doctor who is registered in say particular state, and the patient is not from that state, but he is from the other state, and then he can does the telemedicine consultation, and whether if anything occurs wrong, then where he will file the suit. So that clarity has still not occurred. The same thing in telemedicine, what we are facing about this consent as well as the medical legal issue, same will occur in the CPA 2020, because the person who is in his native place, he can go and file a suit against the doctor who has treated in Mumbai or Nasik or Pune. So that is going to be a big hurdle for this, which will be, this legislation is going to affect us. Biomedical waste, this big thing is going on. In fact, yesterday only we had a very big meeting and we presented lot of issues to the government, and the government department, CPCB, is sympathetic to us. Dr. Mangesh again yesterday presented very details, especially the registration in the biomedical regarding the effluent sewage treatment plants, how to go about it, other things. That still clarity we are expecting from the government. But this legislation is going to affect the entire scenario of hospital management tomorrow, because small hospitals will have to increase the charges. They will have to follow this effluent treatment, and you know how this biomedical waste management takes place. In one of the major issue which we discussed yesterday was the website and the barcoding. They want entire thing, barcoding and website and entire labeling also as per the central agency, and which is going to affect the small hospitals pertinently. And we have already presented our case to them. Let us see what is the outcome out of that. As you see the amendment in Pandemic Act, which I mentioned. Why I'm mentioning? Because in the morning we heard about the violence against doctor. We thought that during the COVID, our doctors are going tremendously working. They are under pressure. They are working out of the way. They are using extra duty hours. They are treating, and we have seen almost 525 doctors have succumbed to this COVID, and which is a much higher percentage, as Dr. Ravi mentioned in the morning. And during that time, if any small mishap or something occurs, you must have also seen a lot of videos, regarding that the patient is alive or the treatment is not done properly or dead body is there and all those things. So this violence against doctor during the pandemic while treating, the government gave some immunity, but we have seen that still the violence has occurred in this thing, and this legislation is a must for us for enforce upon the government, particularly state, because state government is not doing anything. Their act, which was there in 2010, has got hardly any tooth and nail, and we need a central act on this legislation of this amendment, pandemic as well as non-pandemic time of treatment of the hospitals. Other recent issues which I mentioned on morning also, it was mentioned regarding the price capping. The price capping means they have almost regularized the two kinds of hospital rates, right from your normal bed, oxygen bed, ICCU bed, and tertiary care hospitals, non-COVID. During the COVID treatment mechanism, they have also regulated the non-COVID rates, and there already some cases have been filed in Nagpur. And as Dr. Ravi mentioned in the morning, IMA Maharashtra has gone to the much larger bench, and much larger the hearing will take place soon. And we have appealed to the government. We have collected the entire data of the entire India, almost 6 states. What are the rates applicable there? We have almost data from the Tamil Nadu, we have Andhra, we have Kerala and Gujarat, and all those rates, and we have given what are the insurance rates, and then we have given it to the government, and let us see what outcome occurs out of this case. Again, insurance issues, the legislation will mention that insurance should be clarified, because many schemes of Rajiv Gandhi and other things are coming up. What about those insurance, whether the doctors, small nursing home hospitals, whether they'll be benefited? So we had requested the government that they should not have the NABH entry level accreditation program, because otherwise those all will be not able to participate. Government is looking into that. STP, ETP, I already mentioned. regarding the hospital sanitization. This was the main clause in accepting various insurance issues and as well as the this various government schemes. So we have told them that right now they are a little bit liberalized regarding the standardization, but then this legislation also is in the offing. And the last but one listing the electronic data recording. Already you must have read in papers that the government has introduced the digital health mission, and digital health mission, they are going to collect the entire data of the every patient being treated either in the hospital, nursing home or a big hospital, and ultimately that data, how and how they will be useful, where they'll be useful, that its clarity is not there. IMA has already opposed this digital health mission, and but then it is still in the pipeline. The bill has already been tabled in the Lok Sabha. It is not implemented. The rules and regulations have not come. We are awaiting for that, but we'll take up whenever any issues come up. So these are the legislations which are going to affect the hospital, and that is why I appeal every member that you take the help of the big body like Indian Medical Association, which we have insurance help. We have the doctors private public insurance, that wherein we our doctors we protect through the IMA, that is the professional protection scheme. Social security scheme of course is there. So I thank the organizers, Dr. Rajendra Kulkarni, Dr. Mangesh Pate, and national our past president Dr. Ravi and Dr. Bondwe. Thank you very much.
Thank you, sir. Thank you for your excellent lecture and the very much informative about the new laws and legislations on the horizon. For the time constraint, I request the delegates to put their questions on the chat box. We'll send it to the speaker and can be addressed later. May I now request Dr. Dinesh Thakre, who is a doctor and an advocate and a journalist and a management trainee and what not. He's a very, very active IMA member and IMA activist. He will be deliberating on the topic of how to build up a medical legal shield for a small hospital. Over to Dr. Dinesh Thakre, please.
Okay.
Yes, please go ahead.
Thank you, Kulkarni sir. Today's topics, delegates, is how to build up a medical shield for a small hospital. When Dr. Rajendra Kulkarni sir called me a few days back and asked me to speak on how to build up medical shield for a small hospital, I started thinking on it as to how can we do it for on mass scale, because all the small hospitals should get benefited. And again, the shield should be practical and easy to implement at the ground level, because the things discussed in webinars, they should be easy to implement. Then only there is some point in that. Then I appreciated that we face many issues other than medical legal issues on daily basis. So I thought the shield should not only be a medical legal, but rather a proactive, all pervasive, and a multi-pronged shield, which can protect us from all sorts of attacks, about which Dr. Ravi sir was talking about, Dr. Lile sir was talking about, and Dr. Pate sir was talking about, which we face in our day-to-day practice. So what are the challenges, current challenges in our practice? There is a rise in lack of trust. There is a rise in expectation about hospital services. The services may be medical and also non-medical. Rather, the expectation about non-medical services is on rise. Then rise in litigations, and again violence. It may be verbal abuse or physical assault. There rise in amount of compensation awarded by the courts. Now it has gone in crores. Then again, there is a rise in quantum of penalties and punishments for doctors in various acts. In the present acts, they are increasing the quantum of penalties and punishment, especially for doctors. And then draconian legal provisions in newly enacted. Whatever newly enacted acts are there, the legal provisions are more and more draconian. And on the other hand, we do learn ways to handle variety of such assaults and the assaulters also. When we attend the talks by our medical legal experts, communication skill trainers, various authorities, hospital management experts, etc., at the various conferences and webinars like this. Everybody want to be medically safe. We want a sort of medical shield around us. We also understand that if we practice the advice given by these experts, such practice will shield us from medical issues. But we are unable to take practical benefits out of medical talks and advices. Thus, in the given hostile environment, the reasons for deficient medical shield around us and our hospital lies within our responses and behavior. Let's see how. A. When we rejoin our duty, our daily routine practice on Monday after coming from the conference, we could hardly follow anything that we have learned in the conference. Reasons: multitasking. A doctor already has so many various types of work to do, especially in a small setup where is a one doctor or two doctor setup. It is very difficult to do all the things. Then, if we want to keep a employee, that we can't afford a special employee who has received a training from the experts, who can understand the legal jargon and who can understand the terminology and maintain a good documentation. It is very difficult. And most important, there is always a belief that a medical issue will not happen at my hospital. My patients respect me, etc., etc. And it is found that some doctors continue to do the same things even after they come to know that they can be penalized and punished for that. Fourth, therefore, doing some expenditure or being medically complacent or safe seems futile for most of us. Friends, medical issue is like an accident. The severity is not perceived unless and until it actually happens with the person. You will agree with me. This is our society. Thank God the whole isn't on our end, but we fail to appreciate that it will be a doomsday for us also. Again, medical issue is like a coronavirus, infecting a person who believes that he will not get infected and don't take precautions. So what happens? Then on one day he comes positive. And please note the change in behavior of that non-believer in coronavirus pandemic. I say that same is the case with the doctor facing medical issue. Now, reason B is for litigation against doctors, most common causes are deficient documentation and insufficient communication. 90% of the delegates will say that we know this. What's new in that? Everybody knows, yes. Well, what do we actually do to improve it? Whatever one has learned from the experts in the conferences, you need to refresh and update that knowledge regularly. And it also helps in maintaining the high determination needed to practice and implement it. It is like a battery. We get charged in the conference and then after 8 days. So we need high determination to practice and implement the things so as to be medically safe. And unfortunately, some doctors do not accept that they need a training to prevent or to anticipate or to tackle medical issues or medical incidents of violence or legal orders. They just fail to understand this. Next, all of us know that compensation awarded in medical negligence cases comes in crores. Most of us knows. But how many among us have an indemnity insurance cover or have a sufficient indemnity insurance cover? That is the question. Most important fourth point is bad mouthing about own colleague. It is a major reason for rise in litigations against doctors. This also all of us know. But what do we do to stop such known habitual bad mouthers in our city? Nothing. Next, uncertainty about what verdict a random judge gives in a particular case against doctor. No one can predict. Cases in the lower courts are overturned in the higher court, and even the liar cannot predict. We are not sure on which evidence, on which documents the judiciary will definitely rely in that particular case. That is the major dilemma. Therefore, the verdict of sentencing a jail for not signing an F form under PCPNDT Act surprises us. Same is the case with removal of provision of penalty of rupees 10,000 for frivolous complaints by the central government in the new CPA 2019 Act about which Dr. Eliezer was talking about. So we are supposed to be the most intelligent professionals, is it not? But we don't seriously find ways to defend ourselves strongly enough. That is the reality. Now see this video, we react like this cat to all types of attackers, and therefore they are overpowering us. Just watch. See what the mouse is doing and see how the cat is reacting. So we are the cat in today's situation. And now see this video. This is what we are, and we should react like this lion. We have to uphold our own values, our own self-respect, our prestige and position in the society. Watch. See what the lion has done. It is his natural things. We know during this COVID-19 pandemic, government officials, non-medical government authorities are teaching us the medicine. It is very ridiculous. And then there is a mismanagement for which they held us responsible. तंग आ गए अब हम तो रोज आते सरकारी फरमानों से, हमने तो सरकार बनाई थी कितने अरमानों से. So true. When we are trying hard to control pandemic and treat the new infection, we ourselves are confused and trying hard and doing all those things. But what does the government do that like that mama in the picture? Government intimidates us to cancel license, to cancel hospital registration. They want to audit our bills. They want to cap the quantity of oxygen to be given to the particular patient. That boy is playing there with his friend, and his mother is saying, "अगर गिर गया तो टांगे तोड़ दूंगी." Next, society expects self-regulation from some professions like medical profession, judiciary, defense forces, and airlines. Now the question is, do we exhibit our practice of self-regulation like other 4 professions do? Judiciary, defense forces, and airlines. They do exhibit their practice of self-regulation, we don't. Then what is the way out? What is the solution? How can we improve upon the issues discussed above? Hospice shield. This is some shield which can protect us from all the points I discussed above. There are 7 ways by which we can form a multi-pronged hospice shield around us and around our hospital. Let's see how we can do it. First, make good documentation and training of staff an integral part of daily practice. You must have heard this at least 100 times, 50 times, and agree to it also. But what about implementation? How can we do it? If we as an association can hire good quality science graduates, appoint them as hospice shield executives, and train them on the work, which work to be allotted to them as discussed in work allotted to the hospital shield executive below. So there is some work that will be allotted, to these executives, and they should be science graduates. Suppose if you have a 9-bed hospital and a hospital executive visits your hospital and say every Thursday and does the following work. Once in a week, every Thursday, and does the following work. Just think over how much remuneration would you like to give him. Just do the work, just appreciate the work, and then think about the remuneration. So what are the works allotted to the hospital executives? Check all OPD and IPD records. Now here is the problem. Here is the problem or mentality. Someone science graduate will check my OPD and IPD records. But we have to change here. You will find out lacunas in documentation and get it corrected from you. So this is rather a delegation of work. He is doing your work. And what are the common mistakes we find? Like missing signatures, stamps, incomplete consent forms, incomplete discharge cards, incomplete IPD notes, and timings of prescription orders and timings of dispensation. are not matching. Why I took these examples? Because these are the most common deficiencies found for which the court penalizes. So what other work he can do? Check all non-medical records and other documents to be maintained under various acts. There are so many acts and under which you have to keep various records. Yesterday we took a webinar on sexual harassment of women. Then if there is no committee or you are not reporting the district authority, there is a punishment. And I am sure 95% of you are not aware of this. And how many regulations, acts and specific legal provisions are applicable to us? Just guess. Dr. Lele sir has told us. They are more than 130. We are just unaware. And as Dr. Vankekar sir told us, that ignorance of law is no excuse. Dr. Uttare sir usually tell this, that ignorance of law is no excuse. You just can't say that I was not knowing. Then what should he do next? Train the hospital staff on the issues under the heading of the staff. Training of the staff is very important, but we don't get time to train the staff. Even we don't know what to train. What is their problem? So this person can train the staff. Next, meet the patients and relatives and ask for their grievances and suggestions. Again, here there will be a issue of some mindset that the third person will meet patients and relatives and ask for their grievances and suggestions against me. That will be a problem. But we have to be prepared for scrutiny by the third parties. And this will just a trial. You will check the complaints on suggestion box. Many hospitals skip this. Sort out the issues to be addressed and convey them to the doctor and get it sorted. Then he should attend phone calls from allotted hospital for queries related to his work. Work we know. And rush to the hospital in case of any medical legal emergency or incident of violence. This is the most important. And check whether everything related to his work is correct and in place. Because he will be the person who knows everything. What are our weak points? What are our strong points? Which staff is making which mistakes? He will be so trained that on documentation part, on counseling part will be rather safe. Now, training of the staff. The hospital executive will train hospital staff during the course of his work on following points. I have taken some important points only. Relevancy of a particular type of record. That is, which form is to be used in which situations. Correct entries in various documents. There are a lot of mistakes in documents. Correct entry of timings of dispensation of drugs. This is again a major issue. Communication techniques with patients and relatives. When and how to give feedback to the concerned doctor. Especially pre-violence period. The feedback received from the staff is very important. That which relative is saying what. And all other related points as per directions or as we will discuss or we can tell you. Now my question was, how much remuneration will you give for a 9-bed hospital? And if you have 15-bed hospital, he will visit twice a week. For 9-bed hospital, he will visit once a week. For 15-bed hospital, he will visit twice a week. How much remuneration would you like to give him? And if you have 50-bed hospital, he will visit 6 days a week, full timer. How much remuneration would you like to give him? Now, let's expect, this is my expectation, that you will pay him at least 1,000 per bed per month. I written sanctioned because that is a legal point. So you will pay 100 if you agree that I will pay 1,000 rupees per bed per month. So for 9-bed hospital, it comes as 9,000 per month. For 15-bed hospital, it comes rupees 15,000 per month. For 50-bed hospital, it comes 50,000 per month. And cycle will start from the first day of each month. One hospital executive will devote 1 hour per bed per week. This is for calculation, just for details. And hence, for a 9-bed hospital, it comes 9 hours a week. Means 1 full day per week that I was talking about, like just every Thursday or every Monday like that. For 15-bed hospital, it comes 15 hours per week. Means 2 full days per week. And for 5-bed hospitals, it comes full week. That is all 6 days will be your full day employee. And one hospital executive will be allotted, or may be allotted up to 50 beds only, depending upon the capacity and willingness. So after completion of a month, bifurcation of the duty days will be duty of the 4 weeks, that is 24 days, 4 Sundays off. Okay. Then important is that you will get 2 or 3 training days, as the next cycle will start from first of the next month. So out of rupees 1000 per bed received, maximum share will be paid to the hospital executives, right? And what to do about the balance share? Balance share will be utilized to arrange intensive training sessions for them. So whatever work he is doing for you, you will be trained for that. And the executive will be trained for 2 to 3 days every month about the work they are doing at the hospitals allocated to them. This training will help them to do the allotted work professionally and to train and update the hospital staff on the points which we have already discussed. Now, which will be the faculties to train the executives? Our own members who are expert in a particular topics, our own leaders, medical legal experts, communication skill trainers, biomedical waste management agency person, you will directly train, relevant government authorities like chief fire officer, police officers, and other relevant experts. They will take training on this. Now, the second prong of the hospital shield is make good communication an integral part of daily practice. Again, everybody knows this. How to practice? You will have to identify such staff members who have good communication skills. We will further train them in communication skills directly or through the executives I was talking about. So the staff will be directly getting training about the communication. Third prong is training of doctors enrolled in hospital on following points. Now again, the training of doctors, issue comes that do you need training? Yes. On which points you need training? Documentation skills. I talked on how to keep good communication. Not on what documents you should keep, but on why to keep. That is why is important. Why to keep good documentation at a Dhule and Chandrapur. It will teach you maximum monitoring in minimum time. Third prong is training of doctors again about communication skills. Most intelligent doctors may not be good communicators, but the famous doctors definitely are good communicators. Then important. Previous two things we know, good documentation, good communication. Now the third thing is prevention, anticipation, preparing for, handling, and post-event response to and medical legal situation or event or emergency. You will be trained in this. Then again, fourth important point, you will be trained in prevention, anticipation, preparing for, handling, and post-event response to incident of hospital violence. In this also you will be trained. Then again, interactive sessions with authorities, like all the authorities under various acts, law implementing agencies. Again, IMA PPS schemes office bearers, Dr. Anand Kate will be talking after me. Then judicial personalities, journalists, lawyers, social reformists, public figures, so as to get the perspective of other strata of the society, other people of the society, what is their perspective, what they want, and what can be done. Now, fourth important prong is enrollment in IMA PPS schemes. In this modern era of consumerism and with no cap of compensation to be awarded by the District Consumer Commission as per CPA 2019, every doctor needs indemnity insurance. That is a must now. Such insurance cover from our own association is always better. As I told, Dr. Anand Kate sir is going to explain in a short while. Please listen to him carefully. Fifth prong is medical jostling prevention cell. Medical jostling means criticizing the treatment that a patient has undergone so far before consulting you. It is responsible for 90% of court cases and some incidents of violence against doctors. The bad mouthing is very common. So what should this medical jostling prevention cell should do? Of bad mouthing. Listen to, warn the accused member if found guilty, and recommend action against to be taken to the general body of the association. Note that if this cell works efficiently and the general body of the association supports it, no member will dare to do bad mouth. and many incidents of violence and allegations, and thereby harm to trust and faith of society on the profession will avert. It's worth giving a try. Please think of. Sixth prong is legal order study committee. This committee will work on the focused manner, in a focused manner, in detail, to understand the modus operandi of politicians, modus operandi of authorities, judiciary, media, police, and public. What is their modus operandi? On the basis of the better understanding, it will suggest ways to tackle each of them in a given situation. It will suggest such changes in practicing medicine which may either nullify or minimize adversities caused by a particular legal order. Seventh is self-regulation. I talked on the topic role of self-regulation in tackling challenges in medical profession at Bengaluru and Chennai sometimes back. So exhibition of self-regulation I was talking about. Now see the airlines, they charge so much but nobody complains because they exhibit self-regulation. They show the sense of responsibility. They show the teaching from entry, and for them every passenger is king. They show like that, and even a small mistake may prove fatal. They show like this. Then again exhibition of self-regulation by defense forces. Prove patriotism, sense of responsibility, teaching from the entry, harsh penalty on violation, violation is shame public. So they exhibit their self-regulation through these processes. Again, next is judiciary. Acknowledges its fiduciary position, always sense of responsibility, teaching from entry again. So that is a show of self-regulation. They exhibits it. And if we don't self-regulate ourselves, someone else will definitely come to regulate us. That is true. This someone may be any Tom, Dick, and Harry that we are witnessing. We have to make our medical practice society oriented with obvious, deliberate, and transparent disclosure of empathy and self-regulation. That is my quote. It appreciated by many of my friends, and specifically Dr. Ravi Shankar sir, the head of our medical cell. Now the media, politicians, police, public, and to some extent judiciary treat us like criminals who violate laws and norms. They paint us as professional law violators, high profile criminals, like a driver in this car. They equate us with the criminals for this level, living in other strata of society. Now see this policeman, traffic police is wanting to stop this car because violation of the traffic rules. See what does the driver is doing. The media paint us like this driver that we are violating we are doing bad with we are inhuman. We are doing bad with the patients and authorities. Don't follow anything. Now see this video again. Next video. In this, the first car driver is not overtaking the cow because two continuous yellow lines on the road means do not cross the line. He is following this, and there is a kilometer-long queue, but no driver is trying to overtake. The point is that they all expect this level of self-regulation from medical fraternity in India, wherein every other professional will definitely try to overtake in such situation. Please see the video. See the cow. The first car driver can easily cross that yellow line and overtake the cow, but he is not doing it. Will this happen in India? But they expect such regulation from us. Otherwise, you are a criminal. You are crossing the yellow line. What about all other strata of society who is crossing the yellow line regularly? Now see, there is a 1 kilometer long line, but no driver is crossing. So the self-regulation is a journey of self-regulation, and together we can do it. Not only doctors, but lawyers, the managers of various sorts, the reporters, the governments, and the police, all should do self-regulation. But what happens? ये बंद कराने आए थे तवायफों के कोठे. ये बंद कराने आए थे या आते हैं तवाई के कोटे मगर सिक्कों की खनक देखकर खुद ही मुजरा कर बैठे. This is the reality of these people. So what are the take-home messages? It's high time to build up a shield around us and our hospitals. Not only medical shield, but all pervasive multi-pronged hospital shield. Only we will have to do this for ourselves. No one else will do. First message is make a good documentation and communication, integral parts of our daily routine practice. Involve staff into this and train them adequately. Delegate this work to well-trained and well-paid, updated hospital shield executives. Get trained and be updated yourself on skills of documentation, communication, handling medical issues, and incident of violence. Say have a sufficient indemnity insurance cover. Take curative steps to stop bad mouthing. Then study modus operandi of politicians, authorities, judiciary, media, police and public, and plan our moves accordingly. That is the only solution. Self-blaming we should stop. Self-regulation is the key element. Remember, it binds all other 6 prongs of the auspice shield and makes it stronger. Higher the level of self-regulation you practice, stronger is your auspice shield. And we may discuss in detail about the auspice shield. There are many other unique features of it which I have not discussed here because of time constraint. This is eternal truth that all it takes for evil to triumph is for good men to do nothing. So let's do something good. Thank you, all of you.
It was very informative lecture by Dr. Dinesh Thakre for having a good medico-legal shield for a hospital, for a small hospital. Friends, we are running short of time, so we will be skipping the lunch break right now, and we will reschedule the program.
Dr. Rajendra Kulkarni was rather just announcing that we have rescheduled the program. Now there will be the panel discussion, which was rather scheduled after Dr. Kate's lecture. So after the panel discussion, there will be Dr. Anand Kate's lecture.
I request all the delegates that we have rescheduled the program, and there we are starting with panel discussion. Current affairs of hospitals panel list. Dr. Ashok Adao sir, Dr. Ravi Wankhedkar sir, Dr. Shiv Kumar Uttara sir, Dr. Avinash Bondwe, Dr. Mangesh Pate. The chairperson will be Dr. Vinay Agarwal sir, and moderator Dr. Rajendra Kulkarni, the organizing secretary. So please take over Dr. Rajendra Kulkarni sir. Is it okay? We are discussing on current affairs of hospitals. A panel discussion. I hope all have joined.
Welcome. I am a past national president, Dr. Vinay Agarwal sir. Welcome to Hospicon, Mahahospicon 2020. Sir, we are really glad to have you with us for today's this panel discussion. And really your motivating work has always been a guideline for us for all the activities in state of Maharashtra as well as the other all the IMA branches. We welcome you on behalf of IMA Maharashtra State as well as these IMA Hospital Board of India. Dr. Rajendra Kulkarni is at IMA Nasik. There is some electricity problem, and so I request Dr. Mangesh Pate to say a few things before he joins. He'll be joining in a short while.
Dr. Vinay Agrawal sir, on behalf of IMA Maharashtra State, our President sir, Bondwe sir, we all welcome you to this Mahahospicon sir. We are so lucky to have you as a chairman for this very important panel discussion. Very soon, past national president, Dr. Ravi Wankhedkar will be joining in a couple of minutes time. Bondwe sir is already there. Lele sir is there. The panel discussion will start in just 2 minutes. Please bear with us. Thank you, sir.
With the permission of the chairperson of this panel discussion, Dr. Vinay Agarwal sir, which is the past national president and a guiding force behind IMA headquarters all the time. And we are very fortunate to have him as a chairperson, sir. You are welcome to Mahahospicon 2020. The other panelists for this important panel discussion on current affairs of hospitals are Dr. Ravi Wankhedkar sir, Treasurer WMA, our State President Dr. Avinash Bondwe sir, Dr. Ashok Adad sir, the past National President, will be joining us in a short while. Dr. Jayesh Lele sir also will be giving his inputs, and our dynamic IMA Maharashtra HBI Chairman Dr. Mangesh Pate. Will be
Dr. Anand Kate sir is also there, Raja Babu.
yes.
And of course, Dinesh Thakre is there.
Dr. Dinesh Thakre is also there. Dr. Prakash Marathe sir is there.
Yeah.
So we'll start with the one issue after another. The most important issue is when we start a hospital, we come across with problems of hospital registration. The hospital registration in Maharashtra, we do it under the Bombay Nursing Home Act. Though the act is applicable to the entire state, and it is supposed to be same to be in the implementation as well all over, but still it is implemented or rather interpreted differently at different places. Why is it so? I request all the panelists to opine. Maybe we'll start with Wankhedkar sir.
As I was telling all my esteemed participants and leaders, that this Hospital Board of India is the baby of our mentor, Dr. Vinay Agrawal sir. And today we are so fortunate that we are having the person who delivered this baby during his presidency, nurtured it, and has brought to this level. We present to you, dear friends, Dr. Vinay Agrawal sir.
Thank you, younger brother Ravi, and thank you, Nasik branch as well as Maharashtra State branch and the Hospital Board of India, Maharashtra State. Dr. Ravi Wankhedkar, past president of Indian Medical Association and honorable treasurer of the World Medical Association, a dynamic leader of Indian Medical Association. My dear friend, Dr. Adhav, Dr. Uttare, Dr. Lele, Dr. Avinash Bondwe, Dr. Mangesh Pate, Dr. Kulkarni, Dr. Kate, and Dr. Dinesh Thakre, and many other my colleagues. It's a privilege for me to attend a program of Nasik branch and particularly by Hospital Board of India in a conference. I was amazed by the hard work which you all guys have done. I'm surprised to see that about 2,500 persons are attending this seminar. This speaks about the hard work done by our predecessors in Hospital Board of India from 2011 onwards. Ravi has been one of the functionaries. Today, Dr. Monga is heading it. Mangesh and Lele has done a wonderful work in taking it to where it is. Our Secretary General today, Dr. Ashokan, has also been associated with this, and many other stalwarts who have really sweat hard to see that Hospital Board of India reach to today's situation. If I take it before 2010, the only thing which was lacking in Indian Medical Association was a connect with hospitals. We connect with the small hospitals, connect with big hospitals, and even the connect with corporate hospitals. I'm sure Hospital Board of India today has filled that gap. Now we are addressing the issues related to our hospitals, our small hospitals, our commercial establishments, our clinics, our diagnostic labs, and all those, which probably was a little beyond the scope of Indian Medical Association before 2010. I'm really happy about it. There is a lot has been done and lot has to be done. I always say that why should we make segments and why should we leave few segments? Indian Medical Association is a fatherly body to take care of everyone, from its starting to medical students, starting to junior doctors, family physicians, consultants, specialists, talk about small hospitals, big hospitals, or corporate hospitals. Still, we are allowing few of the, heads of very corporate bodies to head various corporate organizations, whether it is, business-oriented organizations or anyone. I personally feel, and my request to our leaders of Hospital Board today, that is Dr. Lele, Dr. Monga, and Dr. Pate, and simultaneously Ravi also to take lead to see that this sectionalization of these hospitals should not be there. Even the corporate hospital should look towards us, look towards Hospital Board of India to see that their problems are addressed too. I'm really happy that you are addressing today in this conference wonderful topics. They are the common topics which bother everyone. They are the topics in today's circumstances of this COVID-19 era, which everybody is concerned about it. Like this panel discussion today on current affairs in hospitals, in today's situation, or in today's atmosphere, is a very, very pertinent this thing. And let me tell you, the faculty which you have are having today is not a faculty of related to only Maharashtra. It is a national faculty, internationally renowned faculty. This faculty has made marks not only in India, this faculty has made marks internationally. This faculty has made marks in our statutory bodies, whether it is Maharashtra Medical Council and Medical Council of India or now National Medical Commission. A lot of these representatives are there. And my all good wishes to the organizers, particularly you, Rajendra Kulkarni. You have done a wonderful job in organizing this. Dr. Mangesh Patel, Lele, and all others have done a wonderful job. Collecting the galaxy of speakers like Ravi, like Dr. Adhav, like Utre, on the same platform with all Avinash and Mangesh and everyone for a small topic, which is very, very pertinent. Hats off to you, Avinash. My all good wishes for the success of this discussion, success of this seminar, and success of this conference. I want the replication, duplication of this conference and these seminars in various parts of the country, in various cities, whether type 2 cities, type 3 cities, where Hospital Board of, everybody should know about Hospital Board of India. Everybody should know there is an agency which talk about us, which fights for us, which is for us, and which takes care of our problems. With that particular aim that we are for you. We are of you and for you. That should be the motto of Hospital Board of India. My congratulations once again goes to Rajendra, again to you, to everyone. My all good wishes for the success of this discussion. Thank you. Thank you so much.
Thank you very much, sir. Vinay sir, as usual, you are crystal clear and very articulate and very encouraging. Your words always encourage us to work more. Your experience from being a family physician to a small nursing home owner to building a 450-bedded tertiary care center, you are really, I mean, a gold mine of experience. Not only for Hospital Board of India, but for Indian Medical Association also. And we wish on behalf of IMA Maharashtra a very, very healthy life for you. And keep guiding us, keep inspiring us, sir.
Thank you.
Go ahead, Rajendra.
Thank you so much. Thanks a lot. Thank you.
Kate sir, can you please answer the question on registration?
Thank you, Vinay sir. Thank you for your blessings and for your kind wishes. We look forward for the same guidance and blessings all together in the rest of our life. Thank you, sir. So we were starting with the first issue of registration. Bombay Nursing Home Act is same all over the state, but it is interpreted and implemented in a very different way in different places. So why is it so, and what can be done for that? Kate sir, please. Dr. Anand Kate.
I think though the act is same, the corporation has got powers in itself which can change, say, the registration fees for the registration that can be decided by the corporation. So it can vary from place to place. But even in this, the corporation has to take concurrence from the state government if they want to increase the fees or change the fees in the Bombay Nursing Home Act. Then various interpretations are different, because some corporations, they give you a registration for 3 years, some corporations they give you a registration for 1 year, because probably they are not aware of the amendments that have been made in various laws. We have to bring all those amendments to their notice, and then convince them that this is to be given for 3 years, and of course they can pass their own changes. like municipal solid waste, charges for municipal solid waste, they also differ from place to place, because the corporation itself can levy, and they can levy those charges on yourself. So they can vary from place to place, and they cannot be uniformly. But if a comprehensive act which is passed by the Maharashtra state legislature, which can give all these things are clarified and given uniformly city wise, say A grade city, B grade city, or C grade city, in that, if that is passed and very clearly mentioned in the act and the rules, I think this confusion which is prevailing all over the state will be prevented.
Okay. So in short, there has to be a comprehensive act which should detail about the grade of city and town, and accordingly the rules should be.
What charges should be levied in particular grade city? What charges? What solid waste charges should be levied? What renewal charges should be levied? And what are the requirements according to that city should be clearly mentioned in the act and the rules.
Yes. Mangesh, would you like to add something?
I will just tell one basic fact. A crux of this issue is, I hope everyone can hear me. There is one clear-cut statement in the Maharashtra Nursing Home Act, Registration Act, that the civic bodies, which are denoted as the competent authorities by the state government, they have been levied with the authority to formulate the rules and regulations which are as per suitability to the civic bodies. It is mentioned in the Maharashtra Nursing Home Act. Because of this one sentence, all civic bodies, they are removing the subjective meaning of Maharashtra Nursing Home Registration Act, and they are applying this to local hospitals. And that is the basic issue why there is no uniformity across the state in various civic bodies as far as nursing home registration is concerned. And the second point over here is that very recently, since long time, Indian Medical Association has been fighting against this CEA, Clinical Establishment Act. Now, what government is doing, that the two things, number one, Clinical Establishment Act, as well as the Urban Development Act rules. These two things, government is trying to implement, give it a backdoor entry by parallel linking it to the nursing home registration. And that's why what Kate sir has said very appropriately, various issues which are surfacing various civic bodies is because of these two things.
Just want to make one comment.
Yes.
As Dr. Patel sir has said that the rules and regulations, they are in the hands of the local bodies or competent authorities. But the act proper, when they are changing something in the act proper, it is not allowed. In the act, it is written that 3 years, 31st March of after the 3 years. And some of the local authorities are asking for renewal every year. I think if we can fight on this and make it from 1 year to 3 years, the hospitals in that particular city will be relieved much.
Okay. So also is the case about the fire safety norms. The fire safety norms is the latest addition, the stringent act and regulations for the hospitals. And it has been very difficult, especially for the old nursing homes, which have been running for last 20-25 years, but now they are denied hospital registration renewal. And even if for the newer hospitals, they are having trouble with getting NOC from fire department and get that B form renewal every 6 months. There is definitely tremendous exploitation being done by the agencies. Can we do something as HBI on this front? I would like to have an answer from none other than the chairman of HBI, Dr. Mangesh Pate, to avoid such kind of exploitation and to have clarity of views and for our members. Mangesh, please.
Okay. See, there are two issues as far as the application of the Fire Safety Act is concerned for the hospitals across the Maharashtra state. Number one, as mentioned very categorically, various civic bodies are compelling the hospitals for the fire NOC from the competent authority, that is the local civic body fire officer. This is point number one. And point number two, as you mentioned, for the older hospital to comply with the whatever fire norms they are asking for according to 2006 amendments in the Fire Safety Act, which is not possible for the older hospitals. This is the second issue. On these both issues, IMA Hospital Board of India, we have met last year with the Director of Fire Services Maharashtra State, and we have very categorically mentioned that it is not possible. On the first issue, he has very specifically mentioned, giving the reference of the three notifications from the government of Maharashtra, there is no need of no objection certificate from civic body fire safety officer if your hospital is going for renewal of administration. Fire NOC from the civic body fire officer is needed only and only when you are registering your hospital for the first time. After that, lifelong, every renewal, you are supposed to have only B certification, which is from the government approved fire safety agencies. There are total 502 fire safety agencies across Maharashtra, and we have got a complete list of fire safety agencies. Before this lockdown, through IMA Hospital Board of India, we tried our best. Even Dr. Dhakre was there in this, that we want to locate 4 or 5 agencies depending on the regions of the Maharashtra, and we want to give through Hospital Board of India contract to these agencies with the minimum charges. They will be fitting the equipment to various hospitals, and also they will be carrying out every 6 monthly fire audit of these hospitals in the ministerial charges, and the trouble of hospitals will be waived off. As far as second point is concerned, application of the fire safety norms which have come amended in 2006. For example, there has to be 20,000 liter of a tank, overhead tank. For the older building, it is not possible. These all points we have categorically raised with the fire safety, the Director of Fire Services, and he has agreed upon that we will address this issue in consensus after talks with the concerned ministry, and we will find a solution for this. Unfortunately, this because of COVID pandemic, we could not follow it over the last 6 months. But as soon as the conditions is out, definitely this second point also we will find out the answer to it and we will address it. First point, we already have the solution. There is no need of a fire NOC from the fire officer of the civic body whenever you are going for the renewal of the hospital. If any civic body, any hospital, any doctor, there is a compulsion for the NOC again and again every time for the renewal, kindly get back to the IMA Maharashtra State Hospital Board of India. This has been told to us none other than the Director of Fire Services. He said he will issue the notice to the concerned fire officer if he is troubling the hospital. We have put this all across the Maharashtra state to Dr. Bhodwe sir before this pandemic started. I think this answers both of your queries.
Yes. So the fire safety norms, the renew at the time of renewal, you don't require any NOC from the fire officer. That is the key point you have mentioned, and that is very reassuring that you mentioned that if there is any problem, you contact IMA Maharashtra State HBI, and that point will be taken directly to the Director of Fire Safety.
Yes.
Another important issue is of BMW. BMW is not the luxury car, but the biomedical waste, which is always already haunting us for last 20 years. And again, there have been amendments in the BMW management rules of late. So what are those rules and regulations, and how are they going to affect small and medium-sized hospitals? I request our panelists to throw light on that. So Dr. Kate sir, can you start it? Anand Kate sir?
No, I think Mangesh would be a better person.
Okay, Mangesh.
Okay, as far as biomedical waste rules and amendments are concerned, these rules came in picture in 1998, and till date there has been 4 amendments. The latest has been 2019. The 2016 rules, the 2018 and 19 amendments, there is one thing which is very common, and it has been the crux of the issues all across the India. That is the compulsion of the STP and ETP plant. Though there is no direct mention of a compulsion of STP and ETP plant, there is a mention of a one sentence in this amendment that all healthcare establishments will have to abide by the rules and regulations of the liquid output discharge by 31st December 2019, which has gone last year. The meaning of this, every state pollution control board has removed that all hospitals, it is compulsory to fit their own personal ETP and STP plants. This very issue has been raised by the IMA Hospital Board of India with the Central Pollution Control Board. Not only that, we have given a detailed presentation to Honorable Union Minister Sri Prakash Javadekar, and he also agreed upon that this is not fair for the to compel this ETP and STP plants. In what situation hospitals are there all across the country, and he has accepted. And in front of us, he called up chairman of Central Pollution Control Board, and he has told you have to negotiate with the Indian Medical Association and Hospital Board of India and take a solution out of it. Yesterday morning itself, we had a meeting on this issue. Again, in that same meeting, they agreed upon this that it is not fair to compel for the ETP and STP plant. The crux of this issue is that it has come from the floor of the Lok Sabha. So IMA headquarters is trying that we will put this on the floor of the Lok Sabha and get it sanctioned as an amendment that the hospitals, which are SHCOs and HCOs category, they should be exempted for the compulsion. And another paradigm which is kept for this compulsion of ETP, STP plant is that number one, the hospitals which are connected to the local sewerage connection system, that is a common sewage collection system and a common effluent collection system, they should be completely waived off. The hospitals which do not have such a collection to the civic body collection system, on that those hospitals also, if hospitals have got a liquid output discharge less than 100 KLD, they will be exempted. This we have put yesterday in front of Central Pollution Control Board. This is the main issue. I want to say one more thing here, very specifically related to this. Many hospitals, after compulsion from the civic bodies, they are erecting this ETP and STP plant. I will request everyone, let us fight together. Do not run after the civic bodies. We are fighting this at the highest level in the country, and we 100% will reach to the solution of this compulsion of STP and ETP plant. Another thing, as far as biomedical waste is concerned, is the categorization. We have been successful in getting the healthcare establishment out of the red categorization, and we also have achieved that the healthcare establishment will not be categorized at par with the industry. So HC hospitals are now categorized as a non-industrial, in the non-industrial zone. That is a very big victory. What is the benefit of just getting hospitals out of the industrial zone or out of the red categorization is that if the hospitals would have been in the red categorization or in the industrial categorization, it would have been compulsory for hospitals to undergo the inspection, vigorous inspection by the State Pollution Control Board or the regional pollution control authorities. And you all know how bad it is when these people come for inspection. It is just for the namesake, and what all we have to go through, hospitals have to go through is for such inspection. So all hospitals are out of the ambit of this red categorization and industrial zone. So hospitals will be undergoing the inspection from the regional this officer every 3 to 5 years, not before that. That is a very big risk. Another thing about this is that barcoding and this thing, we have very not website posting is the responsibility of the common biomedical treatment facility transport agencies, not the individual hospital. We have provided solutions to them. There is a for tuberculosis one app, Nikshay app, where we are supposed to register, and whichever TB case comes to us, we are supposed to register that case over there. On the same lines, we have told the Central Pollution Control Board that through their state pollution control boards, they are supposed to have one common website where the transport agencies are supposed to upload every day how much biomedical waste is collected from every hospital. So this clerical work also we are taking away. This load is taking away from the hospitals. That will help our hospitals. And last point is the environmental compensation charges. Many hospitals have been fined by the state pollution control authorities for a simple error that not reporting or not pre-treating or not, or suppose some needle and syringes are found instead of the yellow bag, you find it in the black bag. The hospitals are fined with the lakhs of rupees. This point was raised. Any such issue is found with any hospital, we have stated that the hospital should be sent a notice. They should be given a warning and not fined directly. And CPCP has agreed upon the same. They have agreed to take a further meeting after a month's time or so. Till then, we are trying that to reach out the minister again to take some solutions for this biomedical waste issue. I think it covers all the issues of BMW.
Yes, Mangesh. Uh, Thank you for a very elaborate reply and which explains all the queries. And I think the highlight is you have been working like IMA and HBI is working at the highest possible level, like the CPCB, that is Central Pollution Control Board. And the biggest victory, I suppose, is that the removal of a hospital from the red category. I think it has saved lakhs of rupees of all the small and medium-sized hospitals all across the country. We must appreciate the work done by IMA HBI, and we are sure that you will carry on that work again henceforth. Now the current burning issue is that of COVID-19. The pandemic has taught us many things, like that in panel discussion only the Kapil Jepay sir has mentioned very nice way, and it has raised quite a bit of issues also to the hospitals. Government has capped the charges of the hospitals. Government has put 80-20, 50-50 regulations, keep the hospital beds reserved for COVID. So we have been fighting all through at the level of state government. So I would like to have the fight given by IMA to be elaborated to all those delegates which may not be aware of that. So I think the best person to listen to this fight is our state president, Dr. Avinash Bondwe, sir. So please tell us about this government capping and what IMA has been doing and what we are looking forward and the response from the government.
Yeah.
Bondwe, sir.
Thank you, Rajendra. As soon as this uh, lockdown was declared and all the other things were announced, the first thing that we have been constantly in struggle with the government of Maharashtra at every point. In the beginning, the government was saying that all the hospitals and clinics, private hospitals and clinics are closed. So that time also we informed government that there are no IMA doctors have kept his clinic closed. We are doing all the telemedicine practice, and most of them are keeping their clinics open for a certain timing, and all the hospitals are working. So that was the first incident. After that, in the month of May, the government of Maharashtra, through their secretaries, they took a meeting of all the IMA representatives, and we had a discussion in which there were some problems we put forth, like PP kits and other thing. There also we put forth our problem that this renewal of hospitals under Bombay Nursing Home Act, which was accepted. But in the same meeting, the government rather appealed us that this is a COVID situation, and most of the Maharashtra is being affected very largely, and so we will be requiring the private doctors' help. That this is the time where you should not think about the charity, and you should think about the sacrifice. This was the appeal which we took, and in the best view, rather the best in the best view of all the common people in Maharashtra state, all the poor people in the Maharashtra state, that the charges will be regulated. They said that it will be for 2 months. So with dissent, we accepted it in this our commitment towards the humanity, and all those things started. At the same time, we had a discussion, and we found out that most of the charges were not very low, except for those charges for the ICU without ventilator and ICU with ventilator. And we found out all the reasons for that, and they were not rather affordable to most of our small and medium level hospitals as well as the big hospitals. And we rather studied all the factorial, all the rather the factors which reach to that bill, and we found out that they are not affordable. And a presentation was made, rather analysis was made by Hospital Board of India, that what are the proper charges. At the same during that time also, there were so many orders and notifications and legal notices sent to our uh, doctors as well as many of our hospitals that they are doing such thing and all those things. At many places, we rather talk to the government officials and rather inform so many government officers, collectors, and the divisional commissioners that such things had to be done in a specific way. When the 80-20 hospitals were taken, rather the was taken over by the government of Maharashtra, there was no mention that how much how many what is their cutoff line of the hospital beds, whether it's 30 beds, 40 beds, 50 beds, and nothing was done. We insisted that any hospital to be declared as COVID hospital should be inspected as per the national and international norms which are given for the COVID hospital. Because a COVID hospital definitely requires something like disinfection parts, the ventilation, and other the trained staff. In spite of that, the government of Maharashtra took over without realizing the importance of these norms. And ultimately, there were so many problems with the government also. After that, once these rates, the last date was given as the 31st of August. And that's why we met government of Maharashtra on 11th of August, and we had a long discussion. Dr. Mangesh was with me. Dr. Utture sir was, of course, was there. Dr. Pingre sir was there. And we rather convinced the health minister as well as the director of medical health that these charges are not affordable. We, of course, mentioned the amount of oxygen which is required for any ICU is the far greater, and we asked them to rather cap the rates of the oxygen. Then again, the charges which were given rather for rather we require for the extra staff and other things were discussed, and the government accepted. We also showed that the neighboring states like Gujarat, Karnataka, Andhra Pradesh, they are giving more charges to the hospital. The government has accepted for the higher charge. So everything was settled, and uh, uh, the government rather pointed out, was minuted, that the rates will be increased in next meeting, and with the help with the discussion with IMA Maharashtra, the representatives of IMA Maharashtra state. But somehow on 31st of August itself, after reminding them again and again, the government not only not only the increase the charges, but they cap the charges again with a very severe stringent norm, that the charges of the PP kits were also included in that. The charges of the investigations and medicine were also investigated or other implemented in that. So it was really unaffordable for all the hospitals, and we gave an ultimatum of 3 days to reconsider, which was not accepted. So we went into a fight, which was a legal fight, which was a rather a democratic fight, that we did. First, we had a meeting of all the presidents all over the Maharashtra, and we explained all the things. We always believe that the things are done by the are rather first they discuss some negotiations and should be done. Then only we can go ahead and take a we can struggle with the government, or we may go into court of law. But since the government did not respond to our negotiations, so that time we declared some few actions, like we had rather one day every branch was there, and they had all those COVID martyrs were offered the prayers and uh, all those things. And after that, we collected the registration. We told the government that this thing we are not affording your charges. So take back this registration. All these things were not responded by the government. And so we, 3 days back, the Indian Medical Association, Maharashtra State, through our HBI board, we have rather filed a case. We have filed a petition in the Mumbai High Court, and all these things are being done. I assure you, at every place, the IMA Maharashtra State has given the first importance to the safety and to all those problems which are faced by our members as well as all the hospitals. Secondly, we never wanted to go against the advantages or against the well-being of our patients, of the society. And third most important thing, we never wanted to do any sort of rather taking back our words or going back to our actions. We have always fought for the betterment. Along with that, there were so many incidents where of violence all over, and IMA Maharashtra State through our action committee and all the hospitals, we have negotiated with in every incident, though it may be two big incidents one in Malegaon and Nashik itself, two incidences in Latur, then in Beed, then Aurangabad, Pune, at so many places. So all the time, IMA Maharashtra State Hospital Board of India has worked for the advantage or for the best interest of the our members, our hospitals, all the doctors, and we have never forgotten that we have some commitments to the society. So with considering all this, we have always fought, and I'm really thankful that all the members of IMA Maharashtra State, all the members of Hospital Board of India has always supported and given their blessings to all these activities. Thank you.
Yes, sir. Thank you for your elaborate response. And IMA has been working in the interest of the common member and the small and medium-sized hospitals all through in this pandemic. Because we know your entire tenure of your presidency has gone with managing this pandemic and other problems related to pandemic. In view of that, you mentioned about the PPE and all those things. Initially, the vendors of PPE kit and N95 all exploited us like anything. For a N95 mask which we purchased from IMA headquarters at 36 rupees per piece, we all have bought it for say 300, 350 rupees also in the beginning, and that too were substandard masks. So can we have some kind of like bulk, like what we did in N95 mask? Can this activity be replicated in future also, like staff supplying agencies or software providing vendors and consumables all can be purchased at mass level at the lowest possible rates? Can this activity be done under the banner of HBI, Dr. Pate?
Yes, definitely. Since our own Dr. Ravi Wankhedkar, when he was a national president, this idea was floated that whatever regular requirements of the hospitals are there, and number two, whatever equipment is required by the hospitals, and number three, the AMC which is required for the equipment of the hospitals, these all can be floated through the Hospital Board of India in the minuscule charges, as the same way what we are trying to do it for the Fire Safety Act. We are dealing with the few agencies, giving them a mass contract so that all hospitals are benefited. On the same lines, we are working on this through Hospital Board of India, and I am just hoping for in the near future we will be successful in launching this type of common purchase, mass purchase, and passing that benefit to the all member hospitals through Hospital Board of India. Definitely.
Okay. Okay. In this COVID pandemic only, in the beginning and even today, we are hearing from our politicians, our people's representative and the administrators that do this thing, do that thing, otherwise we will cancel your registrations and all those kind of threats. So I think Wankhedkar sir was an MMC member and very much studied in all these things. So sir, please explain us where it is doable for the administrators to cancel our registration at just the drop of a hat.
Absolutely not. I think by now it is absolutely clear to all the members that nobody but the person, the body which gives registration has the authority to cancel that particular facility. So whatever threats government of Maharashtra or even courts can't cancel your registration. That authority lies with only the registering body, that is our state medical councils. And that is why don't be afraid of the threats given by any collector or commissioner or any other authority that your registration will be cancelled. They can't do anything. Even cancellation of the registration of hospitals under Mumbai Nursing Home Act is not that easy.
Okay.
So be very, very sure that if any such incidents happens, please contact your local branch of Indian Medical Association or the state branch. And Dr. Bondwe, Dr. Mangesh, Jayesh, Kate sir, everyone is always available. Thank you.
Okay. Thank you, sir, for these reassuring words, because our members have been under constant threat of this.
Dr.
Unmesh sir,
Rajan,
would you like to add something? Yes, please.
yeah, no, just on a lighter side again, as Dr. Dinesh Thakre had shown one cartoon that two boys were sitting on a high wall and their mother is giving them rather a threat that khali hai tujhe tangdi modi. Just like that, the government of Maharashtra has been threatening all our members. And initially, we really were afraid that because our registration is everything for us. So if the registration cancellation is done, then we are nowhere. That's why everybody was having off. We had a discussions with Maharashtra Medical Council officials and this thing, and even with the government. Even we have talked to the health minister that this method is not good for how the way you are threatening, the way you are sending the messages like a summons to some criminals. All this thing is wrong. They accepted it verbally, and till now, I must say that till now, because of our pressure and our talks, not a single registration of any member has been suspended. And there were so many doctors have got these type of notices. Even I got one myself that your registration will be cancelled. But nothing has been done, and nothing will be done unless you do some, you can say some very unethical thing or something like that. Yeah. Thank you.
So on this line only, our registration is given by our Maharashtra Medical Council. Till last week, the Maharashtra Medical Council was under Medical Council of India. Now with that, NMC is in place, National Medical Commission. Will it affect any way on the functioning of small and medium-sized hospitals? Dr. Wankedkar, sir, please.
NMC, the act has been notified. Medical Council now, as a body, is not existing. It has been replaced completely by the National Medical Commission. To be fair, National Medical Commission will have no effect on functioning of the existing small and medium-sized hospitals. But we doctors will now come under the ethical obligations of National Medical Commission, like previously we were coming under the Medical Council Act. So what kind of new ethical regulations the National Medical Commission comes out with, that has to be seen. But again, let me very firmly reiterate that National Medical Commission, coupled with National New Education Policy, is going to produce hybrid doctors. The pure modern medicine practitioner will vanish by in next 10 years. Mark my words. Worldwide today, India is known to produce best quality doctors, very excellent clinicians, and that is why all our young doctors still get an opportunity in all the developed countries also. With NMC in force after 2030, even Pakistan will not accept the degree or recognize the degree of India if it is through the National Medical Commission. So basically, it is anti-student legislation. There has been an extensive as you mentioned about the state medical councils, previously the state medical councils and the Medical Council of India had a very loose sort of relationship. It was not binding on the state medical councils for to obey the directions of the Medical Council of India vis-a-vis the registration issue. Giving registration, cancelling registration was the entire purview of state medical councils. But in the National Medical Commission, in section 38 is clearly mentioned that the state medical councils are 100% bound by the directives of National Medical Commission. So this one single sentence has over-centralized the powers in the hands of the National Medical Commission. So it is anti-student, it is anti-federal, and because in the section 51, 52, section 26, section 31, 30, all these are going to create quacks. There is a massive promotion for mixopathy, and not to state, but 50% of seats will now be filled by the management. The previous management quota of 15% is now minimum 50%. And even for the rest of 50%, the government or the NMC shall issue guidelines which will be non-binding on the private medical colleges. So don't be surprised that even 100% of seats will be filled not on merit but on money basis. Now henceforth merit will have no value, only and only money will have value under National Medical Commission. They will be producing substandard hybrid doctors which will be competing with you and me who are pure, ethical, normal doctors, and thus resulting a total upheaval in the medical field which will affect all the even small and medium hospitals. Thank you.
One,
Thank you. Yes, sir.
Yeah, one thing I would like to add, Dr. Ravi, that the government of India has done very smart actions. All these things of mixopathy are included in our NMC. At the same time, the government of India has come out with a national education policy, which also includes all these things of that they are saying that it is mentioned in that national education policy that there will be the courses of other pathies in modern medicine and vice versa. So these things are really in future. All of us will have to rather raise our voice and fight against this at whatever way. We know that with the demolition of MMC and this NMC came into full existence from the 25th of September 2020, and our hands are tied. But IMA has to fight, and IMA has has decided to fight it all over India against this, and that is definitely going to harm the hospitals and their private hospitals and their future, definitely.
Thank you, sir.
Just
Uh,
can I add a comment?
Yes, Dinesh.
Previously, the cancellation of registration issue used to go to the MMC, and MMC had the powers, as rightly said by Dr. Wankadkar sir. And the issue of appeal to the MCA was not much taken up. And in MCA also, the decisions of MMC or the State Medical Council used to got upheld. But now the appeal is to the NMC, and you know who are sitting in the NMC. And to the surprise that if you are agreed by the decision of NMC, the appeal is to the central government. The natural justice to go to the court of law has been blocked. Thank you.
Further ahead, a very good point which Dinesh has told. Previously in Medical Council, even though the appeal was with the Medical Council of India, Medical Council of India is to take a decision and send it back to the State Medical Council to reconsider. The final decision was still with the State Medical Council. The second thing, which in the composition of National Medical Commission, they have made it an advisory body and a body of 25 people. But in practice, these people who go from various states have no authority at all. The entire authority rests with the 4 autonomous boards, which are labeled as autonomous, but they are not autonomous. They are all government employees which have been appointed on the boards. Say, for example, this issue of registration and cancellation of registration comes to the ethics board, where the appointees are not any elected member or some private practitioner, but director or dean of some government institution. And these boards have the authority. And if anything, the biggest concentration of power in National Medical Commission is with the secretary, not with the president of National Medical Commission, but with the secretary of the National Medical Commission, who is a appointed authority by the central government. A bureaucrat appointed by the central government holds the total power of the National Medical Commission, and rest all the operational and executive powers are with the 4 autonomous boards. The actual 25-member NMC body and the 60-member advisory council are just there for namesake, which was not there previously with medical council. So it is a totally undemocratic body. Thank you.
Okay. Thank you, sir. So NMC and the new education policy, as you mentioned, is going to make a cross-pathy as well, encourage cross-pathy, and is going to make the medical education very costly as well. Taking this clue of the costly affair, even you have your own small nursing home, Mangesh has his own hospital, I had my own hospital, and all those delegates today who are attending this conference are mainly small and medium-sized hospital owners. Even running this small and medium-sized hospital has become very costly these days for so many reasons. So will you suggest anything which will help in managing the good finance of the small hospital? Ravi sir and Mangesh sir, Ponve sir.
It is a fact that the golden era of doctor-owned nursing homes, or what we officially called as own account enterprises, which used to form the backbone of especially the secondary healthcare in this country, that golden era is slowly going away. They had a free run up till now for last 50 years. Minimum of regulation, and people were having faith because they were giving personalized care. Even though today the picture looks bleak, I am very sure, I am not cynical, that a time will come back again where personalized care, personalized healthcare is the new thing which is coming worldwide. It is in fact our concept that each patient is different. Each patient may require different approach. Each patient may require different drugs in different dosages. That person-centric care which was offered by this friendly neighborhood nursing homes or hospitals, which I always use this word as a friendly neighborhood nursing home, providing 24/7 affordable, accessible, accountable healthcare. They are facing lot of problems. To survive, we have to adopt good ethical practices, good financial practices, good technology has to be adopted. And the most important thing, I think, is to have group practice. The future of private practice and small and medium hospitals is in group practice. In all aspects, synergize. Say, I am a surgeon running a nursing home for the last 25 years. Even if I used to operate 3-4 cases per day and a very, very fantastic OT with lot of investment, 3-4 hours the operation theatre get used. Rest of the time the operation theatre remains vacant. This is a waste of resource. Hence, I think we all doctors should try and come together and start our own group practice, which not only synergizes our energy, our resources, but also the burden is shared. You are psychologically, mentally more peaceful. But saying all this, even the tertiary healthcare, big hospitals, let me share with you, all of them practically are running in losses. Their maintenance cost becomes so huge that after a certain point of time, half of the big chain of hospitals, especially those who have sprung up in last 10 years, are in running losses with big reserves, or companies which are having other businesses are only able to sustain. So again, I will say I am optimistic all the while that our golden era, though it appears to be going away, it will come back again. Thank you.
Uh, Dr. Rajendra,
Yes, sir.
one a small good thing which happened because of the IMA National's effort, that the medical sector or health sector is included in MSME. Dr. Lele sir is there. We can talk because it includes the financial support to the hospitals. Dr. Lele sir, if you can talk about that. Dr. Mangesh.
Mangesh, you can
I think Dr. Kate sir runs 2 successful nursing homes, and we all would like to hear his inputs on the future of nursing homes.
financial management, especially, sir.
I agree with Dr. Ravi that though we are losing Shin and the small hospitals are going out of the favoritism, I think there will be a time again when we will come back with a good, yeah. But one thing I can say is, though we are saying that there is no future for small hospitals presently, but I think still people or a majority of population, they prefer to go to small hospitals, or as Ravi said, the friendly neighborhood hospitals. They prefer to go to the hospitals because they are available 24 hours. They are much cheaper than the corporate hospitals, and you get a personalized care. One thing I would like to tell is to maintain this or to say that the small hospitals stay in the run is that we should manage the small hospitals as the corporate hospitals manage corporate hospitals. So we should learn from them how to manage a hospital financially, equipment wise, as well as the patient management wise. You have to see and you have to avoid wherever there is a excess spending in our hospital. See to it that only proper utilization of all the funds, proper utilization of all the departments, proper utilization of all the equipment is done, so that the you don't lose a lot of money in all those things. Proper utilization of the staff also is very important. You should have only the limited amount of staff which is exactly required. You don't need to have a lot of extra staff with no work around. And the most important thing, of course, in a private hospital, a small hospitals, you have personal relations with your patients. Transparency is another very important thing. Be transparent with the patients in all the things, as as to management as well as financial aspects of the billing and everything. If you're transparent, you minimize the chances of violence, you minimize the chances of looting and all other hooliganism in your hospitals. I think that is a very important thing which one has to do when managing a small hospitals. And it is, I don't think the small hospitals will totally vanish from the scene. Most of the local people, they do prefer small hospitals in their neighborhood for routine illnesses. It may not be tertiary care, it may not be angioplasties or bypass surgeries or whatever, but for normal illnesses, for maternity and child health, I think small hospitals are preferred and will be preferred for a time to come.
Very, very true, Kate sir. Transparency and ethicality are two cornerstones in the long term success of running your nursing home. Don't go after what you say a herd mentality or a sheep mentality, that or some peer pressure, and try to do things beyond the limitations,
Yes.
inbuilt limitations of a small nursing home.
Yes.
Stick to secondary healthcare. You need
Exactly.
not have then your input cost will be less, your operational cost will be less. You don't have to face huge EMIs. I have seen young budding, very smart young postgraduates falling and building up huge loans on their head. And once you are having a pressure of EMI that I have to earn 4 lakh rupees per month as my operational cost, then whether 10 patient comes to you or 100 patient comes, then you tend to venture into the unethical area of
Yes,
practice.
exactly. Then you try to do all sorts of malpractices.
Yes. So my humble request, transparency, ethicality, and know your limitations. Thank you.
Thank you.
Thank you. Thank you, sir. So you all have given a very nice ray of hope in the dark cloud of dwindling financial turnover of the small and medium-sized hospitals. We are hopeful that it will continue to survive. These hospitals will continue to survive with given the ethicality and legality is observed. So we are actually watching a very turbulent and changing era. So I would like to know from Ravi sir whether this similar kind of change had happened in the previous years in the developed countries as well, because we are a World Medical Association treasurer, we are an international
Exposure.
exposure. So from that point of view, what had been the history of healthcare system in the developed countries how they have come today?
See, if you will see the history of healthcare system in the developed countries, one thing which we deferred, where we changed track, was we lost the public healthcare system. Since independence at 1947, 80% of people used to take treatment from government hospitals. Kate sir is there, Bondwe sir is there, many other senior people must be there, doctors. Where even in say GMC Nagpur or Sassoon hospitals, good class of patient is always used to come. But in last 70 years, the ratio has exactly changed, where only 20% people take treatment from the government hospitals. This change of trend which happened in India, it was exactly reversed in the developed countries. They always strengthen their public health infrastructure. But the second change which affected especially a country like United States of America, which has one of the highest percentage of spending of health vis-a-vis GDP, that is around 17 to 18% of their GDP spent on health. But they have accepted a model which has shown its fallacies and now is considered a failed model, which is an insurance-based model. So the American system of insurance-based healthcare delivery has pushed USA on the 11th position in all the health parameters worldwide. Even though they are number one spenders as a GDP, they are much behind than the European counterparts, where the public health infrastructure is much more stronger. The insurance-based model, which was accepted by America, and very sad to say that Indian government is copying very wrongly the insurance-based model. See, try to understand one basic thing. The insurance-based model is for the maintaining profits of the insurance companies. Insurance companies are not interested in neither in the doctors nor in the patients. They are only interested in running their company with profit. And that is why this model has failed. Even if you will see the communist countries or the socialist countries, they are spending much more on their public health infrastructure. In a continent like Africa, where they supposedly spend least amount of money on health, because of their inbuilt constraints of money. If you will see the COVID figures, the latest crisis, the entire African continent numbers are less than what India has. The entire African continent altogether has less number of deaths than what India has. Forget America. Why this is there? Because they have a robust public health infrastructure. And why did they have a robust public health infrastructure? Because all were, if you go into the history, all were colonies of European countries. And the Europeans, even if we decry the colonialism and the empires, may it be French, Dutch, Portuguese or the British Empire, all were present, all had colonies in the African continent. They created a robust government health infrastructure. That legacy continues there. We also had that legacy. Unfortunately, over 70 years, we lost that legacy, and now we are entering in a more worse phase of insurance-driven healthcare. So basically, we will have to find a midway between the public health infrastructure and the private healthcare sector. We really can't rely on totally private health sector. I, a member of the private health industry, is making this statement with all due responsibility. There has to be a judicious mix of government health infrastructure and private health infrastructure. And it should be government funded health care delivery system, not government paying an insurance company and trying to deliver it through private healthcare. Because the insurance based model, again I will repeat and remember this statement, it is not beneficial neither for the provider nor for the beneficiary, that is the patient. Thank you.
Thank you. Thank you, sir, for the global perspective, which I intended to have in this question. And you have categorically also given your opinion about the public healthcare system, which needs to be strengthened, even though we all are private practitioners. That is very good of you, sir. Thank you. Now, as the time is going short and we are running, we are just completing this panel discussion.
And just to make 1 minute.
Yes.
Just a minute comment. Very good overview by Dr. Wankhedkar sir. And what I feel is that we are heading towards the insurance-based system. I feel that here is the role of organization, where when our government is following America or the insurance-based system, we should hold our small hospitals as far as possible, give them support and promote them for group practice, and whatever support or backup they need. If we can do this for coming 10 years, then as told by Dr. Wankhedkar sir, the era of personalized care will again come back. Just we have to hold it all these things for 10 years, I feel. Thank you.
At the end, I would request every panelist to give us a take-home message. Like, see, in today's era, patient expectations have changed. They have risen to a new high level. So what a small and medium-sized hospital owner should do? Just a one-liner, please. What a small and medium-sized hospital owner should do to rise up to the expectations, the changed expectations of the patient. Ravi sir first.
I have already spoken on this topic: ethicality, transparency, and knowing your limitations. But I would take the liberty of taking another minute with your due permission. That whatever experiences, whatever narrations you have heard through the panelists, again I would like to reiterate whatever I said in the morning, that whatever we can achieve is to achieve through the unity of doctors and through our organization. The issue of biomedical waste is such a complex issue. The issue of fire safety is a complex issue. The issue of registration of hospitals is a complex issue. Though we have not achieved any success, but whatever little success is being achieved by showing our unity and going through the organization. I personally know that many individual hospital owners try to manage issues at their own level, say a fire safety issue. Rajabhau, you know it very well what happened in Nasik.
Yes, sir.
Individual doctors approach and try to settle issues at their own level, which ultimately weakens the strength of the organization. So, be with the organization. It is the only way where we can together fight the government, the media, or all the regulations. That is my take-home message.
Bondwe sir, one line message for the small and medium sized hospitals.
Join Hospital Board of India and find out all the essential things to survive today and tomorrow. That's all.
Thank you. Anand Kate sir.
I would also say work within your limitations. Be transparent. Don't cheat your patients.
Okay. Dinesh Thakre.
I will repeat the same quote, which is like most of my colleagues. We have to make our medical practice society oriented with obvious, deliberate, and transparent disclosure of empathy and self-regulation. Thank you.
I think Mangesh Pate has left.
No, I'm there. There is problem with my video.
Yes, yes. So we are you are audible to us, Mangesh.
Yeah,
Just give a message to small and medium sized hospital owners.
I feel I will choose whatever everyone has said. Ethicality is the first thing.
Yes.
Second thing, we have to know our limitations. Third thing, I will add that our hospitals should not run in the rat race, which is harming to the entire medical fraternity. That is most important. And last, but the most important, it is only IMA and the Hospital Board of India, which is going to be a savior for the small and mid-sector hospitals. So my wish, and maybe I can say my advice to every hospital owner, that at the earliest join Hospital Board of India and let us unitedly fight whatever problems we face. Thank you, sir.
Thank you, Mangesh. And I thank all the panelists, Dr. Wankhedkar sir, Dr. Bondwe sir, Dr. Kate sir, Dr. Dinesh and Dr. Mangesh Pate sir for the excellent information you all have given us. And I again appeal to all the delegates attending this conference to join Hospital Board of India to address all the issues related to hospitals and to come out for legal, ethical, and practical solutions from all the problems which hospitals are facing today. Thank you all. Thank you, the panelists. I hand over the mic to Dr. Rajan Sancheti to start next lecture, that is on PPS by Dr. Anand Kate sir.
Thank you.
Sancheti sir.
Next talk is by Dr. Anand Kate sir. Sir is a consultant physician, AMA General Hospital, senior consultant in critical care of Wockhardt Hospital, Nagpur. President IMA Nagpur branch 2005 to 6. Founder co-chairman of IMA PPS. Chairman PPS since last 5 years. Delivered CL Javeri oration in state conference in 2007. Receptionist of best secretary and best president of big branch at state and national level. I don't think I have to tell anything more because sir is well known. Sir, please take over. Thank you.
Thank you. Thank you, Dr. Sancheti. First of all, let me thank IMA Nashik team, Dr. Rajendra Kulkarni, for giving me this opportunity to present for you. Am I audible or not? Hello.
Yes, sir, you are audible. Go ahead.
Thank you for giving me this opportunity. I must thank Dr. Bondwe sir also, who has been very instrumental in designing our new scheme. Respected Dr. Ravi Wankhedkar, past national presidents and other office bearers of Maharashtra state. This PPS is a scheme of IMA Maharashtra state, which is one of the schemes like in a social security scheme and the professional protection scheme. These are two very important schemes of IMA Maharashtra. Why can't I move the slides? What is professional indemnity? This is, one should understand, professional indemnity is an insurance plan which is there to financially safeguard the medical practitioners against legal cost claims for compensation by the patients and in case of a legal row. Legally, it is an exemption from liabilities for damages. It covers any legal case arising due to injury or death of a patient due to the omission or act of commission or negligence or error of the insured person. The premium depends on the limit of indemnity and the risk group of the doctor and the ratio of limits. The jurisdiction of the policy is limited to Maharashtra state only. The professional protection scheme was first started in the state of Kerala way back because, as we all know, the state of Kerala had a very high litigation rate against the doctors. And in Kerala, there are almost 100% of the members of IMA are members of the PPS, and this scheme became very successful. And because of the success of the scheme and because of the very well running of the scheme, the litigation rate had drastically dropped down in Kerala. Gujarat also is running a very successful professional protection scheme. There is a national professional protection scheme also, which is being operated from Trivandrum. Friends, most of us, we have insurance or indemnity insurance with some of the other insurance companies or some of the other associations of our specialty associations. But the insurance companies only take care of the financial part of the litigation. They don't take care of the doctor's reputation, which is spoiled when a case occurs or when some adverse publicity occurs. Insurance companies are very eager to do out of court settlements, and if you do an out of court settlement, many people think that because you were guilty, you accepted the out of court settlement. Lawyers provided by the insurance companies are not experts in their field in the dealing with the medical negligence cases, and onus of providing expert opinion rests on the doctors. And the experience of most of the doctors with the insurance companies is far from satisfactory. So IMA decided to start its own professional protection scheme. It was started by IMA Maharashtra State Branch for the benefit of its members. It is an autonomous scheme of IMA MS with the head office at Nagpur. The scheme started functioning from 1st July 2008. All the life members of IMA can become members of the scheme. A member can enroll in the scheme by filling in a form and paying requisite amount of fee, which consists of admission fee and annual fee. The fees depend on the participant speciality, and the cover starts on the first day of the next month. There is no refund which is admissible to any members on discontinuation. If any members wants to rejoin the scheme after discontinuation, he has to rejoin as a new member. All medico-legal risks arising out of activities in surgical and diagnostic camps and all activities outside the state of Maharashtra are excluded from the purview of the scheme. The scheme is not responsible for any act of a member for which she is professionally not qualified or professionally inexperienced. Continuation of membership of Maharashtra State Branch for the entire period of coverage is mandatory. The scheme does not provide any indemnity cover for any act of a member which is against the law of the land. A general practitioner having a nursing home and admitting his own patients will treat medical cases up to his own qualification level. That is true for all the specialties, and a hospital should be responsible for all the consultants to be member of the scheme. For legal disputes between the member and the administration, the jurisdiction shall be restricted to the courts of Nagpur. Members doing MTP must get their nursing home hospital registered with the government under the MTP Act. Similarly, members must get registered with all agencies mandatory by the law like Nursing Homes Registration Act, PCPNDT Act or the MTP Act. If any member furnishes any wrongful information in this application or furnishes any wrongful information at any time during his membership period and thus tries to obtain any benefit under the scheme, his membership shall be terminated. Now, what the scheme does for all its members? The scheme will provide a legal defense in civil, criminal case before the medical councils, consumer grievances redressal forum and courts. It will provide a reasonable expense for bail procedures in case of arrest arising out of professional criminal negligence. It will pay fine arising out of professional negligence within prescribed limits, that is 10 lakhs per case or 20 lakhs depending on the cover which the person has bought. It will provide a list and addresses of telephone numbers of office bearers and panel lawyers selected by the scheme. In the event of medical legal problem, the members shall inform the office bearers or counsel of defense of choice from the panel of lawyers which will be provided by the scheme. The members will provide medical record exactly describing the evolution of the case and keep a copy in safe custody. They will avoid making any oral or written commitment without the specific permission of the scheme and hand over all original documents or Xerox copies demanded by the legal counsel. The scheme provides legal defense in case of medical negligence, civil or criminal cases, or cases in medical council, or cases in consumer fora or various courts. It provides reasonable expenses for bail. It pays fine. It pays settlement arising out of the civil courts. If a member so desire, he can engage his own defense lawyer at his own cost, which shall not be reimbursed by the scheme. Such lawyer shall assist a panel of lawyers in defense in which the decision of the panel lawyers will be final. These are the rates which were prescribed according to various specialties, but in my next slides I am coming to the new rates because we are in a process of modifying the scheme, which I will be coming in the next few slides. During the course of our period of 12 years, we introduced certain new features. Our scheme, we gave discounted annual membership fees to the first 500 members. We gave 10% discounts to the first 500 members which are enrolled in the scheme. And we enhanced the cover for C2 category from 20 lakhs to 50 lakhs. We had also signed an MOU with the National Professional Protection Scheme for the payment of settlement for members who are members of both the schemes, that is state PPS and the national PPS. And we had established a coordination between the NPPS and the Maharashtra PPS for representing members in the higher fora or the courts, that is the National Forum or the Supreme Courts. Presently, there are about 1,400 members in the scheme. The corpus fund with the scheme presently is about 2 crores and 80 lakhs. We give 5% of the share of our annual fees to the local branches depending upon their membership, and the 5% of the state share to the state branch. Last year, our contribution was almost 2,25,000 to the Maharashtra state branch. Up till now, we have had about 38 cases, out of which 28 were resolved. 15 cases were resolved only on the basis of reply to the legal notice. 5 cases in the district consumer redressal forum which were in our favor, and 1 in the state consumer forum. Cases still going on are 11 in various district consumer fora, 4 in the state forum, and 1 at the national forum, and 1 a criminal case with the JMFC in Nagpur. We found that there were certain drawbacks in our scheme which were coming in the way of growth of the scheme. First thing was the process of the scheme was completely offline. There was a corpus clause which limits your claim and paying capacity. That is, the liability is limited to 50% or even after receiving full program fees. Staff and the hospital cover was not available as the cover was only limited to the doctors, and the coverage limit was 20 lakhs in aggregate, which was enhanced to 50 lakhs. There was 10% loading for members who had claims on them, and due to limited coverage amount, members don't enroll as they are looking for higher cover. We were missing out on the certain doctors which needed higher covers. So what we proposed was make it digital and paperless, provide individual login and access to program details and benefits, move your burden of financial liability to insurer, increase your coverage from 20 lakhs to 5 crores aggregate, remove the corpus clause and keep upper limit, keep it up to the cover amount, add coverage for the staff, no additional loading on members having claim, an opportunity to upgrade existing cover to 5 crore along with staff cover irrespective of enrollment date, a real-time report on branch-wise enrollment and other reports. With some insured enhancement, we have the opportunity to increase the average ticket size and fund corpus extensively. It will help us penetrate PPS program into IMA branch level. This PPS program is 50% economical than the market indemnity product. This unique proposition will help increase IMA, Maharashtra State and PPS membership. In this program, members will receive their unique login credentials. Members will be enabled to enroll or upgrade directly from our platform. Program fees will be paid online. Program owner will have a complete access to check real-time performance. Members will be able to check their coverage, raise requests, and many more features available on the online platform. Members will be able to modify nominations or update contact details. Renewal, reminder, and enrollment process will be available online, and IMA will have a centralized access to track monthly performance and renewal retention of various members and branches. Revenue will increase year on year as a number of members will increase. Entire claim liability will shift to an insurance company from IMA PPS. The scheme will make IMA image more stronger as compared to any other competitive indemnity product in the market. IMA can claim to members as they have done some welfare things for their members. It will be easy to sell and penetrate to each branch of IMA as this product belongs to the association. IMA's net earning also will increase. Now the difference between the old and the new scheme, the old scheme used to cover limited work. It was limited to general practitioners, physicians, consultants, invasive, non-invasive. The maximum cover was 20 lakhs. There was no provision for cover to the hospital staff, no provision to cover consulting doctors of your hospitals, loading on each members on claims and offline process. Now even plastic surgeons are covered. The maximum cover is up to 5 crores. There is a cover for hospital staff. It covers radioactive therapies, no loading even on claim, up to 80% cheaper than any plan with similar cover and complete online journey. And there is a call center support also. The new feature which we have introduced is the hospital indemnity cover. It gives covers for the hospital nursing home up to rupees 25 crores. Covers the hospital and the qualified and the unqualified staff. It covers radioactive therapies, doesn't cover all the states of India. It is only covers only the state of Maharashtra. Up to 80% cheaper than the market premium and complete online. And there is a call center support as I have already told you. These are the rates which we are proposing for the new scheme. The upper table shows the personal professional indemnity starting from 10 lakh. It depends on the general practitioner, consultant, non-invasive consultant, and invasive consultant. There will be one more category of super specialist, which will have more premium than this. So I think whatever the premium is being shown in these charts is much less than what the insurance companies normally charge for that amount of indemnity cover. And again, the next chart is for the hospital indemnity cover, which starts from 50 lakhs and goes up to 1 crore. Well, now we are going to inaugurate the new scheme at the hands of our President, Dr. Bondwe, sir, and past National President, Dr. Ravi Wankhedkar, sir. I would come to another screen to inaugurate the Yes, sir. I would request Dr. Bondwe, sir, to please, can you log in on this? Ankush? Okay,
Yes, sir.
Can Bondwe, sir, log in on the screen?
Yes. Just inaugurate it.
लॉग इन करा ना सर कमी करू
तुम्ही करून टाका
फार मोठा पासवर्ड बनवला रे. Yes, here we go into the scheme. Ankush, can you take over now?
Let me speak before that.
Yes, sir.
Yeah. Dear all friends, dear all members of HBI and delegates of IMA Maharashtra State, it gives us immense pleasure to introduce this new insurance schemes. Not only the new insurance scheme regarding the professional, the personal protection scheme, as well as we have come out with some other insurance schemes which are really genuine, really affording, and it will really it will really cover all the aspects of your own practice, as well as you yourself, as well as all the belongings of you, like your vehicle. Dear friends, as Dr. Kate just explained, that this new professional protection scheme uh, will be covering all the types of doctors, and the upper limit is up to 5 crores. For a long time, it was rather asked by many of our members that we require higher level of insurance. So this is being done, and mind well that you will get 80%. This scheme is 80% cheaper than any plan which is available with a similar cover. So this is really beneficial for all the members, and it will be completely online. It will be completely it will be supported by a call center 24/7. So all these things are very important. So be sure it is a product of Indian Medical Association with the help of all these insurance company. At the same time, we are now coming out with the hospital indemnity cover. This is really a genuine thing. As I told in the morning, that this hospital indemnity is the first time that your hospitals will be insured for up to the 25 crores. You know, all these the new hospital, the construction cost and all the equipment cost goes very high. So we require a larger cover which will be taken care of in this scheme. So the another product will be hospital indemnity cover, which will cover hospitals up to 25 crores. Not only the 25 crores, it will cover all the hospital qualified and unqualified staff. It will cover the radioactive therapies. It will cover, it is not only restricted for the state of Maharashtra, but any doctor from all over India can participate in this. And again, this is also 80% cheaper than any market plan. It is again a uh, uh, very much online, and you can definitely log in personally and definitely go ahead with the scheme which you want. You will get immediate receipts and all other thing. We are also coming out with the personal schemes like life insurance scheme, the uh, indemnity life insurance scheme, and the cover of our vehicle insurance scheme. Of course, we are also having a corona protection schemes also. All these schemes, whenever you log in, you will be seeing all those uh, plans available in the market with the discount, and you can compare all the insurance provider, all the companies, right from the government companies to the private companies. You can definitely confidently choose your plan. You can play it online and you will get it immediate receipt also, and a policy. So this is very important, and I'm really pleased to inaugurate it. And our insurance provider will give a short demonstration on these schemes. I'm sure these new schemes, or rather all these new schemes, will definitely keep all the members protected, and they will be happy to take part in it. And it is very easy, very simple. After this inauguration, we'll be sending the links to all the branches all over. In few days, we'll be taking again one demonstration for all the presidents and secretaries and all the interested people in all these schemes. And right away, any branch who wishes to go ahead with all these plans or any of these plans, they can definitely arrange similar type of demonstration for their branch. So with this, I say that this is a great day in the life of Indian Medical Association of Maharashtra. We are really happy, we are really pleased, and we are really thankful to the Dr. Anand Kate for the personal protection scheme, which he has given all these inputs. Of course, the Hospital Board of India, Dr. Mangesh Kate and his team for giving the hospital protection scheme, and of course all the other members and my colleagues or all those personal insurance schemes, including the life insurance, term insurance, and car insurance. So with this, I declare that the scheme portal is inaugurated, and I request to Mr. Ankush to give a demonstration in short for the benefit of all our members. Thank you.
So thank you so much, sir. First of all, I would like to thank Bondwe sir for giving this wonderful opportunity to serve IMA in a better way. Thank you so much, Kate sir, for guiding us to take through this journey all over the professional indemnity and hospital cover. And thank you so much, Pate sir, for helping on a in detail thing. What are the things? What are the problems and challenges of the currently doctors are facing in terms of the insurance side, and wherein we will be able to deliver such kind of portal. And we are really honored that we are going to serve the medical fraternity in a better way, and we will definitely try to give as better service as we will be able to give as compared to the market. So sir, Kate sir, request, can I have a authority to share, or you can also just click to buy
No,
on this?
you go ahead, you go ahead, you go ahead.
Okay, sir. Yeah, so this is once anyone who have select the product, be it professional indemnity, they just need to click on the find product, and once they click on the find product, they will. Sir, I do not have access of the screen, so I would like to have our.
You talk, I'll do it.
Okay, so if any general practitioner is there who can just click on the screen, immediately he will end up with the page, and he just need to select the product. So there is a, as Kate sir has said, coverage starts from 10 lakhs to 5 crore. So as per their requirement, they just need to select the product of, suppose, let's say 10 lakh rupees. If it is selected 10 lakh rupees, so this is a demonstrate purpose. We have kept it 10 rupees 10, just to go ahead how the payment is going to be happen. Once click on the subscribe now, immediately the member will land up with the page where in 2 minutes he will just fill up the basic details of the form, wherein he'll require all the basic details which will be mentioned on the proposal form. Once he fill up all his details, there is a icon of a make payment, wherein the basic details, number of beds, hospital, and clinical address, and all details is required, wherein that all details will become on the PPS certificate. So if suppose anyone who have not filled the details, complete details, then these are the errors will come up. So they will come to know the which are the details are still pending to fill up. Sir, if you can allow me to share a screen, so I can share a screen immediately, and then we can do it.
Yes, yes, come on, go ahead.
हाँ.
मी बंद करतो याला म्हणजे तुला करता येईल.
Yes, yes, sir, please. So once member can click, once member logged in, they will have a two coverages like professional indemnity, hospital cover. So if they choose to go for a PPS, then they just need to click to buy. Once they click on that particular tab, they will come up with the categories, whichever categories they are fall into. They just need to click on that particular category. So if suppose, just for example, we are taking as a general practitioner who would like to enroll to the scheme, then they can click on their general practitioner category, and then they will come up with a page where they can choose their coverages. Suppose they are opting for a 10 lakh rupees or any other coverage, 1 crore. So automatically the premium will arrive, and then they can click on the tab, and they can go ahead to complete the enrollment process. So for example, we are choosing this 10 lakh rupees coverages. If any members would like to subscribe for, he will click on the subscribe now. Immediately they will land up with a page where they just need to fill the basic details like their name, their specialty, and their address. If they have a hospital, then hospital address, their hospital, how many beds they do have in their hospital, their professional qualification, year of registration, their membership number, which is again the must, because this benefit only for the IMA members. So they has to have a IMA membership number. If they do not have, we will also coming with the feature wherein Bondway sir will tell you that how can they or how can they become IMA member from this portal itself. So once they fill their basic details, they just need to click on the make a payment. Then they will immediately land up on the page where they will go and they will get into the payment page. So they just need to fill their debit card or net banking or any UPI they have address or any wallet like Paytm and all. They can choose from the left hand side. You must be able to see cards, banks, UPI and wallet. They can choose. They can fill the details. They can fill the details and they can enroll their subscription. So suppose now I'm just filling the details of card just to make you through the end-to-end journey where you will be able to get a clear idea that how it processes and how smoothly it runs, because it hardly takes 5 to 7 minutes to complete enrollment process. So it will be a time saving, and it will very easy to access, and immediately so immediately once you click on this payment part, you will get an OTP as a normal payment procedure happen. So once you enter your OTP, click on the submit OTP button. So if any delay happen to get a OTP, they can click on the resend OTP. They will immediately, because this OTP should come from their banks. So if any other delay, and if they're not receiving their OTP, they just need to click on the resend OTP. They will get a OTP. They just need to put their OTP number. By clicking on the tab of submit OTP, their enrollment process is complete. So they will immediately get a confirmation with their transaction ID, that what is their transaction ID, like the UTR number which we get from the banks. So this is how the screen will get. Immediately you must be checking whatever the registered mail ID you have given in the IMA membership, that registered mail ID, immediately you will get an invoice copy. So I will just show you how invoice copy will be given immediately. The point of time you make a payment, in the fraction of second you will receive a mail ID. You will receive an invoice copy on your mail. So I'm just going to show you the invoice copy. Once you receive an invoice copy, this kind of certificate will be going to send you through in your mailbox. You'll receive in next 24 hours. So the payment receipt which you will get immediately after making a payment, that's called the invoice copy. And the next 24 hours, you will get such kind of certificate which is given by IMA, Indian Medical Association Professional Protection Scheme. In this particular certificate, whatever the details you filled in your proposal form, that all details will be mentioned in this particular certificate, and this will be the valid proof of your enrollment that you are a member, or you are a authenticated person who have become a member of professional protection scheme. So this kind of certificate will be given by the professional protection scheme to the each member whomsoever will opt for this particular scheme. Similar way, the process for the hospital indemnity cover also will be apply by same way. So over to you, Kate sir. This is how the overall journey which we are try to save as much as time of doctors, wherein it by just investing a 5 to 7 minutes, they will be able to get their enrollment or subscription of the PPS scheme and in their account. Similarly, if I talk about once if they don't receive due to any error in certificate, they can view get into their account like once they enroll. So there is a member area. They can go into the dashboard and they can also view their certificate over there as well. So here also they will have their all details view, and whenever the next renewal comes up, so they can see their invoice copy, they can see their address, whatever the details they need to change, they can change it here. They can view their invoice copy, they can view their PPS certificate or any other insurance which will they will opt from this particular portal will be automatically available in their particular account. So they need not to search again and again their emails, or they need not to search their hard copies. Every particular record, whatever products they will buy from this particular website or their particular portal, that will be available this portal, wherein they can check and they can get any point of time whenever they require their copies. Along with the professional indemnity, as they can buy for the hospital indemnity, similar type they have also insurances, which is health insurance, motor insurance, corona coverage, corona rakshak. So all under one roof will be available. Just click on on the 2 minutes of their clicks.
Mr. Ankush, can you give us a small demonstration on the other insurances also? Which are
Sure, sir. Sure. So
yeah.
once
Be short,
thank,
be precise.
yes, sir. Yes, sir. Thank you so much. Once we click on the insurance part, I will just show just a second how it works. So we'll just take one example of any like motor insurance or anything. Yes. Once they click on the insurance, like vehicle insurance, so they will come up with this kind of portal. They just need to put their car number. Once they put their car number, I think so. Just second.
Yes.
So once they click on their car number, if they have a claim, they have done a claim in last year, so they just need to mention their yes or no. If they have not done a claim, they just need to click on no. There's a drop down will come up, and then they just need to have policy expiry date. Whatever the dates their policy is going to be expired, that date they need to put it here. Once they put that dates, just click on the view codes. So whatever the model they do have, automatically the details will come up upside by just putting a vehicle details. They just need to select the coverages if they would like to have a zero day per all. So these are the all insurance companies premium quote will come. All are competitive pricing, whatever they can see it, whatever the insurances they would like to opt for. There's a 15 plans found. So whichever quote or whichever insurance company's particular plan they feel it, they can click on there and they can buy from immediately from here itself. If suppose if anyone would like to change their insurance value, vehicle value, or they just need to add zero depreciation cover or any cover addition, so there is a column upside where they can add it by clicking here. Immediately the premium will change in the downside. So whatever the features they would like to add, so every particular feature is available there. Even there's explanation of particular features is also available there. So just click. So suppose let us say we will go for the Bajaj Alliance. These are plan details. If they click on the plan details, what are the plans is covering and the particular policies are covering, this is also available. Cashless garage is also available. If the particular person would like to see that in which garage is available in that particular locality, which is cashless in that particular insurance company, that list will reflect here. So if my registration this vehicle particular registration is Ahmednagar, so nearby this particular Ahmednagar, whichever the garage is available, which is the cashless in this particular insurance company, that is available in this particular thing. So while selecting the insurance plans, we will also come up that in your nearby your locality, which garage is available this particular insurance policy in the cashless part. So near future, any particular claim comes in, they can directly go that in garage and they can do their all claim cashless way. So you select any territory, you will get all garages available which are the cashless. So client no need to pay anything from their pocket. By having a look of the plan details, they can again click on the buy now, and immediately they can buy the policy. The point of time they will make a payment, immediately the policy copy will be sent on their registered mail ID. So this is how Bhunve sir, this is how the very seamless process, little time consuming, it hardly 5 minutes. If any member would like to enroll for any particular product, they need not to spend more than 10 minutes on the particular product. So they will save their time, they will get all pricing comparisons, so they will not also feel that they have been getting cheated in terms of the price concern. So comparison is available in terms of the features, in terms of the pricing, and also the seamless process. Although if they found any difficulty, there is a client center support, call center support, which is available upside. A number is also available upside of call center. They can call, which is our call center person will definitely support them for any assistance they will require for. So thank you so much, Bondwe sir, for giving this opportunity. Please.
What other policies rather we can apply for through this portal of IMA Maharashtra State? Just let us know.
Just a second, sir.
Just name those products.
So we can offer car insurance, we can offer term insurance, we can offer life insurance, we can offer health insurance, we can specifically offer the Corona Rakshak or Corona Kavach. We can offer any travel insurance. If anyone is going abroad, they can also get a comparison, similar type of comparison by filling small details or basic details. They will get all comparison of all insurance company which are available in the market. Along with that, if anyone would like or taking a consignment or taking a medical equipments from outside, so we can do a marine insurance, their factory insurance, fire insurance, everything they can opt from, click from their particular thing. If anyone like to do an investment, that investment tab is also available, so that investment also they can do it from particular this platform itself.
So thank you, Mr. Ankush.
Thank you so much.
This is definitely a helpful thing which IMA Maharashtra State has done. I'm sure that each and every member of all our 45,000 members will get benefited by at least a few of the insurances. It will not only save your money, but be assured that this will definitely increase, because these are right now they are available only for IMA members, and those doctors who are not IMA members, uh, if they want to join this, they will have to become IMA members. So we will be having some rather increase in our membership also. That is additional benefit, and this will definitely protect each and every member. It will protect his profession. It will protect his hospitals. We have thought about their vehicles as well as the term insurance, which will protect their life, and life insurance is also there, and health insurance and these travel insurance are added advantages. So all these things are there. Definitely do try. We'll be sending the links to this portal, and definitely we'll be arranging these type of demonstrations for every branch or the group of branches all over Maharashtra. So thank you very much, and thanks Mr. Ankush. Thank you, Dr. Anand Kate sir. Thank you, Dr. Mangesh Patil,
Thank you very
and
much.
all our colleagues. Thank you for joining this, and this is a really, I must say, a really very great day in the state of Maharashtra. And thank you,
Thank you so much,
Dr.
sir.
Rajendra Kulkarni. Over to you.
Thank you so much, sir.
Hello.
Sancheti sir.
Yeah. Thank you very much, Dr. Bondwe, sir. Insurance at a click. I would say that is a great job for all IMA members so that we can save our valuable time. So also, I would like to thank Dr. Anand Khate, sir, for his excellent presentation of this personal protection scheme. So also, Ashutosh, who has taken great efforts for IMA members. Next session, I would request Dr. Prakash Marathe, sir, who will speak on Social Security Scheme, SSS. I'll just introduce, sir. Dr. Prakash Marathe
Hello.
is consultant ophthalmologist. Thanks a lot again. Dr. Prakash Marathe, sir, consultant ophthalmologist. Yes. Anything, Dr. Bondwe, sir?
No, sir, please go ahead.
Is the Netra Yogi Eye Clinic at Karvanagar in Pune. Honorary Secretary, Social Security Scheme, IMA Maharashtra State. Past Honorary Joint Secretary, IMA Maharashtra State. Past President of IMA Pune. Convener, National IMA Headquarters, New Delhi. Standing Committee, Prevention of Diabetic Retinopathy and Blindness. CWC members, alternate, National IMA HQ, New Delhi. Managing Committee member, All India Ophthalmic Society. Past President, Maharashtra State Ophthalmological Society. Past President and Advisor, again, Pune Ophthalmological Society. Member, AIOS Standing Committee on Legal Affairs. Chairman, Maharashtra State Chapter, ISM, SICS. I request Dr. Prakash Marathe, sir, to enlighten us on SSS. Please, sir. Over to Dr. Prakash Marathe, sir.
Good evening, all of you. Am I audible?
Yeah. We can hear you.
Okay. Can I share my screen?
Please, sir.
Please allow me to share my screen.
You can share your screen, sir.
Yes. Is the screen seen?
Yes, sir.
Yeah, we can see, sir.
The slides are seen?
Yes, sir.
Yeah, we can see.
Hello. So I am thankful to IMA Maharashtra State President Dr. Avinash Bondwe sir and office bearers of IMA Maharashtra State. Then organizing team headed by Dr. Rajendra Kulkarni, Mahahospicon, Nashik, and HBI Maharashtra State Chapter for giving me this opportunity to talk about social security scheme in this auspicious occasion of Mahahospicon. I think this particular topic is not only related to hospital owners or hospital doctors, but it is related to each and every member of Indian Medical Association. About Indian Medical Association Social Security Scheme, this is a recent address where we have shifted, that is Dr. Neetu Manke IMA House, Tilak Road, Pune. And this is our website which has started functioning, that is www.imamharashtrastatesss.com. This particular presentation is done by our senior chairman, Dr. Jayan Naurange sir, along with past secretary of IMA Maharashtra Social Security Scheme, past president IMA, Dr. Shyam Damle. Their mobile numbers and emails are there. Those who need, they will also be accessible to them. And this is our office bearers team of IMA Maharashtra State. Dr. Jayan Naurange sir is as chairman, myself as secretary, Dr. Meenakshi Deshpande as honorary treasurer, and Dr. Amrish Shade as honorary joint secretary. I think with the leadership of Dr. Jayan Naurange sir, we have taken the social security scheme at Pune. In the past, when the social security scheme started, that was in the year of 2005. Before that, it started in Pune in the year 1990, and it was up to the year of 2005, it was at IMA Pune. But afterwards, it was getting shifted to Mumbai office from 2005 to 2019. In last annual general body meeting, it was again shifted to Pune. So since 2019-20, the functioning of social security scheme has been started at Pune. So what are the objectives of social security scheme? Basically, to provide immediate financial help to the family of deceased member to cope up the financial crisis in the immediate period after death of, and this is very important sentence, after death of the only breadwinner in the family. So consider this situation after the working doctor about his family. Second important thing is it is not only about paying the nominee or paying the family, but increase fellowship amongst Indian Medical Association Maharashtra State Life members. That is also our ultimate aim. Now, if you see this particular chart, when the scheme started in 1990, probably this idea was not known to many more members. Even membership number of IMA headquarters, IMA Maharashtra and IMA Pune, everywhere it was quite less at even local branches like Mumbai, Nashik, Aurangabad, everywhere. So the members of Social Security scheme to start with in the year 1990 was 336 only. But if you see at the end of 2019, it was the enrollment number 7,789. And let me share the good thing in this year, we have reached up to the enrollment number of 8,200. And out of these 8,200, the FFC notices this year were sent to 6,489. So around 6,500 we can count it as. And in between last year and this year, up to till date, 380 new members have joined. I must tell you that around 128 new members have joined recently. And I think this is the awareness amongst people. Maybe COVID also has helped, and many more people are becoming members of this particular social security scheme. This particular slide is very important. Most of the doctors, when they are practicing, they are achieving, they are gaining what they feel. Probably their daily income, their monthly income, their yearly income is very good. So why to go for social security scheme? But if you think when they retire and when there are some days when one feels about family and next generation. So if you sow your nominee reaps, remember about the mango tree. You are sowing the mango tree and probably you are not going to get the fruits. But your next generation, your granddaughters and grandsons, they will be getting those mangoes. So it doesn't mean that you shouldn't sow. So you sow nominee reaps. This is very important slide. So what is the basic aim of this particular scheme? Financial assistance to bereaved family of member doctor to overcome the crisis period. There are cases in the history after the death of the doctor, the wife, the sons, daughters, and other family members, they are in very bad situation. And to overcome from that particular situation, if IMA Maharashtra or IMA National helps them, they are really helped. But it is not the state way. The person has to be Social Security scheme member. He has to pay his FFC, those particular premium charges every year, not to get in the defaulters list, not to discontinue. What is the difference between LIC and other insurance schemes? There are 4 or 5 points I'm going to tell you. This is very small scheme and variable premium. So you will feel that premium is getting varied every year. Last year, some people were asking why this much premium is there. Basically, the premium depends upon the number of deaths in that particular year. If the number of deaths are less, maybe premium will be less. If the number of deaths are more, premium has to be little on higher side. So look at the premium from that angle. Then low operating cost. This is the small, it is not like very big investment company or LIC. So disbursement only on death. Remember this particular thing. Many more members, they ask us, doctor, can I get this particular amount when I am sick, when I am admitted? Why don't you give us? But basic aims and objectives when they were written for Social Security scheme, they were just for after death. Of course, there is one exception about disability claim, but we are not promoting that. So only on death, the nominee and next generation gets that amount. So, and one more important thing, no premium liability after 25 years, though the benefit amount increases. So the person has to pay for 25 years only. And afterward, just the maintenance cost of around say 200 rupees nowadays. So no medical examination is needed, which is needed in case of LIC and other investments. So promptest of the payment is done, usually within 1 to 2 weeks of the death of that particular doctor. And least formalities are required. What are the benefits of the scheme? Benefits basically start after 1 year. If you become the member now, for first year you need not pay FFC, that is paternity fund contribution, and no benefit also. But there is one exception. In case of accidents, where benefit is also extended even before completing 1 year. Some peculiarities about this scheme. So there are tax benefits what one can get. No tax to the beneficiary. Then tax exemption on premiums. Whatever premium you pay, you can show that as your expenses and you can get tax exemption. So contribute for 25 years only. And as the membership number grows, the death claim benefit increases. This is very important. Many more members ask us, can this benefit be increased? Such and such scheme can give more rupees, more amount of rupees. What we tell them, it is dependent on the number of members of the scheme. So I request most of you to become members yourself if you are not, and tell your colleagues who are IMA members to become members of Social Security scheme. What are the highlights of this scheme? IMA MSSSS, it was established in 1990, just now I told you. The founder chairman was Dr. YG Kelkar from Pune and few seniors at that time who thought about this particular scheme. Just now I have told effective membership, that is enrollment number, is around 8,200. Out of them, 400 died so far, whose families have been paid. What is the goal? To reach the magic figure, magic number, that is 10,000. So minimum 500 every year we must get. Basically, dear friends, many more members, they are eligible to become members of SSS, but they are not getting this membership. They are not becoming members. So you must motivate yourself as well as others to reach this magic figure of 10,000. Nowadays, the death claim benefit of rupees 8,44,000 is given for the year 2020-21. All the corpus fund is invested in nationalized banks and other safe securities permitted by charity commissioner as well as by income tax. So please be assured that whatever amount you have been investing in this scheme is safe in the hands of Social Security scheme of IMA Maharashtra State. How does the scheme work? Eligibility. After listening to me for a few minutes, you must have thought, who can become the member of IMA Maharashtra Social Security scheme? I think the life member of IMA, this is the basic requirement. Just forget that the person who is the doctor can become SSS member. No, he has to be life member of IMA. And one more important thing is up to the age of 60 years complete. So don't wait. If you are not 60, start today. But if you have crossed 60, just tell others who are still not completed 60 years of age. So what are the requirements? Apart from proof of life membership of IMA, nowadays you can download that from IMA headquarter website also if you don't have your life membership certificate. So duly completed application form, which is available in physical format, which is available on our website, which is also can be asked by sending email to us. We are sending the soft copy of application form. Your age proof, so that you are not crossed 60 years of age, and check or DD of appropriate amount, what we tell you to give for this particular enrollment. Fourth thing is name and signature of nominee. This is important, and for this, the physical copy of application form is needed. Even if you are submitting the soft copy, even this physical copy you have to retain for years together, because for 25 years you have to pay. So many more years we are preserving these copies in nice format. Passport size photograph of member and his nominee. And nowadays, as our charity, means income tax advisors, they are telling, Aadhaar and PAN card of both the member as well as his nominee, they are supposed to submit Aadhaar and PAN card. And the most important thing we always advise, that is no medical examination is required. Now you will be thinking, when you are giving rupees 200 per death, how that 200 is getting utilized? Suppose there are 40 deaths, it comes to 8,000 that particular year. And if the number of deaths are less, probably the premium will be less. Out of this rupees 200, 140 rupees is paid to the nominee and rupees 60 goes to the corpus. So interest on this corpus takes care of FFC payment after 25 years. Imagine the person who has already paid for 25 years and is still getting survived for another 10 years, 20 years, 25 years. His FFC is paid by our scheme. And how our scheme pays that particular FFC? From this particular interest on corpus. So as the member ceases to contribute, he cannot pay after 25 years because we don't ask him to pay. So that amount is paid from the scheme. Then this slide is very important. If you are looking at the screen and look at the column of age group, when it is up to 30 years of age, admission fee is 1,000. Then advance paternity contribution, that is variable. Why it is 8,000? So number of deaths in that particular period of 2 to 3 years. So 40 deaths, it is calculated and hence it is 8,000. Why annual membership is rupees 400? Basically annual membership fee is rupees 200 only. But for first year, the person doesn't pay that FFC. So that 200 rupees also he has to pay. So sending him notice and he pays 200. So basically it is clubbed with that 200 plus 200, it comes to 400. So for the person who is up to the age of 30 years, pays 9,400 and 18% GST is applicable. The same way it is on the increasing side, like for the year 30 to 40, it comes to 10,000 something. For the year 40 to 50, it comes little more than that. Then 50 to 55, it is 12,000 something. And after 55 till 60, it is around more than 13,000. Just look at these two things, 50 to 55 and 55 to 60. Recently, we are thinking to increase this amount of 4,000 and 5,000 little more, maybe in multiples, because people are taking undue advantage of getting this membership when they are knowing some comorbidity like cancer or something else, maybe around the age of 58 or 59. So just to decrease that particular tendency, we are thinking of increasing the admission fee of these particular two groups, 50 to 55 and 55 to 60. Let us see what happens. So death claim payment is immediate and that we are giving by NEFT because it is getting deposited in your bank. So what is the requirement for death claim? It is death certificate which is duly countersigned and attested by local IMA secretary or president along with advance stamp receipt. So what is the schedule of FFC payment? This year you must have received the notice because on 1st of April we start sending the notices, and notice of demand of FFC latest by 15th April. It is sent to you by post. This year post was not working. So we have sent bulk emails, bulk SMSs, and I'm very happy to say almost 97% people they have paid by this particular communication. So to pay this year what you have paid, just this particular 3 lines you just observe. So latest by May end you have to pay every year. But this particular year we had extended by 1 month because of COVID. And FFC was rupees 9,676 without any late fees. For next particular month of July, 118 rupees was added. So it came to 9,794 rupees. And from the month 1st August to 30th September, that is the period of 2 months, 354 rupees late fee was added. It was 10,030. And we have again, if you see the last line, for FFC 2020, the basic FFC amount was 9,676. So how this amount comes? People ask us the question, why 9,676? So it depends upon the number of deaths which occurred last year. So they were 35. So multiplied by 200 comes to 7,000. So in that 200, that is the maintenance charges of 200 for that particular year, and 18% GST is added. So this way the calculation comes. If you are aiming for less amount of FFC, suppose there are 10 deaths, this amount will decrease. Suppose there are more deaths which can happen this year because of COVID, the FFC may increase. So non-payment on 1st October, this is very, very, very important line. Non-payment on 1st of October, this year we have extended for 1 more month, that is 31st of October, automatic deletion occurs. If you do not pay the FFC, your name is dismissed from the scheme, but can be restarted till next 3 years with refilling of forms, extra payment, which is quite huge, and maintaining the seniority can be done. So this is known as revival. But apart from that first line, what I've said, pay without any late fee till the May end, or this year it was June end. That is the best thing to do. So from 2020 May, these payments are accepted even this year. Online payments were accepted, NEFT, RTGS, QR code, mobile pay, and all other online options. So voluntary deposit, some people feel, suppose we forget to pay FFC and our name may get deleted. We are going abroad. We don't remember. So there is the chance we can do one thing, that is voluntary deposit. So members can pay minimum of rupees 10,000 and then in the multiples of 5,000, like 10,000, 15,000, 20,000 with us. And then it takes care of your FFC. So voluntary payment is available for retired members also. Say they can pay 2,000. So which takes care for nearly 8 to 10 years, like 200 per year administrative fees. For this particular voluntary deposit, there is no interest paid. It is totally voluntary. And statement of balance advance deposits will be sent each year by email or by post if working. This year it was not working. Few words about National Social Security Scheme. You must be thinking why I'm telling about National Social Security Scheme. At the end, you will be getting that particular remark. So it is run on the same basis as of IMA Maharashtra State Social Security Scheme, except for age group and some fee structure, which is a little different. One important thing which is different from state scheme and national scheme, they are having around 17,000 members all over India at present. And how many do we have? Around 8,000. So almost they have got the double. So because of that, their death claim benefit was 11,040,000, 11 lakh 40,000 in June 2020. So get more numbers of membership enrolled and get more death claim benefit. That is the thing one has to remember. So eligibility for them, again, less than 60 years of age, must be life member of IMA since last 3 years. This is very important because person who is 58, 59, just getting IMA membership also that time and getting SSS membership, his intentions are different. So he should be little senior in IMA membership. So this condition of 3 years is not there for doctors joining before 40 years of age because they are already young. There is likely chance that they are going to pay their 25 installments, whereas the person who is getting admitted at the age of 58 or 59 may not be able to pay 25 number of installments. Requirements, same as IMA, SSS, life membership certificate, as I have told you, it is from headquarter you must have got, or you can download it from headquarter website. Just note down this website, www.ima-india.org. And anytime you can get your IMA life membership certificate, which is required to enroll yourself for national as well as state social security scheme. And this is the chart which I am not going to explain in detail because this is about national social security scheme. The numbers and figures are little different. So present scenario, this slide is very important for all seniors and stalwarts and juniors. See, IMA MS Life membership, say around 40,800. Effective Social Security membership, 8,200. National IMA membership around 3,50,000. National Social Security membership, 17,000. IMA Pune around 4,750. And Social Security membership for state 945 and for national only 170. See what that particular comparison tells. There are many more IMA members, but those are not getting social security memberships. So it is your turn, your thinking, you must change and you should become members of social security scheme. So a large gap and hence big scope to enroll yourself for both social security schemes. I am telling you both. Why? Because cover up 20 lakhs, almost 20 lakhs as of now with minimum premium of say 11,000 after initial admission fees. No need for LIC, you may not go for that. Take only term plan, not investment plans. So they can complement each other. So it is national, social and some other investment scheme if you take probably post death, so much of amount one's family may get. So dear members, no other scheme gives such financial benefit within such a short period. Present data reveals that the members who have joined the scheme, this is a very important line, in 1990 have paid not more than rupees 35,000 because that time FFC was quite less. But the nominees are assured benefit returns. Now from 2019, it is rupees 8,44,000 plus or so at present. See, they have paid just 35,000 and they are getting almost 8.5 lakhs or more. So estimated rise of 7 to 10% in death benefit claim every year. But this particular sentence is related to number of increased enrollment by us for social security scheme. So by paying meager rupees 200 per deceased member, we can help families of our fellow colleagues. I again add one thing. Many more doctors, they must be rich. They must be having their children also doing very well. They may be thinking why to get membership. But think one particular thing, when you go for birthday or marriage, you give some gift to that person in the family. But when you are going for death, probably you are not giving anything. And for our doctor colleagues, suppose you are contributing something, that is 200 per death. I think this is the humanity cause, social cause. So think in that angle and become social security scheme member to help your colleagues' families. We appeal all the IMA members to take advantage of this scheme and make your family secure. In short, the real advantage of becoming IMA member is you can become member of IMMS SSS as well as National SSS and secure your financial needs for your family to some extent, that is 20 lakhs plus as of now with meager premium. We at IMA Pune will do everything to guide and assist you to become members of both social security schemes. We have got 20 people of that team of volunteers at IMA Pune, which is helping for us. Our managing committee members, they are putting their efforts. Seniors, past chairmen, stalwarts of IMA, they are also helping our social security scheme. So don't wait even for a day. It is in your interest. Collect forms now and submit it tomorrow. So pay regularly for 25 years. And if you are going abroad for some time, pay in advance in form of deposit or tell somebody. Safeguard your families. Please do not compare it with risk investments like shares, mutual funds, etc. It is certain and steady for social security scheme. Special word, this particular era is COVID era. Today we are facing COVID-19 pandemic and such newer pandemics are bound to recur. This is the scheme which takes all members without medical examination and after 1 year, irrespective of cause of death, benefit is applicable. Secondly, this para is very, very important. Just watch it thoroughly. After AGM passes in November 2020, entry load for members joining after the age of 50 and 55 years will go up tremendously. That is from 4,000 to 25,000 and from 5,000 to 35,000. We are thinking on those lines. So don't waste time. You can become member now. So join today and take advantage of this particular early intimation to you. So this is our team under the leadership of Dr. Avinash Bondwe, who is the president, IMA Maharashtra State, Dr. Bandar, who is secretary, Dr. Kalavadia, who is treasurer, and the stalwart of IMA, pediatrician, past president of IMA Pune, medical legal expert, Dr. Jain Naurange, who is the backbone of this particular scheme, who is our chairman. Under his leadership, we are trying to go ahead, and I hope with the help and confidence and faith by all of you, we at SSS, we are going to succeed. I think with these words, I will conclude my talk. If there are any queries, you can ask me. Thank you so much. Thank you, organizing team and IMA Maharashtra State for giving me this opportunity. Thank you so much. Bye.
Thank you, Marathe sir, for explaining in a very nice way of this SSS scheme. And actually, I am seeing day-to-day work. Dr. Jain Naurange sir and Secretary Dr. Marathe sir and the team is taking great efforts for this SSS scheme. And I hope we plant this mango and take this forward, being only about 200, a meager amount. I again thank Dr. Avinash Bondwe also to take this further of SSS scheme. Thank you, sir.
Thank you. Thank you.
If any queries, you can please contact our team. They will be with you whenever you require for SSS. Thank you.
Thank you.
Should we go ahead? Thank you, sir.
Thank you. Thank you.
Next, yeah. If any queries, you can just contact Dr. Prakash Marathe, sir. Okay.
Yeah, I'm ready to answer anytime.
Okay, sir. Should we go ahead? Dr. Kulkarni, sir.
Yes, yes.
Hello.
Yes, sir. Go ahead, please.
Sir, should we go ahead?
Yes.
Last and the best lecture, I would say.
Are ready.
And Both the full names are required. Dr. Santosh Kulkarni, sir.
Yes, sir. आवाज ऐकू
Last and the best lecture on PCPD virtue and the verdict and the cases. We will present that. I would like to introduce Dr. Santosh Kulkarni, sir. Just a second. Dr. Santosh Kulkarni, DMS from Pune University, worked as a district ophthalmic surgeon Solapur at Chiplun and PCMC Pune in 2002-03. Working as a chairman PCPNDT Committee IMA Maharashtra State, consultant ophthalmic surgeon at Atharva Eye Hospital, Kurwadi since 2007. Working as Central Working Committee member for Central IMA India. Worked as Honorary Joint Secretary IMA Maharashtra State. Worked as Chairman Medico Legal and Anti-Quackery Committee. Worked as Rotary District Chairman since 3 years. Awarded as Best Medical Officer at Chiplun. President's Special Felicitation Award from Maharashtra State in 2013 and 2018. A dynamic, I would say, leader from Chiplun, Dr. Santosh Kulkarni, please take over for the last and the best lecture of today's. Go ahead, sir.
Yes, thank you, sir. राजन संजती सर, थँक यू. आवाज ऐकू येतो माझा सगळ्यांना? हॅलो.
एकदम जोरात येतोय, थोडा कमी केला तरी चालेल.
धन्यवाद सर.
संतोष, गड संतोष.
आजच्या ज्या कॉन्फरन्सची जे आयोजन केलेलं आहे स्टेट IMA, नाशिक IMA आणि HBI यामध्ये अविनाश बोंडवे सर स्टेटचे प्रेसिडेंट, त्याचबरोबर ऑर्गनायझिंग चेअरमन राजेंद्र कुलकर्णी सरांनी मला आज जी काही संधी दिलेली आहे त्याबद्दल मी सर्वप्रथम आपलं मी आभार मानतो. माझा समारोपाचा आजचा लेक्चर आहे. खरं बघायला गेलं तर मी आज गायडन्स पेक्षा सुद्धा संवाद साधू इच्छितो आपल्या सर्व मेंबर्सच्या संदर्भात. कारण PCPNDT लीगल कमिटीकडनं सर्वप्रथम मी आपल्या सर्व मेंबर्सला सांगू इच्छितो की कधीही स्टेट IMA कुठल्याही आपल्या मेंबर्स कडनं सेक्स सिलेक्शन असेल, सेक्स डिटर्मिनेशन असेल, या अशा करणाऱ्या कुठल्याही डॉक्टर्सना आपण पाठीशी कधी घातलेलं नाहीये, घालणार नाही. परंतु त्याचबरोबर आपल्या ज्या डॉक्टरांसवर क्लरिकल मिस्टेक संदर्भात असतील किंवा बऱ्याचशा काही NGOs कडनं जे चुकीच्या पद्धतीचे स्टिंग ऑपरेशन केले जात आहेत याच्या संदर्भात दरवेळेस आपल्या स्टेट IMAच्या PCPND कमिटीकडनं आपण त्यांना वेळोवेळी मदत केलेली आहे. यावर्षी तर आपल्या स्टेट IMAच्या प्रेसिडेंटने गव्हर्नमेंटच्या GR मध्येच आपले प्रेसिडेंट जे आहेत त्या डिस्ट्रिक्टचे IMAचे यांना त्या कमिटीमध्ये GR मध्येच आपले कमिटीमध्ये इन्क्लूड केलेलं आहे. बऱ्याचशा लोकांना माहिती नाहीये की PCPNDT डिस्ट्रिक्टची ऍडवायझरी कमिटी असते, त्याच्यामध्ये बाय डिफॉल्ट त्या IMAचा प्रेसिडेंट हा त्या ऍडवायझरी कमिटीचा मेंबर आहे. त्याच्यामुळं बऱ्याचदा आपले प्रेसिडेंट जे असतात त्यांना माझी विनंती आहे की त्यांनी त्या कमिटीला जावं. आता सर्वप्रथम महाराष्ट्रामध्ये आमच्या कमिटीकडे म्हणा किंवा ज्या प्रत्येक ठिकाणी जजमेंट्स किंवा केसेस होत आहेत त्याच्यामध्ये पहिली गोष्ट आहे ती म्हणजे मायनर ऑफेन्सेस, ज्याच्यामध्ये क्लरिकल मिस्टेक्स म्हणतो. या क्लरिकल मिस्टेक्ससाठी फॉक्सी असेल, IRA असेल, IMA असेल यांनी वेळोवेळी केंद्र सरकारकडे हा सेंट्रलचा ऍक्ट असल्यामुळं आपण ग्रेडेड पनिशमेंटच्या संदर्भात मागणी केली, पण ती निष्फळ ठरली. आणि आत्ताच 3 मेला 2019ला सुप्रीम कोर्टाचा डिसिजन आलेला आहे, ज्याच्यामध्ये फॉक्सी वर्सेस गव्हर्नमेंट ऑफ इंडियाचं जे डिसिजन आहे ते तसं बघायला गेलं तर NGOsच्या प्रेशर खाली सुप्रीम कोर्टाने जो दिलेला जो निर्णय आहे तो आपण शिरसावंत मानू, पण तो निर्णय खरंच डॉक्टर फॅकल्टीसाठी अन्यायकारक आहे. ज्याच्यामध्ये क्लिअर कट सुप्रीम कोर्टाने सांगितलेलं आहे की नॉन मेंटेनन्स ऑफ रेकॉर्ड नॉट जस्ट ए क्लरिकल एरर बट द स्प्रिंग बोर्ड फॉर कमिशन ऑफ ऑफेन्स ऑफ फिमेल फेटिसाइड्स. त्याच्यामुळे आता इथून पुढे क्लरिकल मिस्टेक्स जे आहेत ते अप्रोप्रिएट अथॉरिटींना त्याच्यामध्ये लक्ष घालायला अधिकार आहेत. पूर्वी आपण क्लरिकल मिस्टेकसाठी बऱ्याच अप्रोप्रिएट अथॉरिटीसाठी त्यांना भांडायचो, परंतु आता क्लरिकल मिस्टेक सुद्धा तितकीच इम्पॉर्टंट आहे. परंतु सर्व मेंबर्सला मी एक अश्युअर करू इच्छितो की आज महाराष्ट्र मेडिकल काउन्सिलमध्ये आपले डॉक्टर उत्तरे सरांच्या अंडर MMC मध्ये आपल्या ज्या काही केसेस गव्हर्नमेंटकडनं रेफर केल्या जातात तर गेल्या आता 3 ते 4 वर्षामध्ये जवळपास 188 केसेस MMC कडे रेफर केले गेलेले आहेत आणि त्याच्यातले जवळपास 170 केसेस ह्या निकाली काढण्यात आलेल्या आहेत. परंतु 2012 आणि 2013 यावेळेस एक जे जजमेंट आहे ते अत्यंत क्रुशियल आणि लँडमार्क जजमेंट आपल्या सर्व रेडिओलॉजिस्ट आणि गायनेकॉलॉजिस्टसाठी आहे, ज्याच्यामध्ये रामिनी वेणुगोपाल वर्सेस MMC आणि प्रदीप चंद्र गांधी वर्सेस MMC याच्यामध्ये रामिनी वेणुगोपाल आणि MMC मध्ये जस्टिस सोनक आणि जस्टिस जहागीरदार यांच्या खंडपीठाने 2012 ते 2013च्या काळामध्ये बऱ्याचदा असं व्हायचं की लगेच चार्जेस फ्रेम झाल्या क्लरिकल मिस्टेकसाठी की अप्रोप्रिएट ऑथॉरिटी हे MMC कडे नाव कळवायचे आणि त्याच्यानंतर तात्काळ इतकं प्रेशर असायचे की MMCने त्यांचं नाव एकतर सस्पेंड करावं किंवा त्यांना टर्मिनेट करावं. आणि त्या काळामध्ये घाईघाईने जवळपास 65 डॉक्टरांचं सस्पेन्शन केलं होतं. परंतु 2013च्या रामिनी वेणुगोपाल वर्सेस MMC ह्या लँडमार्क जजमेंटच्या नंतर जवळपास 35 लोकांचं सस्पेन्शन हे MMCने मागे घेतलेलं आहे आणि त्यावेळेसपासून असं झालेलं आहे की कुठल्याही केसेसमध्ये जरी आपल्या डॉक्टर्सना जे तालुका कोर्टाने JMFCने जरी त्यांना पनिशमेंट दिली आणि त्यांचं जरी नाव MMC कडे कळवलं तर MMC ही क्वाशी ज्युडिशियल बॉडी आहे. त्याच्यामुळं महिन्याच्या 3ऱ्या शनिवारी प्रत्येक महिन्याला आपण त्या संबंधित डॉक्टरांची हिअरिंग घेतो आणि त्याच्यामध्ये आतापर्यंत जवळपास 188 पैकी 170 केसेस निकाली काढलेले आहेत. परंतु त्यामध्ये कधीही जे खरंच डॉक्टर दोषी आहेत, ज्यांच्याकडनं एकदा आणि दोनदा चुका झाल्यात, अशामध्ये जवळपास 5 डॉक्टरांचं परमनंट सस्पेन्शन केलेलं आहे, तर 2 लोकांचं टेम्पररी सस्पेन्शन केलेलं आहे आणि जवळपास 29 ते 30 डॉक्टरांना स्ट्रिक्ट वॉर्निंग नोटिसेस दिलेले आहेत. त्याच्यामुळं MMC मध्ये मात्र ह्या निकालाच्या नंतर ग्रेड एन पनिशमेंट आहे आणि त्या सर्व गोष्टीचा MMC फॉलो करतं, ही अत्यंत सर्वांसाठी आनंदाची गोष्ट आहे. परंतु सगळ्यात दुसरी गोष्ट हे जरा क्लरिकल मिस्टेकच्या संदर्भात, पण दुसरी गोष्ट आहे की ऍडव्हर्टाइजमेंट बद्दल सुद्धा बऱ्याचदा काही केसेस झालेले आहेत. आपण ऍडव्हर्टाइजला इतक्या लाईटली घेतो. बऱ्याचदा सगळ्यांचे सिंगल ओनर हॉस्पिटल्स आहेत, कॉर्पोरेट हॉस्पिटलची स्पर्धा करत असताना बऱ्याचदा कॉर्पोरेट हॉस्पिटल असू द्या किंवा सिंगल ओनर हॉस्पिटल असू द्या, IVF सेंटर्स असतील, गायनेक असतील, त्या ठिकाणी बऱ्याचदा ऍडव्हर्टाइजमेंट करत असताना जी थोडीशी भावनिक पद्धतीने किंवा थोड्याशा हरीमध्ये आपण जी काही ऍडव्हर्टाइज करतो त्याच्यामध्ये एक अत्यंत लँडमार्क केस झालेली आहे, ती म्हणजे डॉक्टर छाया तातेड ह्या BHMS डॉक्टर्स होत्या आणि त्या डॉक्टर शुभांगी आडकर ह्या दादरला त्यांचं श्री नर्सिंग होम आहे. दादरला श्री नर्सिंग होम हे शुभांगी आडकरांचं आहे, ते MBBS डॉक्टर आहेत. त्यांच्याकडे BHMS डॉक्टर छाया तातेड यायच्या. वास्तविक पाहता डॉक्टर शुभांगी आडकरांचा काही तिथं रोल नव्हता, परंतु छाया तातेड या BHMS असताना त्यांनी ऍडव्हर्टाइज मध्ये लोकप्रभामध्ये अशा पद्धतीची ऍडव्हर्टाइज दिली की एनीवन वॉन्ट सन, याचा मराठीमध्ये ट्रान्सलेशन होतं मुलगा हवा आहे का, असा प्रश्न विचारलेला होता. आणि एवढ्या गोष्टीवर ही केस झाली. त्याच्यानंतर त्यांनी एक्सप्लेनेशन दिलं की हे थोडंसं ट्रान्सलेशन चुकलेलं आहे, मूल हवं आहे का असं ते प्रिंट करायचं होतं, पण मुलगा हवा आहे का अशा पद्धतीची ती झाली. आणि ही महाराष्ट्रातली माझ्या माहितीनुसार एकमेव केस आहे जी 2004 ला ते FIR लॉन्च झाला आणि 2011 पर्यंत आता जवळपास ती केस हायकोर्टामध्ये आहे. आणि ह्या केसमध्ये केवळ ऍडव्हर्टाइजसाठी आपल्या डॉक्टरांना 3 वर्षाची शिक्षा आणि 10,000 दंड झालेला आहे. त्याच्यामध्ये पुढे जाऊन सेशन कोर्टाच्या नंतर डॉक्टर शुभांगी आडकर ज्यांचं नर्सिंग होम होतं त्याचा याच्यामध्ये काही रोल नाही, त्याच्यामुळे त्यांची निर्दोष मुक्तता केली. पण त्याच्यातले जे BHMS डॉक्टर मॅडम आहेत त्यांना ही शिक्षा कायम ठेवलेली आहे. त्याच्यामुळे माझी कृपया सर्व मेंबर्सना विनंती आहे की ऍडव्हर्टाइजमेंट करत असताना थोडंसं आपले जे PRO असतील किंवा आपल्या हॉस्पिटलचे जे कोणी प्रिंट मटेरियल किंवा प्रिंट मीडिया बघणारे लोक आहेत त्यांच्यावर सुद्धा थोडंसं लक्ष दिलं पाहिजे. तिसरा पार्ट, ज्या बऱ्याचशा केसेस आपल्याला आढळतात त्या अनरजिस्टर्ड सेंटर्स मध्ये. अनरजिस्टर्ड सेंटर्स म्हणजे कोणते, तर मध्यंतरी आता सांगलीला एक केस झालेली होती. त्याच्यामध्ये सांगली महानगरपालिकेने केस केलेली आहे, ज्याच्यामध्ये एक डॉक्टर BMS होते, त्यांनी ते हॉस्पिटल चालू केलेलं होतं आणि त्या हॉस्पिटलमध्ये एक गव्हर्नमेंट मेडिकल ऑफिसर पण त्या गायनेकॉलॉजिस्ट आहेत आणि दुसरे अॅनास्थेटिक, ते दोघंही त्या ठिकाणी जाऊन अनरजिस्टर्ड हॉस्पिटलमध्ये त्या ठिकाणी जाऊन MTP केलं जायचं, त्याचबरोबर सोनोग्राफी केली जायची. आणि ही केस जी आहे ती त्या केसच्या नंतर जे गव्हर्नमेंट मधले जे डॉक्टर त्या ठिकाणी अनरजिस्टर्ड प्लेस मध्ये जात होते त्यांचं सस्पेन्शन झालं. परंतु त्याचबरोबर आपले जे डॉक्टर्स आहेत जे त्या ठिकाणी अनरजिस्टर्ड प्लेस मध्ये अॅनेस्थेशियाला जात होते किंवा गायनॅकला जात होते यांच्या बाबतीत सुद्धा कारवाई करून त्यांच्या MMC कडे त्यांची एन्क्वायरीसाठी पाठवलेलं आहे. माझ्या सर्व मित्रांना एक सांगायचंय की तुम्ही ज्या ठिकाणी हॉस्पिटल, मग ते ॲलोपॅथी डॉक्टरांचं असो किंवा आयुर्वेदिक डॉक्टरांचं असो, अशा हॉस्पिटलमध्ये जर तुम्ही सोनोग्राफी करायला जात असाल किंवा MTP करायला जात असाल तर कृपया 3 गोष्टीची लक्ष द्या की ते हॉस्पिटलचं बॉम्बे नर्सिंग होम रजिस्ट्रेशन आहे का, असेल तर ते रिन्युअल केलेलं आहे का, दुसरी गोष्ट त्याला MTP रजिस्ट्रेशन आहे का, तिसरी गोष्ट ज्या डॉक्टरांकडे जाता ते त्या डॉक्टरांकडे तुमच्या absence मध्ये बऱ्याचदा सोनोग्राफी करायला तुम्ही आठवड्यातून 2 दिवस जात असाल, पण तुमच्या absence मध्ये ती सोनोग्राफी मशीन जी आहे ती बऱ्याचदा सील केलेली नसते किंवा बंद खोलीत नसते आणि तुमच्या absence मध्ये बऱ्याचदा तिथले जे डॉक्टर्स आहेत ते सोनोग्राफीचा प्रूफ फिरून काही पेशंट मध्ये सोनोग्राफी नुसतीच केल्यासारखं भासवतात आणि पैसे घेतलेले अशा बऱ्याचशा केसेस सोलापूर डिस्ट्रिक्ट मध्ये झालेल्या आहेत. आणि अशामध्ये ज्याचं हॉस्पिटल आहे तो जो आयुर्वेदिक डॉक्टर असेल किंवा BHMS डॉक्टर असेल ज्याच्या नावाने नर्सिंग होम आहे त्याच्यावर कुठली कारवाई झालेली नाही, परंतु आपला जो डॉक्टर त्या ठिकाणी सोनोग्राफीला जातोय त्याच्या नावाने ते सेंटर सोनोग्राफी सेंटर रजिस्टर्ड असल्यामुळे त्याच्यावर कारवाई झालेली आहे. तर अशा अनरजिस्टर्ड सेंटरला शक्यतो तुमचे स्वतःचे सर्टिफिकेट देऊ नका. अशा अनरजिस्टर्ड MTP सेंटर्सला स्वतःचे अनेस्थेटिक डॉक्टरनी स्वतःचं अनेस्थेशिया सर्टिफिकेट देऊ नका. कारण आताच पुण्यातली केस झालेली आहे, त्यामध्ये केस झालेली आहे जी ऐतिहासिक जजमेंट आहे ज्याच्यामध्ये 2 BMS डॉक्टरांना 10 वर्षाची शिक्षा देण्यात आलेली आहे. त्याच्यामध्ये एक BMS डॉक्टर ज्यांचं हॉस्पिटल होतं त्यांच्याकडे दुसरे डॉक्टर्स येऊन सीझर आणि कुटुंब कल्याणची म्हणजे ट्युबेक्टोमी केस केलेली होती. वास्तविक पाहता जे डॉक्टर होते ते BMS MS होते आणि अनेस्थेशियाला जे गेलेले होते आपले ॲलोपॅथी डॉक्टर्स होते. अनेस्थेशियाची त्याच्यामध्ये कुठल्याही पद्धतीची चूक नाही असं ससून हॉस्पिटलने सांगितलं. त्याच्यामुळे आपले अनेस्थेशियाचे डॉक्टर त्याच्यामध्ये कुठल्याही पद्धतीची त्यांच्यावर कारवाई झाली नाही. त्यांना फक्त थोडंसं कॉम्पेन्सेशन द्यावं लागलं. परंतु अनरजिस्टर्ड प्लेस आणि जो सर्जन होता तो शल्य म्हणजे BMS नंतरचा सर्जरी केलेला व्यक्ती होता. असेच खूप सारे BMS नंतरचे MS गायनॅक जे आहेत त्या डॉक्टरना सुद्धा सोनोग्राफी असेल MTP असेल हे किंवा ट्युबेक्टोमी असेल हे नॅशनल प्रोग्राम्स आहेत आणि सेंट्रलचे ऍक्ट आहेत ते अलाउड नाही आहेत. परंतु बऱ्याचदा आपले काही डॉक्टर्स त्यांच्या MTP सेंटर्सला म्हणा किंवा OTला आपले सर्टिफिकेट जोडत आहेत. ते सुद्धा MMCच्या अंडर चुकीचं आहे. अशा पद्धतीचं जर काही घडलं तर आपल्यावर त्या संदर्भात कारवाई होऊ शकते. दुसरी गोष्ट बऱ्याचदा काही डिस्ट्रिक्ट जे आहेत त्याच्या नियर बाय काही दुसरे राज्य आहेत, आंध्र आहेत, कर्नाटक आहेत, या ठिकाणी बरेचसे आपले डॉक्टर्स हे सोनोग्राफी करायला जातात किंवा सर्जरी करायला जातात किंवा गायनॅक प्रॅक्टिस करायला जातात दर शनिवार रविवारी वगैरे. तर त्या अशा ठिकाणी ते अनरजिस्टर्ड प्लेस आहे. तिथल्या संबंधित स्टेट काउन्सिलला तुम्ही रजिस्टर्ड नाही आहात तर कृपया माझी विनंती आहे की PCPNDT ऍक्ट अंतर्गत बाकीच्या राज्यात सुद्धा किती MTP झाल्या याची संपूर्ण माहिती महाराष्ट्र राज्य सुद्धा शेजारच्या राज्याकडनं मागून घेतं दर महिन्याला. त्याच्यामुळे आपल्याला असं वाटत असेल की मी शेजारच्या राज्यामध्ये सोनोग्राफीला जातो, माझ्या मित्राकडे गायनॅकच्या सर्जरी करायला जातो, तर जर जायचं असेल तर तुम्ही जाऊ शकता, MMC कडे अर्ज करू शकता आणि प्रॉपर तिकडच्या स्टेटचं रजिस्ट्रेशन करून आणि NOC कडे MMC महाराष्ट्र स्टेटची NOC घेऊन तुम्ही त्या अदर राज्यामध्ये सोनोग्राफीसाठी जाऊ शकता. तिसरं आहे, माझा आवाज ऐकू येतोय? हॅलो,
हो येतोय व्यवस्थित येतोय.
तिसरं आहे ते इरेग्युलेटरी ऑफ रजिस्टर्ड सेंटर्स. बऱ्याचदा सेंटर्स जे आहेत काही डॉक्टर्स म्हणतात की आम्हाला 2 पेक्षा जास्त सेंटर्स आम्हाला सोनोग्राफी सेंटर्स अलाउड केले पाहिजे. परंतु आता नवीन जो आपला गव्हर्नमेंटचा GR आहे किंवा सेंट्रल गव्हर्नमेंटच्या गाईडलाईन्स आहेत त्याच्याप्रमाणे फक्त आपल्याला 2 सेंटर्सच अलाउड आहेत. बाकीच्या सेंटर्स हे तुम्ही दुसऱ्या डॉक्टरांच्या नावाने घेऊ शकता. परंतु सगळ्यात महत्वाची गोष्ट आहे की ती प्लेस, पर्सन आणि मशीन अशा तिन्ही गोष्टी रजिस्टर्ड असतात. त्याच्यामुळे चुकू नये. खूप ठिकाणी असं आढळतं की रजिस्ट्रेशन हे दुसऱ्या रेडिओलॉजिस्टच्या नावाने असतं परंतु त्या ठिकाणी रेडिओलॉजिस्ट हा वेगळा असतो. तर कृपया 2 सेंटरपेक्षा जास्त सेंटर्स करू नका. आणि आता बऱ्यापैकी पूर्वी MBBS डॉक्टर्स असतील किंवा काही आयुर्वेदाचे डॉक्टर्स असतील यांच्याकडे ग्रामीण भागामध्ये सोनोग्राफी सेंटर्सचे रजिस्ट्रेशन दिलेले होते, पण आता ते दिले जात नाहीये. त्याच्यामुळं तुम्ही स्वतः ठरवा की अशा आयुर्वेदिक डॉक्टरांकडे सोनोग्राफी सेंटर्सला तुमचे सर्टिफिकेट्स द्यायचे का नाही. कारण बऱ्याचदा ह्या ठिकाणी असा प्रॉब्लेम होत आहे की जे काही आता मोबाईल व्हॅन मध्ये सेक्स डिटर्मिनेशन असेल, मग सातारा असेल, सांगली असेल, या ठिकाणी मोबाईल व्हॅन मध्ये सेक्स डिटर्मिनेशन होत आहे. हे मॅक्झिमम सगळे जे डॉक्टर्स आहेत ते सगळे अदर पॅथीचे आहेत, कुठलेही रेडिओलॉजिस्ट किंवा गायनेकोलॉजिस्ट नाही आहेत. आणि हे वेळोवेळी आम्ही स्टेटचे डायरेक्टर जे आहेत त्यांना आम्ही वेळोवेळी सांगितलेलं की आता जे काही सेक्स डिटर्मिनेशन केलं जात आहे ते मॅक्झिमम अदर पॅथीज किंवा वॅक्स कडनं केलं जात आहे. परंतु प्रॉब्लेम असा आहे की बऱ्याचदा आपले डॉक्टर्स प्रॅक्टिस करत असताना आपल्याकडे काही डॉक्टर्स असतील, काही सिस्टर्स असतील किंवा काही परिचयाचे सामाजिक कार्यकर्ते असतात, ते आपल्याला पेशंट रेफर करतात, सोनोग्राफीला रेफर करतात किंवा MTP साठी वगैरे पाठवतात. पण असं करत असताना या लोकांशी भावनिक न होता सोनोग्राफी करत असताना कुठल्याही पद्धतीचा फॉर्म न करता सोनोग्राफी करू नका, कितीही ओळखीचा असेल. कारण सोनोग्राफी करत असताना कुठलीही भावनिकता उपयोगाची नाहीये. सोलापूर जिल्ह्यातली एक केस आहे की एक नेहमी पेशंट घेऊन येणारी महिला जी सिस्टर होती, ती वेळोवेळी सोनोग्राफीसाठी यायची आणि त्या डॉक्टरांनी त्या सोनोग्राफी करत असताना फीस तर सोनोग्राफीचीच घेतली, परंतु केवळ त्या डॉक्टरांचा विश्वास आणि ती पेशंट त्या डॉक्टरांच्या परस्पर पेशंटकडनं पैसे घ्यायची. वास्तविक पाहता आपले डॉक्टर्स कधीही सेक्स डिटर्मिनेशन करत नव्हते, परंतु डॉक्टरांच्या केबिनमध्ये ती यायची पेशंट सोबत आणि केबिन मधनं बाहेर येऊन सांगायची की अमुक अमुक तुम्हाला मेल चाइल्ड आहे, फिमेल चाइल्ड आहे. वास्तविक पाहता याच्यामध्ये डॉक्टरांचा काही दोष नसायचा. म्हणून माझी डॉक्टरांना विनंती आहे की कृपया कितीही ओळखीच्या कुठलाही हॉस्पिटलच्या कर्मचारी असेल, डॉक्टरचे रिलेटिव्ह असतील किंवा रेफरिंग डॉक्टर्स असतील, त्यांना तुम्ही तुमच्या सोनोग्राफी केबिन मध्ये घेऊ नका. तुमच्या उपरोक्ष ते परस्पर बाहेर जाऊन त्या पेशंटच्या रिलेटिव्हला काय सांगत असतील किंवा तुमच्या उपरोक्ष कुठल्या पद्धतीचे पैसे घेत असतील ते आपल्याला कल्पना नाही. अशा पद्धतीच्या केसेस सोलापूर डिस्ट्रिक्ट मध्ये झालेल्या आहेत, सांगली डिस्ट्रिक्ट मध्ये झालेले आहेत. बऱ्याचदा आपले डॉक्टर्स म्हणतात की ह्या ऍक्ट मध्ये पेशंटच्या हजबंडला किंवा पेशंटच्या नातेवाईकांना कुठल्याच पद्धतीची शिक्षा कशी काय होत नाही, ती झाली पाहिजे. तर दुर्दैवानं आपल्या सर्व मेंबर्स हे बोलणं खरं आहे, परंतु केवळ महाराष्ट्रामध्ये माझ्या माहितीनुसार 2च केसेस आहेत जे बाबासाहेब खिद्रापुरे जे BHMS डॉक्टर्स होते. म्हैसाळ प्रकरण अत्यंत गाजलेलं प्रकरण आहे सांगलीतलं, आणि दुसरं आहे ते सुदाम मुंडेचं परळीचं प्रकरण. या 2च केसेसमध्ये त्यातल्या त्यात सुदाम मुंडेच्या केसमध्ये 10 वर्षाची शिक्षा ही सुप्रीम हायकोर्टाने सुद्धा 10 वर्षाची शिक्षा ही त्या गर्भवती महिलेच्या पतीला डॉक्टरांसोबत दिलेली आहे. आणि म्हैसाळचं जे खिद्रापुरे प्रकरण आहे याच्यामध्ये मात्र फक्त पोलीस कस्टडी दिलेली. तर हे जे काही फॅक्ट्स आहेत जे मोबाईल व्हॅन मध्ये SD करतात ते बऱ्याचदा सोनोग्राफीसाठी आपल्या रेडिओलॉजिस्टकडे पाठवतात आणि ह्याचं बॅकवर्ड ट्रेसिंग होतं अशा पद्धतीने की वास्तविक पाहता आपले रेडिओलॉजिस्ट या कुठल्याही गोष्टीमध्ये इन्व्हॉल्व नसतात. त्यांना ह्या गोष्टीची कल्पना पण नसते की अशा पद्धतीने होत आहे. परंतु पेरिफेरीचे काही डॉक्टर्स जे असतील, ज्या ह्या गोष्टीमध्ये इन्व्हॉल्व असतील, काही क्वॅक्स असतील, काही अदर पॅथीचे डॉक्टर्स असतील, ते आपल्या डॉक्टर्सकडे सोनोग्राफीसाठी पाठवतात. सोनोग्राफीसाठी पाठवल्यानंतर आपले डॉक्टर्स 20 आठवड्याच्या नंतर जी काही सोनोग्राफी आहे ती लिगली रिपोर्ट देतात. परंतु ते संबंधित डॉक्टर्स त्या पेशंटला त्यांना अनुकूल असा रिपोर्ट देऊन सांगून त्याची इलिगल MTP केली जाते आणि मग त्या पद्धतीने बॅकवर्ड ट्रेसिंग केली जाते. तर या गोष्टीमध्ये सुद्धा आपल्या डॉक्टर्सनी या सर्व जे कोणी रेफरिंग डॉक्टर्स आहेत किंवा सोनोग्राफी करतायत यांच्यावर थोडस आपण लक्ष दिलं पाहिजे. तिसरी गोष्ट, बऱ्याचदा गायनेकोलॉजिस्टचं स्वतःचं हॉस्पिटल असतं, परंतु त्या ठिकाणी अनोमली स्कॅनसाठी बऱ्याचदा रेडिओलॉजिस्ट येतात. पिंपरी चिंचवड म्युनिसिपल कॉर्पोरेशनच्या अंडरची अत्यंत लँडमार्क जजमेंट आहे. खूपदा आपण आर्ग्यू करत बसतो अप्रोप्रिएट ऑथॉरिटींच्या सोबत की माझी काय क्लरिकल मिस्टेक झाली. अप्रोप्रिएट ऑथॉरिटींना ज्या पद्धतीच्या पॉवर्स आहेत, जरा थोडासा आपण अभ्यास केला तर ज्या पद्धतीने त्यांना सुद्धा अप्रोप्रिएट ऑथॉरिटींना सुद्धा काही लिमिटेशन्स आहेत. त्यांनी सुद्धा एक विशिष्ट वेळेच्या नंतर तुमच्याकडे वेळोवेळी दर 3 महिन्याला येऊन इन्स्पेक्शन केलं पाहिजे. इन्स्पेक्शन केल्यानंतर तुमच्या क्लरिकल मिस्टेक ज्या आहेत त्या दाखवल्या पाहिजेत. त्यामध्ये तुम्हाला त्रुटी असतील तर तुम्हाला शोकॉज नोटीस दिली पाहिजे. असं डिरेक्टली कोणीतरी आलंय आणि तुमच्यावर कारवाई केली असं जर कुठं घडत असेल, कुठल्याही पद्धतीचे जर समजा काही अप्रोप्रिएट अथॉरिटी तुम्हाला जर हॅरसमेंट करत असतील, तर संबंधित IMAच्या अध्यक्षांना किंवा आमच्या मेडिको लिगल कमिटीला, स्टेट प्रेसिडेंटला तुम्ही तसं लेखी कळवा. आम्ही त्या संबंधित स्टेट अप्रोप्रिएट अथॉरिटीशी या संदर्भात वेळोवेळी आम्ही आमच्या मेंबर्सला मदत केली आहे, मदत सुद्धा करू. बऱ्याचदा काय होतं की क्लेरिकल मिस्टेक्स मध्ये शो कॉज नोटीस दिलेली असते किंवा टेम्पररी सस्पेन्शन केलेलं असतं ते सेंटरचं. याला सुद्धा आपले डॉक्टर्स थोडंसं घाबरतात. याच्यामध्ये घाबरायची काही गरज नाही. आपण कुठल्याही पद्धतीची चूक केली नसेल तर ज्या पद्धतीने डिस्ट्रिक्टला ऍडवायझरी कमिटी आहे तशी स्टेटला सुद्धा ऍडवायझरी कमिटी आहे आणि त्या ठिकाणी भाग्यश्री रंगारी म्हणून लिगल ऍडवायझर मॅडम आहेत. त्यांचं वेळोवेळी IMA मेडिकल PCPNDT कमिटी आणि स्टेटला वेळोवेळी मदत असते आणि त्या आपल्याला मदत करतात आणि त्याच्यामुळे तुम्हाला जर समजा कुठली शो कॉज नोटीस किंवा टेम्पररी सस्पेन्शन डिस्ट्रिक्ट ऍडवायझरी कमिटीने दिली असेल तर त्याचा एक विशिष्ट फॉर्मॅट आहे. आम्ही स्टेट IMA कडनं प्रत्येक ब्रँचेसला पाठवू. तर तुम्ही त्या विशिष्ट फॉर्मॅटमध्ये डिस्ट्रिक्टच्या ऍडवायझरी कमिटीच्या विरोधात तुम्ही तक्रार न घाबरता स्टेटकडे करू शकता आणि न्याय मागू शकता. कारण आपल्याला जर त्यांच्या अप्रोप्रिएट अथॉरिटीचे काय रोल आहेत हे जर आपल्याला माहित असतील तर आपण त्यांना विशिष्ट पद्धतीने त्यांना क्रॉस करू शकतो. आणि अशाच पद्धतीमध्ये PCMC मध्ये जी केस सांगत होतो की त्याच्यामध्ये गायनाकोलॉजिस्टकडे एक रेडिओलॉजिस्ट यायची आणि रेडिओलॉजिस्ट प्रॉपर रिपोर्टवर साईन जी असायची ती रेडिओलॉजिस्टची असायची. परंतु जे म्युन्सिपल कॉर्पोरेशनला द्यायचे जे रिपोर्ट्स आहेत त्या रिपोर्ट्सवर आपल्या गायनाकोलॉजिस्टनी साईन केली होती आणि अप्रोप्रिएट अथॉरिटीचं म्हणणं होतं की ज्यांनी सोनोग्राफी केली आहे त्यांनीच साईन केलेला रिपोर्ट पाठवला पाहिजे. वास्तविक पाहता हा फार मोठा इश्यू नव्हता, पण एवढ्या इश्यू त्यांनी त्यांच्यावर क्लरिकल मिस्टेक्स रेकॉर्ड किपिंगच्या अंडर त्यांच्यावर केस केली. 2011 ते 2017 पर्यंत केस चालली आणि त्यांना 3 वर्षाची शिक्षा ही केवळ फक्त काय चुका आहे तर रेडिओलॉजिस्ट येतोय त्यांनी साईन करायच्या ऐवजी हॉस्पिटल ओनर त्यांचं म्हणणं होतं की मी हॉस्पिटल ओनर आहे आणि म्युन्सिपल कॉर्पोरेशनला रिपोर्ट देत असताना मी साईन करतो. तर हे सुद्धा PCPNDT ऍक्टच्या अंतर्गत अलाउड नाहीये. तिसरी गोष्ट सेक्स सिलेक्शन. सेक्स सिलेक्शन मध्ये माझ्या माहितीनुसार तर आता एवढ्या केसेस झालेल्या आहेत. या केसेसमध्ये जवळपास 572 केसेस आतापर्यंत झालेले आहेत आणि आम्ही वेळोवेळी स्टेट PCPNDTच्या जे अथॉरिटी आहेत किंवा डायरेक्टर आहेत त्यांना सांगतोय की 572 केसेसमध्ये जवळपास 282 केसेस ह्या पेंडिंग आहेत आणि ज्या की क्लेरिकल मिस्टेक्सवर आहेत. आणि सर्व मेंबर्सला, सर्व जिल्ह्यातल्या मेंबर्सला महाराष्ट्रातल्या माझी विनंती आहे की ज्या काही केसेस ज्या डॉक्टरांच्या पेंडिंग असतील, खूप ठिकाणी 3 गोष्टीमुळे केसेस पेंडिंग आहेत. नंबर एक तर ज्या संबंधित मेडिकल सुप्रिटेंडेंटनी किंवा अप्रोप्रिएट अथॉरिटीनी तुमच्यावर केस केलेली आहे त्याची ट्रान्सफर झालेली आहे. दुसरा आलेला अथॉरिटी त्या केसमध्ये काही इंटरेस्ट घेत नाही, कोर्टाच्या तारखेला येत नाही आणि अशामुळे तुमच्या केसेस जर पेंडिंग असतील तर कृपया तुम्ही स्टेट IMA कडे PCPNDT कमिटीकडे बऱ्याच दिवसापासून केस पेंडिंग असेल तर तुम्ही कळवा. आपण अप्रोप्रिएट अथॉरिटी स्टेटच्या त्यांना सांगून त्या केसेस जेवढ्या जलद गतीने त्यांचे स्वतः अप्रोप्रिएट अथॉरिटी येतील आणि त्या केसेस निकालित काढतील या संदर्भात आम्ही सर्व मेंबर्सला मदत करू. आपण मध्यंतरीच आपले स्टेट प्रेसिडेंट आणि PCPNDTचे डायरेक्टर यांच्या मार्गदर्शनाखाली आपण कोल्हापूर आणि सोलापूर डिस्ट्रिक्ट मध्ये बऱ्याच दिवसापासून केसेस पेंडिंग होत्या. सोनोग्राफी मशीन सील होती. हायकोर्टाचा रिझल्ट हा डॉक्टरांकडनं लागलेला होता, परंतु संभव आपले डॉक्टर्स परत एकदा ते गव्हर्नमेंटचे लोक सुप्रीम कोर्टात जातील या भीतीने निकाल आपल्याकडनं लागलेला असताना सुद्धा शांत बसून होते. असंच एक चुकीचं स्टिंग ऑपरेशन कोल्हापूरमध्ये झालेलं होतं. वास्तविक पाहता ते स्टिंग ऑपरेशन सेशन कोर्टाच्या पुढे गेलं नाही. सर्व लोक त्या सेशन कोर्टामध्ये सुद्धा साक्ष द्यायला आले नाहीत. मग असं असताना आम्ही त्या डॉक्टरांना विनंती केली की कृपया तुम्ही रिटर्न मध्ये स्टेट ऑथॉरिटीला द्या. स्टेट IMA PCPNDT कमिटीला प्रेसिडेंटला कळवा की माझा रिझल्ट लागलेला आहे, परंतु प्रत्येक ह्याला एक 90 दिवसाची लिमिट असते. हायकोर्टातनं सुप्रीम कोर्टामध्ये जायचं असेल तर त्याचं एक लिमिट आहे. त्या लिमिटमध्ये जर समजा स्टेट ऑथॉरिटी जर तुमच्या विरोधात सुप्रीम कोर्टात गेली नसेल किंवा सेशन कोर्टातनं हायकोर्टातनं गेली नसेल तर तुम्ही 100% स्टेट PCPNDT कमिटीकडे, स्टेट ऍडवायझरी कमिटीकडे तुम्ही दाद मागू शकता. आणि तशा पद्धतीने आम्ही आमच्या 2 IMA मेंबर्सला कोल्हापूर आणि सोलापूर मधल्या सांगितलं आणि तशी त्यांनी लेखी पत्रव्यवहार केला आणि सांगायला मला आनंद वाटतो की त्यांची आपण मशीन बऱ्याच वर्षाच्या नंतर डिसील करून दिलेली आहे. हे नक्कीच स्टेट PCPNDT कमिटीचं यश आहे. आणि अशा पद्धतीच्या जर पेंडिंग केसेस असतील तर कृपया स्टेट IMA कडे कळवा. कुठल्याही पद्धतीचं घाबरायचं कारण नाही, कारण एकदा आता तुमची मशीन सील झाली आणि एकदा जर तुमच्यावर जर समजा FIR दाखल केलाय तर याच्यापेक्षा वाईट आता वेगळं काही होऊ शकत नाही. त्यामुळे कुठल्याही स्टेट ऑथॉरिटीला तुम्ही न घाबरता तुमच्या केसेस पेंडिंग असतील तर 100% कळवा. आणखीन एक प्रकार, काही म्युन्सिपल कॉर्पोरेशनला काही कंत्राटी गायनेकोलॉजिस्ट असतील किंवा मेडिकल ऑफिसर भरलेले आहेत आणि बऱ्याचदा असं झालेलं आहे की ते रेडिओलॉजिस्ट असतात किंवा गायनेकोलॉजिस्ट असतात आणि त्यांच्याकडे अप्रोप्रिएट ऑथॉरिटीचा चार्ज दिलेला आहे, जो की चुकीचा आहे. असं जर कुठल्या महानगरपालिकेमध्ये जर असं आढळत असेल किंवा एखाद्या डिस्ट्रिक्टमध्ये अप्रोप्रिएट ऑथॉरिटी हा प्रॅक्टिसिंग रेडिओलॉजिस्ट किंवा प्रॅक्टिसिंग गायनेकोलॉजिस्ट असेल तर कृपया आमच्या कमिटीकडे कळवा. आम्ही मध्यंतरी मराठवाड्यातील एका डिस्ट्रिक्टमध्ये एक स्वतः गायनेकोलॉजिस्ट, त्या स्वतः अप्रोप्रिएट ऑथॉरिटी होत्या, त्यांची त्याच गावामध्ये प्रॅक्टिस होती आणि केवळ अकसापोटी आपल्याच स्वतःच्या कलिगवर त्यांनी मशीन सील करणे आणि कारवाई केली. आणि त्या संबंधित डॉक्टरांनी ज्यावेळेस आमच्या कमिटीकडे तक्रार केली, आम्ही स्टेट अप्रोप्रिएट ऑथॉरिटीकडनं त्या प्रॅक्टिसिंग गायनेकोलॉजिस्ट अप्रोप्रिएट ऑथॉरिटीचा चार्ज काढून त्यांच्या ठिकाणी दुसरी अप्रोप्रिएट ऑथॉरिटी नेमण्याची सुद्धा आम्ही कारवाई केलेली आहे. तर अशा पद्धतीचे जर समजा कुठल्या डिस्ट्रिक्टमध्ये किंवा म्युन्सिपल कॉर्पोरेशनला प्रॅक्टिसिंग रेडिओलॉजिस्ट गायनेकोलॉजिस्ट अप्रोप्रिएट ऑथॉरिटी असेल तर त्या PCPNDT ऍक्ट नुसार ते अलाउड नाही, त्याच्यासाठी तुम्ही विरोध करू शकता. तिसरी गोष्ट आहे की बऱ्याचदा रेडिओलॉजिस्ट आणि गायनेकोलॉजिस्ट जे आहेत की यांचे जे केसेस ज्या पेंडिंग असतात त्या स्टेट ऍडवायझरी कमिटीमध्ये असतात. तर त्या स्टेट ऍडवायझरी कमिटीमध्ये जर समजा पेंडिंग असतील तर त्याही गोष्टी तुम्ही PCPNDT कमिटीकडे कळवा. आणि शेवटी सर्वात महत्वाचं, मी आता जास्त वेळ घेत नाही, परंतु आम्ही वेळोवेळी हेच सांगतो की आता 20 आठवड्याच्या नंतर जे MTP केल्या जात आहे किंवा जे काही मोबाईल व्हॅन मध्ये जे सेक्स डिटर्मिनेशन केले जात आहे ते नक्कीच रेडिओलॉजिस्ट किंवा गायनेकोलॉजिस्ट आपले ॲलोपॅथी डॉक्टर्स कोणी करत नाहीत. वारंवार आम्ही प्रत्येक जिल्ह्यामध्ये जे काही बोगस डॉक्टर्स असतील किंवा अदरपॅथीचे डॉक्टर्स आहेत जे मोबाईल व्हॅन मध्ये सेक्स डिटर्मिनेशन करतायत किंवा इलिगल MTP करतायत, यांची आम्ही कात्रणं स्वतः स्टेट अप्रोप्रिएट ऑथॉरिटीला देत आहोत. त्यांच्यावर कारवाई करण्यासाठी आम्ही त्यांना वेळोवेळी पत्र देत आहोत. आणि माझं एकच सर्व मेंबर्सला म्हणणं आहे की खरं बघायला गेलं तर काय आहे की आता प्रत्येक डिस्ट्रिक्टला IMA प्रेसिडेंट हे डिस्ट्रिक्ट ऍडवायझरी कमिटीमध्ये आहेत, परंतु ह्या सर्व मंत्रालयामध्ये असेल, मिनिस्टर असेल किंवा स्टेट कमिटीच्या ऍडवायझरी कमिटीच्या लोकांना आपण ज्यावेळेस हे सर्व मांडतो त्यावेळेस आता स्वतः प्रेसिडेंट आहेत, राजाभाऊ आहेत, त्यांना माहिती आहे की आपल्याला नंबर फार महत्वाचा असतो. आपला IMA मेंबर्स जर वाढले आणि आपली IMA लोकल जी पॅरेंट बॉडी आहे ती प्रत्येक डिस्ट्रिक्टची, प्रत्येक गावातली जर आपण स्ट्रेंथन केली तर आपली पॅरेंट बॉडी जी IMA आहे प्रत्येक ठिकाणी गव्हर्नमेंटच्या प्रत्येक कमिटीवर, आज ब्लड बँकची असेल, PCPNDT असेल, प्रत्येक ठिकाणी आपल्या कमिटीमध्ये आपले बाय डिफॉल्ट प्रेसिडेंट हे मेंबर्स आहेत. आता तर कोरोनामध्ये डॉक्टर बोंडवे सरांच्या कष्टाने, त्यांच्या प्रयत्नातनं आपल्या कोरोना कमिटीमध्ये सुद्धा डिस्ट्रिक्टच्या आपले स्वतः बाय डिफॉल्ट एक ऑनररी मेंबर आणि एक डिस्ट्रिक्टचा प्रेसिडेंट सुद्धा त्यामध्ये मेंबर आहेत. त्याच्यामुळे ह्या IMA ला स्ट्रेंथन करण्यासाठी जास्तीत जास्त मेंबर्सनी IMA मेंबर्स व्हावं. तुम्ही स्वतः तरी सर्व IMA मेंबर आहातच, पण बाकीच्या लोकांना IMA मेंबर होण्यास नक्कीच भाग पाडा, कारण शेवटी नंबर काउंट्स. कारण ह्या सर्व इश्यूज मध्ये आता थोड्या वेळापूर्वी हॉस्पिटलच्या संदर्भात ज्वलंत विषयावर सर्वांनी चर्चा केली, पण हे विषय सॉर्ट आउट करत असताना आपल्याला नंबर्स फार गरजेचा असतो. त्याच्यामुळे सर्वात शेवटी मी एकच सांगू इच्छितो की आपण सुशिक्षित आहोत, सुसंस्कृत आहोत, परंतु संघटित होऊन संघर्ष करणं आपण थोडंसं कुठेतरी कमी पडतोय. त्याच्यामुळे जरी आपल्या संघटना वेगवेगळ्या असतील, फॉक्सी असेल, IRA असेल, IMA असेल, परंतु आपली पॅरेंट बॉडी ही IMA आहे. तर IMA ला ह्या सर्व विषयावर एकत्रित होऊन त्यांना सपोर्ट करा. जास्तीत जास्त लोकांनी IMA मेंबर व्हा आणि किमान महत्वाच्या कॉमन मिनिमम प्रोग्रामवर जर आज महाराष्ट्रामध्ये वेगवेगळ्या पक्षाचे, वेगवेगळ्या विचाराचे लोक एकत्र येऊन जर कॉमन मिनिमम प्रोग्रामवर जर काम करत असतील तर आपण सर्व लोकांनी PCPNDT सारख्या अशा ज्वलंत विषयावर, MTP सारख्या ज्वलंत विषयावर एकत्रित येऊन कॉमन मिनिमम प्रोग्रामवर सर्व फॉक्सी असेल, IRA असेल यांनी IMA ला साथ द्यावी आणि आपण सर्व लोकांनी संघटित होऊन आपल्या हॉस्पिटलच्या इश्यू संदर्भात संघर्ष केला पाहिजे अशी मी विनंती करतो. आणि कुठल्याही पद्धतीच्या पेंडिंग केसेस असतील किंवा कुणाची मशीन डिसील करायची राहिली असेल आणि काही अडचणी असेल तर तुम्ही स्टेट प्रेसिडेंटला किंवा पीसीबीडीटी कमिटीला तुम्ही लेखी ईमेल करू शकता. आम्ही आपणास योग्य ती मदत करू. आमच्याकडे मेडिकल लीगल कमिटी आहे, वेगवेगळ्या पद्धतीचे सर्व डॉक्टर्स लॉयर्स आहेत, ते तुम्हाला सर्व पद्धतीचं कायदेशीर मार्गदर्शन देतील, यात मला शंका नाही. धन्यवाद. ऑर्गनायझिंग चेअरमन राजेंद्र कुलकर्णी सरांनी मला आज आपल्याशी संवाद साधण्याची संधी दिली, त्याबद्दल मी आपले मनपूर्वक आभार मानतो. धन्यवाद.
Thank you, Dr. Santosh Kulkarni, sir.
Hello.
उत्कृष्टरित्या आपण नमूद केली आणि त्या माहितीद्वारे डॉक्टर राजेंद्र कुलकर्णी सर टेक ओव्हर.
Yes, sir.
This program.
Thank you.
Thanks all of you, and faculty members, and I rest Rajendra Kulkarni sir. Please, sir.
Thank you. Thank you, Sancheti sir. Thank you, Santosh Kulkarni sir, for the excellent presentation. अतिशय सुंदर ओघवत्या शैलीत मनापासून बोललेलं भाषण सगळ्या आपल्या डेलिगेट्सला नक्की आवडलं आणि भावलं असेल, याबद्दल मला शंका नाही. आणि जे महत्वाचं तुम्ही सांगितलं की जे काही पेंडिंग केसेस असतील सिंपल क्लरिकल मिस्टेक साठी म्हणून झालेल्या, त्याचा डेटा नक्कीच तुमच्यापर्यंत पोहोचेल.
डिसील करायचे
डिसील करायच्या राहिल्या असतील आणि कुठल्याही प्रकारची मदत असेल तर इथे मी सांगू इच्छितो की IMA-Maharashtra-state@gmail.com याच्यावर तुम्ही बोंडवे सरांना म्हणून मेल टाकला आणि पीसीपीएनडीटी कमिटीकडे पाठवा असं सांगितले, तो आपोआप पोहोचेल आणि ती कमिटी सर्व मेंबर्सला अप्रोप्रिएट सहकार्य करेल. बोंडवे सर, आपल्याला काही सांगायचं की समअप करू मी? ओके सर, सो अनम्यूट सर. सर अनम्यूट युअरसेल्फ. सर तुम्ही बोलताय, अनम्यूट करा. तुम्हाला
अनम्यूट करा सर.
अनम्यूट करा आणि बोला सर. तुम्ही बोलताना दिसताय पण ऐकू येत नाहीये. तुम्ही अनम्यूट करा तुम्हाला. बोंडवे सर.
येस, डॉक्टर संतोष कुलकर्णी खूप छान बोललाय. फक्त सुरुवातीला तुम्ही सांगितलं की हे लास्ट लेक्चर आहे, तर हे आजचं लास्ट लेक्चर होतं. वन मोर गुड थिंग अबाउट डॉक्टर संतोष कुलकर्णी, दॅट ही स्पोक इन मराठी. आपण नेहमी असं सांगतो की ज्या वेळेला तुम्हाला खरोखरच काही एक्सप्रेस करायचं असेल त्यावेळेला तुम्ही मराठीत बोलता आणि ज्या वेळेला इम्प्रेस करायचं असेल त्यावेळेला तुम्ही इंग्रजी भाषेत बोलता. थँक्यू डॉक्टर संतोष. थँक्यू डॉक्टर मराठे सर ऑल्सो फॉर गिव्हिंग व्हेरी गुड हे. मला वाटतं की आजचा हे संपूर्ण उद्याही कार्यक्रम आहे याची लोकांना आठवण द्या.
थँक्यू.
बरोबर आहे सर. बोंडवे सर तुम्ही म्हटलं त्याच्यावर मी सांगेल की संतोष कुलकर्णींनी एक्सप्रेस करून इम्प्रेस देखील केला आहे डेलिगेट्सला. स्वतःला एक्सप्रेस केलं आणि डेलिगेट्सला इम्प्रेस केलेला आहे.
येस सर.
So I take this opportunity to call it a day. There was some difficulty for the inauguration ceremony initially in the beginning of the day, but as the ball started rolling, the scientific program went on very smoothly. I hope the delegates have enjoyed it. Atta sudha there are more than 400 delegates which are logged in and actively participating in the conference. This was a wonderful day. I take this opportunity to thank our chief guest of today's inauguration, Dr. Wankhedkar sir, State President Dr. Bondwe sir, guests of honor Dr. Monga sir and Dr. Vinay Agrawal sir, who contributed to our panel discussions as well. All the dignitaries like President-elect Dr. Londe sir, immediate past President Dr. Hozi Kapadia, MMC President Dr. Utture sir, President-elect that is Dr. Suhas Pingle sir, who is the currently Action Committee Chairman, HBI Chairman of Maharashtra, Dr. Mangesh Pate, who has been very helpful in all the organization of this conference. So we are just coming to an end of the first day of the conference. It was very eventful and interesting and enlightening day. I think the participation is very high, and I'm very proud to say that there are more than 2,500 registrations for this conference, which is, I think, as far as my knowledge goes, is the highest number, record number of delegates in this online conference.
Yes.
In COVID historical.
Record number.
Yes,
and
sir.
we are watching your accounts.
Yes, yes, sir. So, all of you, though this is a online web conference, so I missed the opportunity to host a big banquet in Nasik. But you all are welcome in Nasik.
उधर राहिला.
नक्की नक्की. I will be happy to host all of you. Please do come. Please stay on, log in online tomorrow morning at 10 a.m. We have a full interesting series of lectures tomorrow as well on COVID related topic, advances in medicine, and COVID related topics. And one of the important lecture that is going to be delivered by none other than me about past, present, and future of standalone hospitals. So once again, thank you everybody. Thank all the dignitaries, all the speakers, all the delegates, the technical support of DigiShield, and my own Nasik branch president and the entire team of Nasik for their kind help. So I call it a day. Thank you everyone. See you tomorrow morning 10 a.m. And I declare that today's deliberations of the first day of Mahahospicon 2020 are over.